So wish the program all the best.
Thank you, sir. Thank you.
Ashraf, good morning. Good morning.
Morning.
And in video, I'll only listen. Only when that program comes, I want to listen and concentrate.
Thank you, sir. Okay.
ഞാൻ പറഞ്ഞേ ദിയോറയ്ക്ക് മെസ്സേജ് പോയിട്ടുണ്ട് എന്റെ
ഞാൻ ഇടയ്ക്ക് നോക്കാം സാർ. അപ്പം
ലിങ്ക് അയച്ചു കൊടുത്തിട്ടുണ്ട്. ജസ്റ്റ് റെക്കഗ്നൈസ് ഹിം.
Okay.
He was very much interested. നമ്മൾ അങ്ങനെ ചെയ്യണ അറിഞ്ഞപ്പോ വെരി ഹാപ്പി ഹി വാസ്. Vijay, good morning.
Good morning.
Good morning, sir.
Good morning. Good morning, Vijay. Vijay കേൾക്കണില്ല. മ്യൂട്ടാണ്.
Good morning, Amita ma'am.
Good morning, Dr. Sindhu. How are you?
Fine, ma'am.
Good morning, Dr. Gupta.
Good morning. Good morning. How are you?
Was well.
Good.
Just reached Pondicherry in the night.
Okay.
So how are things in California? I heard there are
Everything is fine in California.
Wildfires are going on.
Those are far away from
Far
us.
away.
Those
Okay.
those are mostly almost 400-500 miles away.
Oh,
where
that's good.
they are. Yeah, that's too hot there, and it's a lot of trees and wildfires.
I know.
So how is the situation with
Situation
COVID?
is under control. Now it's at its nadir. We have only 3 patients in the hospital.
Good, good.
Everybody's got discharged, so it's fine. Let's hope we don't have the third wave, a big third wave. Small wave will be there, but not a big one.
I hope not.
Yeah, that's what we're
I think
hoping.
as more people get vaccinated,
Yeah, absolutely. Absolutely.
yeah. So far you can prevent hospitalization and death. That's what it
Yeah,
is.
yeah. Oh, flu-like illness is fine. We are all used to
Right.
flu.
Who minds to get a little flu? That's
Yeah. That's it. So when is your next trip to India then?
I think it will be in December, early December.
Okay.
Yeah, early December. That's the plan, which was my original for the conference.
Yeah.
I'll keep that, even though we moved the conference, but we'll keep
Yeah.
the date. So I'll be there in early part of December.
Absolutely.
Yeah, my wife is there.
Acha.
Yeah, Abba left
Organizing the
last-
wedding. Organizing the
Huh?
wedding.
The
Organizing
wedding
the
is all
wedding.
a fluid.
Okay.
I think it might move. It might move
Yeah.
also to Malta. It's just so difficult.
Absolutely, you can't plan. My nephew's wedding got cancelled. It was end of April. And that was the peak of the second wave. So then
Yeah,
now
it
we
is
had it in a gap of 10 days. We said, let's have it. Whatever, finish it off.
so uncertain. So
Absolutely. My daughter couldn't come from US. She was supposed to come in April. So
Yeah.
that got cancelled.
It's just so difficult. Abba was supposed to go in June, and then
Yeah.
ഒന്നുമില്ല
happened. So
ഗീത അത് പ്ലേ ചെയ്യണം.
Absolutely.
yeah, I think your major problem now is in Kerala and Maharashtra.
Yeah. Kerala is still quite a bit.
Yeah, I
But
don't
they have very
know.
low mortality. That's very good thing about Kerala. Their mortality is very low. Very
Right. Absolutely.
But madam, still we are having more than 15,000 per day.
Yes, but your mortality is very low, no?
Yeah.
That is, at least you're saving lives. That is what is the most important thing in any illness.
Yeah. Yeah, that's what they have to look at it.
Yeah.
You get a little mutant, it is more sticky. So if you are close by, you are not vaccinated. Even you are vaccinated, if you didn't make antibodies, because 10% people don't make antibodies.
Absolutely.
The
So they talk about-
prevalence in our area is less.
Talk about this breakthrough.
National
They are expected,
Yeah, yeah. We had a
Even
lot
in
of people had
clinical-
breakthrough infections.
Even in clinical in trial, the best you did, the 94-95%. So it's still 5% of the people didn't make neutralizing antibodies.
Yeah.
So they are susceptible to get infection. T cell will take care of not getting very sick.
Yeah, yeah. Immune system is still great, whatever said and done. It looks after us very well.
USA is still, the numbers going up
Yeah.
because there is a very sizable portion
Population
who
who
are
doesn't
not
want to get vaccinated.
All the people who have been hospitalized or positive, they are 99% are vaccinated.
But I heard this week they've had a good drive. My daughter was saying that the Republicans have said that you get vaccinated.
Right. I think if Trump goes out and he says that everybody get vaccinated, I think those are all hardcore Trump supporter, go get vaccinated.
Absolutely.
It's so difficult to do a meaningful talk in 15 minutes.
Yeah, I know. I thought it's an art talk, so I just now saw the program. I said, okay. I was telling Rakesh, I said we can have breakfast after that. Then.
Morning, madam.
Good morning, sir.
Yeah, yesterday I was giving a talk on, again, the COVID at an international conference in breast and ovary cancer.
Okay.
And somehow the slides didn't open on their side. And it was a disaster because they were then moving the slide and it couldn't.
That coordination never comes. You never enjoy a lecture, somebody else moving your slides.
Absolutely. And you see, you move it, they didn't move it, so it was so discoordinated.
Very difficult. But overall experience, I think, of Zoom has been very good. Zoom has been the best platform, I think.
Absolutely, absolutely.
Because the government doesn't use Zoom and they use all those funny ones, WebEx and go-to meetings. Those government meetings sometimes are real chaotic. Absolutely.
So how is everything at Lucknow?
Yeah, it's all well. At least the OPDs have opened because OPDs were absolutely shut for months. So we opened in between for 2 months, 3 months actually, Jan, Feb and March. And then again, they were shut down.
Hello? I'm in the webinar. Yeah, of your time. Yeah. Was calling me.
Yeah.
I wrote to her that I'll be in the webinar. I'll call you after 10:30 of your time.
Absolutely. So the registry has taken off. So we'll now get down to adding data into that.
Yeah, that will be so awesome.
Because our center is anyway already there because of the genetics department. So I've spoken to them and we'll use their login and put in there.
And I'm so happy, before Harshvardhan was removed, I got everything done, even in the rare diseases. We got everything completed, so I'm so happy, And
it was very unfortunate to get him off. We just made a scapegoat.
Absolutely. He was doing a good job. Yeah, before he went, he appointed me to Scientific Advisory Board of National Institute of Immunology. So I'm on their advisory board of NII.
They don't have a full-time director as yet.
They don't?
I don't think so, because this person is looking at it now. I think Gokhale.
You see,
Gokhale is holding the charge at present, Rajesh.
Yeah, they got to get somebody who is really translational.
Gupta sir and Amita madam, now I am muting all. Please unmute yourself for the to avoid the background noise. I am muting all. You can unmute and discuss.
Okay.
Yeah. Gupta sir, unmute yourself.
I did.
Yeah.
Okay.
Continue discussion. Okay.
No, because it's already 8:29.
Yeah.
So
we are going to start.
Yeah. Okay, so our conversation is being heard by others. Doesn't matter. It's nothing secret.
Good morning, everyone. The COVID-19 pandemic has literally brought humanity to its knees. The challenges for a pediatrician are of varied complexity.
There's some echo is coming.
Positively the services we provide for sick children and their families. Deliberations will focus on perspectives gleaned from experts on the global scene as well as from local and regional arena. We, the Department of Pediatrics, Government Medical College, Kozhikode, and Indian Academy of Pediatrics, Kozhikode, extend our warm welcome to this academic extravaganza. The first session is on COVID vaccination in children and adolescents, current perspectives and future directives. The speaker for this session is Dr. Sudhir Gupta. This session will be chaired by Dr. Amita Agarwal, Professor and Head, Department of Clinical Immunology and Rheumatology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Dr. Suresh Kumar E.K., Senior Consultant and Head of Department of Pediatrics, Aster MIMS Hospital, Kozhikode. We hand over the session to the chairpersons.
Thank you. Thanks for inviting me to chair this very important session. I think the person who's speaking does not need much introduction. He has visited Kozhikode and has interacted with pediatricians there. But however, for people who don't know him, Professor Sudhir Gupta is Professor of Medicine, Pathology and Lab Medicine at University of California at Irvine. But I think his major contribution has been to get primary immunodeficiency on the map of India. He's been absolutely instrumental in making all the physicians think about PID and dream that PID can be a disease which we can diagnose and treat. And he has put hard work tirelessly to get centers across India. He is a great immunologist. I've known him for 3 decades, and he works on both B cell and T cells. His major area of work in T cell is basically T follicular helper cell, how they regulate B cell development. And he is a product of our own country. He did his graduation and post-graduation at King George Medical College, Lucknow, and then moved abroad to US. And there he's been chair of this department at Irvine, I think, for decades. He's also the founder, president of Primary Immunodeficiency Foundation, which he and his wife have set up, and is also the director of Jeffrey Model Foundation Diagnostic Center for Primary Immunodeficiency. So I would not waste more time and would invite Professor Sudhir Gupta to talk to us on a very important topic of COVID-19 vaccine in children and adolescents. What is the current situation and what do we envisage in future? Over to Dr. Gupta.
Thank you, Amita, for that kind introduction. And I also like to thank Professor Geeta for inviting me. Since there are only 15 minutes, it's difficult to cover the topic like this, but I'll try my best. So as you know, the risk factor for severe cases of COVID are listed in this. There's one I have added at the bottom, which is the genetics. This is one of the issues that is championed by Casanova, involving 41 countries. And at the top, you see the aging there, where we'll come to children and adolescents. So in genetics, what they have done is they have taken almost 50,000 infected people who were severely ill and 2 million control. And they have discovered at least 4 loci with susceptibility, 9 loci with severity. There are about 40 genes they have discovered. 6 of these loci are never described associated with COVID. And as you can see on the right side, the 2 genes which have been associated with severe in children is the TEC2 and DPP9. But let me leave that and go to the age. So here you have, as of January 1, from 78 countries, that means 60% of the world, there are 8,700 children and adolescents who died of COVID. And as you can look at it, there are very few, and all of them are in adults and aged. In the US, death rate in children depending upon the state, varies from 0, that means nothing, to 2.6%. And if you look at the hospitalization, it's 1 to 1.9% of all cases hospitalized in children. And the reason most like, can you hear me? Hello?
Yes, sir.
Dr.
Yes,
Ashraf,
sir.
please mute us. Dr. Ashraf, please mute. I think sound is coming.
So the reason being that ACE2, which is a receptor, is reduced in alveolar epithelial cell in children. The TRPSS2, which is a transmembrane serine protease, which is very important in activation of the spike protein and resulting in the fusion. The less of the cytokine storm, the protective Th2 immunity, and a better antibody, and including neutralizing antibody responses. And here is a very recent study in which they look at less than 3 months of old children and the parents who had the COVID positive. And as you can see here, you have entire anti-spike antibodies much greater in 3 months, less than 3 months old as compared to the parents. You look at the neutralizing antibodies, they are high. And also you look at the interferon, which is less, because the interferon along with TNF induces apoptosis and therefore is much more severe if you have more of gamma interferon. So this will be my outline for presentation, is give you some structure and mechanism of replication of the virus, immune responses, both in children and adult, and then vaccine to give you the platform, the 2 clinical trials so far in children and adolescent, and then I'll spend, that's really the one which I want to focus more, is the future of COVID vaccine, and there might be some concern that I might give with respect to the priority of the COVID-19 vaccine in children. So the virus, the COVID coronavirus, there are 4 categories of coronavirus: alpha, beta, gamma, and delta. It is one of the largest of RNA virus. It's about 29 kilobases. It has about 14 open reading frames. It has 4 structural proteins. It has about 8 accessory proteins. And most of the mutation that you see is in the spike protein and number 8 open reading frame. So you look at the SARS belongs to beta virus family, coronavirus. So it is, and even the delta, so it is the mutation or the variant of the beta virus is not the delta virus. And now there is a lambda also, which is a virus of interest, not of concern yet. So here is the structure for the spike protein. You have the S1 and S2. S1 is the protein that binds to ACE, and S2 is the one which causes the fusion to the membrane so the virus get inside. So here you see the receptor binds, and at that time you see these fusion protein, they come very close to the membrane, and it is a TRP, the serine protease, that activates it and facilitates the fusion. Once the fusion takes place, the RNA comes out, it goes through the entire machinery of all the replicase, because if you see here in this, these ORF1, A and B, they are the one encode for all replicative enzymes, including the RNA-dependent RNA polymerase. And then genomic and subgenomic translation takes place. And as you see, the subgenomic, which is a structured protein in endoplasmic reticulum, and genomic in the Golgi, and they get assembly and that come out of it, and then elicit the immune responses. So if you look at the immune responses, first you have the innate immune response, and they produce these molecules in a right amount. And these dendritic cells then prime the CD4, CD8 cells, the CD8 cells, which will become the cytotoxic T cells, and the B cells, they will produce a specific antibodies against both the spike protein as well as the nucleoproteins. And as you know, I wrote something for Indian newspaper in January and February, and in Nature it was that T cells might be much more important than antibody, and especially when it comes down to mutants or strains are concerned. Because one fundamental thing you should remember, antibody prevent the transmission or infection. T cells clear the infection. Once they get infected, these are the cells. And therefore, the clinical presentation will depend upon how efficient are your killer T cells. So let's look at the vaccine. These are some of the rationale that NIH has put together why one should start the vaccine trial in children. But here is very important concept one should know. In a natural infection, what you see is, because it's going from the nose to upper respiratory tract, so you have the local IgA production, and then you have in lower lung IgG production. When you give the vaccine, you have predominantly a IgG response, very little IgA response, and that also adds to increased susceptibility of catching the infection because you don't have that. And we'll come back to that. These are the various platforms, and I'm not going to go through it. I'll just mention the one which are currently being used. Here is the inactivated vaccine in which you chemically inactivate the whole virus. And you have one in India and another one, CoronaVac. I'll give you some data on that. And here, very important thing is that immune responses would be to all component of the virus, not just the spike protein. As you can imagine, those are the T cells responses. They can still kill the cells no matter what mutation you have. Other is the subunit protein, where you can take the recombinant protein, and this is Novavax, where the spike protein is taken. Here, it is combined with adjuvant. And the reason for the adjuvant is because when you take the subprotein versus the vector-induced or nucleic acid, they can be easily presented by an antigen-presenting cell, where the proteins of these are not that efficient, and therefore you require adjuvant. And then you have a replicating or incompetent recombinant vectors in which you insert the gene, the DNA. And so what you have here is an adenovector, which is AstraZeneca one. Here is the chimpanzee adenovector, while the classical vectors are in that Sputnik and J&J. And again, if time permits, I'll tell you the advantage and disadvantage of those. And then you have the nucleic acid platform where messenger RNA, and that's Pfizer and Moderna, that is delivered through the nanolipid particle. So here is, and I'll just summarize because of the time constraint, and skip the following slides, which have the data. It is the safety and immunogenicity of. This is a CoronaVac. This is a just like your COVAX or whatever you have in India. This is the inactivated virus. This is a double-blind randomized controlled phase 1/2 study. And what the results are that the vaccine was very well tolerated, safe, and induced a strong antibody response. And when they have the two doses, 1.5 microgram and 3 microgram, they have the higher response in the 3 microgram, and 3 microgram with 2 immunization schedule will be the one which is further studied. And I won't go through because otherwise it will take too much time of the design of their studies. But what you see is they have the data are 3 to 17 years, and then they have de-escalated to 3 to 5 years. 6 to 11 years and 12 to 17 years. In all of them, as you see in phase 2, the levels of the antibodies are much more than phase 1 in each of these groups. And if you look here, let me just leave this. And here, again, they have looked at what I have told you. If you look at the grade 1, these are side effects. Side effects, the grade of the side effects are very similar, whether you use the aluminum hydroxide they use along with it versus the vaccine. This is the second one. This is the one which is used here. This is a Pfizer Biotech vaccine. This was multi-center. This was a huge studies of 2,200 or plus adolescent. So previous one was children, different age plus adolescent. So that was the advantage. Here it is just the adolescent, and they were divided half into getting placebo as a saline and the vaccine. And what the result was that safety and side effect profile, they had mild to moderate adverse effect, which are common to most of the vaccine, the side pain, fatigue, and headache, and the geometric mean of 50% neutralization titer. And when they compare 12 to 15 years versus 16 to 25 years, 12 to 15 years made 1.76 times greater response than the older one. And again, in vaccine group, they were culturing throughout whether the patient contracted the COVID. In the vaccine group, there was 0, whereas 16 in the placebo group. So it was effective. So let me just skip those. Okay, now what Pfizer is doing it, they are doing the studies just like I showed you the first study with inactivated virus with their vaccine. Now they are looking at de-escalating the age group, and they are doing the study from 6 months to 4 years and 5 years to 11 years.
Me,
and
sir,
what is
running out of time. Thank you.
Okay. I'm out of town. The best thing was to come. Okay. If you don't want, yeah, that's okay.
Sir, we will continue, sir, for some more time. We'll
Okay.
finish off,
This is very important, the future of the vaccine. What you need to alternate here, as I told you, that the intramuscular vaccine will only give you the systemic response. If you give intranasal, you'll get IgA response as well as the IgG response. And here you see on the left side is intranasal, right side intramuscular. You also produce, in addition to IgA, the IgA neutralizes the virus as well as recruit memory and plasma cells, and therefore will give you much better response. And let me give you the very important thing as that what will happen in future, there will be nanotechnology that will be used for the diagnosis, for the vaccine delivery and therapy, gene editing of SARS-2 using the CRISPR-Cas system to simultaneously, because you can target number of viral genome, and this has already started it. Therefore, you can completely destroy the viral genome RNA. There are 22 CRISPR RNA to target different RNA-dependent RNA polymerase, as well as nucleocapsid antigen. And therefore, if somebody is infected, you can very completely remove it. Lastly, I would say COVID-19 will be with us for some time. Vaccine would not protect us completely for contracting emerging mutant strain. Therefore, we would need the effective, safe, and orally administered drug, just like we give the Tamiflu and the flu, targeting replication machinery. And there will be at least one from Merck, which is siRNA, a small interfering RNA that will be an oral pill that should be available by October. And then we should have 3 more by next spring. My concern for the priority is because, and this is at the level of the government and the local authority, since the severity in the children is very similar to influenza, they may not give it priority to vaccinate these children. And since again, in case of in Norway, they have kept the school open, everything without immunization, and they still have very low risk, their group. So that's my concern, is that the health authority and the government may not give the priority for childhood vaccine. So thank you very much giving me extra 3-4 minutes.
Thank you, Dr. Gupta. You've nicely summarized what we have at present, that we have some vaccines which are being tested in children, and what we look for in future, probably the intranasal vaccine, which will be easy to administer without injection for children, and the priorities which the government needs to have. So I pass on to Dr. Suresh for handling the question answer session.
Thank you, madam. And it was an excellent presentation by Dr. Sudhir Gupta. And I think he was actually, it's a very big topic, actually. It takes a lot of time to clarify or mention all the points in childhood and adolescent vaccination regarding the COVID. So if anyone has specific doubts, you can ask now. There are no questions in the chat box at present. So one question now.
One question is there.
One question is there. Just like other vaccines, just 1 second.
I will read it for you.
I'm reading it. I'm reading it. Yeah. One is there a need to vaccinate children at all? Maybe except high-risk kids. Should we be in a hurry? That is the question by Dr. Purushothaman. And another question here. Yes, sir. You can answer that question. And
I very strongly feel that every child should be immunized, because not only because they don't get very much disease, they may be asymptomatic, but they can transmit to their parents who are much, much older. And therefore, I very strongly feel that everybody should be immunized.
Just one more question by Dr. Purushothaman. Just like other vaccines in kids, can't we wait more till it proves safety?
Say it again.
Just like other vaccines in kids, can't we wait more till it proves safety? So do we need to wait till it proves safe for children? Yeah, that's what.
Age for vaccination, you are saying?
No,
yeah,
so they are asking about safety.
Group,
so they're asking that should we wait for more safety data in children?
Yeah, you see, we definitely need, and that's what they are doing. Both Moderna and Pfizer will have a lot of data within the next 4 to 5 months. So before the year ends, and it might be up to November, that will have the data as low as 6 months of age.
Yes, sir. There is one more question. What about a booster dose for high-risk individuals like health workers?
Yeah, that's very interesting question. And I think, and that I had yesterday when I was giving in the cancer conference, that people who are immunocompromised for any reason, whether they are born with immune deficiency, whether they are cancer patient getting chemotherapy, or you have a transplant patient, that is one of the group has to be very seriously considered for booster dose. It is not yet here because for regular people, that is not needed at the moment, because so far the data shows it has a quite durable immunity, especially of the T cells, because that's what would determine the clinical outcome of these infections. Because as you know, in Singapore, they have done the study of, and they found 5 different patterns of antibody if they followed for 9 months. So there will be some people, the antibody will disappear within 6 months. So they will be a little more susceptible to infection, but their T cell will keep them pretty asymptomatic or mildly. So the booster answer to the question to the booster is, I think those special group would be the one, not anybody else at this moment.
So one more question. Is there any update or data regarding vaccination trial in children in India? Do we have any information?
That you guys know. So I think you have a lot of session there, so they will be able to answer.
Now, the government is not licensed as yet for vaccination in children. So that is why we have no data.
Yeah. And you see, and I have, that's why I put that last slide, children for underdeveloped and developing countries may not be a priority for vaccination, and they will make all the case that, okay, it is as, common as flu is, the deaths are same way, so I'm worried about that.
It's running short of time. I think we will stop chat box questions.
Yeah, you can send me by email and then I can answer those.
That's good, sir. Madam, anything you want to add?
No, thanks a lot. Thank you.
Thank you all. Thank you, sir, for your excellent presentation, and over to the organizers.
Thank you. Thank you for giving me those 3 extra minutes.
Thank you, sir. That was a really informative session. Moving on to our next session, which is on COVID-19 infection in children on a global, national, and regional perspective. Please note that this will be a pre-recorded session. The first session. We have 3 eminent speakers to execute the session: Dr. Antonio Condino Neto, Dr. Tanu Singhal, and Dr. Santosh Kumar. The chairpersons for this session are Dr. Arvind R., who is the head of Department of Infectious Disease, Government Medical College, Trivandrum. He is also an infectious disease consultant at Sri Chitra Tirunal Institute for Medical Sciences and Technology and Regional Cancer Center, Trivandrum. The co-chairperson for this session is Dr. T.P. Jayaraman, who is currently working as a pediatrician at the District Early Intervention Center, Government Women and Children Hospital, Palakkad. He is also the current President Kerala IAP. Kindly requesting the chairpersons to take over the session.
Good morning. First of all, I thank the organizers for giving this opportunity. I am Dr. Jayaraman. COVID-19, as you all know, is a new disease, and it is a dynamic disease where our understanding is on the change. What we were thinking in the initial phases has changed regarding the epidemiology, management, every aspect of COVID-19 disease. And I think it is very apt to have a presentation on the epidemiology in the COVID conference to start with. And as you all know, the presentation as well as the severity, everything is different from different ethnic groups. And in children also, it is more common in certain groups, even though it's a relatively mild disease. And it is so apt that you have started the presentation with Professor of Immunology from Brazil, Dr. Codino, because pediatric COVID as such, you all know, is more common in South American children compared to other children in the Hispanic group. And Brazil had a very severe form of COVID, and you have got a very apt person to discuss the epidemiology of COVID from a global perspective in pediatric COVID. And to introduce Dr. Codino, he is a professor of immunology and allergy in Sao Paulo, Brazil. And I present the podium to Dr. Codino. Thank you.
Receptor has an expression body, the lungs, heart, cells, kidneys, intestines. Once the virus penetrates the cells of the ACE2 receptor, the virus triggers its cytokines, and this will bring the cells to the antiviral state. And once the cells appear, just an example of cells in our respiratory tract, and once it reaches the antiviral state, those cells will also release other cytokines that recruit myeloid cells to the infected tissue. And this, although it's part of the defense, may eventually trigger the so-called cytokine storm, which is an excessive inflammation that will eventually impair our breathing, our respiration. So the clinical picture of COVID-19 includes mostly of the cases will be mild to moderate, severe in 14% of cases, and critical in 5%. So in patients with the critical form, severe form of COVID, they will show up with neurological disorders, hyperinflammation, acute respiratory distress syndrome, cardiac dysfunction, hypermobility, acute kidney injury, and the so-called multisystem inflammatory syndrome in children, which I will not bring many details at this time because I am aware that one of you will have a specific conference on that. The point I would like to bring is that a minority of patients, otherwise healthy, generally young or even children, they will be asymptomatic, and once they get the coronavirus infection, they may, a minority of the cases may evolve with a very severe form of the disease. So for us immunologists, we looked at one virus, one coronavirus with some genetic variation, but a so diverse clinical picture, diverse phenotypes, especially in young and children otherwise asymptomatic and healthy, and they suddenly develop a very severe form of the disease. So we cast the question, is that possible that there is a genetic susceptibility in those children, in those youngsters? Previously, we know several viral diseases that will present with genetic susceptibility. For example, influenza virus, severe pneumonia, toll-like receptors, and IRF transcription proteins, transcriptional factors may be involved in that kind of immunopathology. Herpes simplex and encephalitis in children, there is a genetic susceptibility. Beta papillomavirus virus, Epstein-Barr virus, varicella zoster virus, cytomegalovirus. So many of those diseases, we already know that there is a genetic susceptibility. So this motivated an international group of immunologists to make up an international consortium, the COVID Human Genetic Effort, and we started to cooperate worldwide in order to study the genetics of those young adolescents and children, otherwise asymptomatic, that developed unexpected severe COVID. Here are some of the results that were published in September last year. If you look here, IRF7, IRF3, TBK1, toll-like 3, and receptors for interferon gamma. So there are genetic variations which we can strongly associate with very severe course of the disease. In other words, there is a genetic susceptibility in those otherwise asymptomatic children and adolescents to develop severe COVID. Many of those observations were described here in adult patients, but the research kept going, and we currently have the data of children that will show up with similar results. Look that most of the patients will have an autosomal dominant pattern, which also explains why those patients can be so easily affected. So this is the publication in Science, and we next investigated cases that will behave like phenotypes. So we already know that patients with autoantibodies against interferon gamma may develop mycobacterial diseases. Patients with autoantibodies against IL-17 may develop cutaneous candidiasis, and patients with anti-IL-6 autoantibodies may develop staphylococcal disease or even sepsis. So we questioned if those patients could develop autoantibodies against some cytokines that will make them susceptible to coronavirus infection. Indeed, we identified a group of patients that developed autoantibodies against type 1 interferons, mainly interferon alpha, anti-interferon alpha. Some of them a little bit against interferon beta or kappa or epsilon. But the fact is that autoimmunity and autoantibodies against interferons, type 1 interferons, is part of the immunopathology and susceptibility to this disease, and may also explain why those patients will develop a so severe form, very difficult to manage. So in summary, what this research has shown is that a minority of patients will present with susceptibility, genetic susceptibility to infection, or even develop autoantibodies against type 1 interferons. At this point, this consortium has evolved, and we have additional data that was is already accepted for publication, and very soon you will find out additional mutation analysis studies and autoantibodies studies. And we can say that for certain ages, at least 20% of the cases with the severe form of COVID do present those kind of autoantibodies. So this was the paper published in Science last year. I would like to briefly show some of the observations about COVID in patients with important errors of immunity, which includes children and adults. We would like to give emphasis that 30% of those patients have a mild coronavirus disease. And however, some of them eventually lost. In this graph, it shows that most of the cases were antibody deficiencies, and the others are combined deficiencies, and we had some mortality in the groups. For this work developed in Brazil with 121 patients, providing children and adolescents, I would like to stress that the main observation is that the risk for death is times three times more in this population group who has immunodeficiencies. This is the clinical picture. Fortunately, 55% have mild disease, but anyway, the risk is higher for those patients. I would like also to show, as the Pfizer vaccine became recently approved for immunizing adolescents over 12 years of age, in the group of primary immunodeficiency patients, 19 over 26 patients responded somehow to this vaccine, and we should strongly encourage our primary immunodeficient patients and adolescents to receive that kind of immunization, because most of them will produce some kind of neutralizing antibodies against the anti-S protein for the Pfizer vaccine, and as well they will produce cellular immunity, giving protection to our primary immunodeficient patients. So this is the first study performed with primary immunodeficient patients, and it's a clear evidence that we should encourage our patients to get the vaccine. For the future, considering the autoantibody scenario, we are proposing a clinical trial to treat critical forms of COVID with the beta and the interferon. It's part of the not have patients, the critical cases do not develop any antibodies against interferon beta, so perhaps we can rescue a group of critical patients, and we are planning to pursue with a clinical trial on that. I would like to thank your attention. Please let me know if you have questions, and I will be very happy to send you my comments. So thank you very much, and hope to talk to you in the future. Thank you very much.
Thank you. Since it was a recorded session, we cannot have question and answers. I think we'll go to the next session. Over to Dr. Aravind.
Good morning. I'm Dr. Aravind. I would like to thank Ajit Kumar sir as well as Geeta madam for giving me this opportunity to chair this session. So in the first speaker, Professor Antonio Contino actually mentioned about the immunopathogenesis of severe and critical COVID-19 in children, especially the type 1 interferonopathy, whether it is due to inborn errors in interferon pathway or due to the neutralizing autoantibodies against interferons. It did also take us through the pathogenesis of the COVID-19 in children with the immune deficiency disorders and the safety of the Pfizer vaccine. From actually the financial center of Brazil, Sao Paulo, one of the most populous cities in the world, we'd like to take you to Mumbai, the financial center of India, as well as one of the most populous cities in the world. And the second session will be dealt with a very eminent speaker and academician, Dr. Tanu Singhal. She trained in pediatrics from All India Institute of Medical Sciences, and then got further trained in infectious disease from the London School of Tropical Medicine and Hygiene. She is a national level as well as an international level speaker, and she has been involved with COVID-19. So many publications in COVID-19 is there to her credit. So I would like to welcome Dr. Tanu to take us through the India experience with regard to the SARS-CoV-2 infections in the pediatrics and the lessons to learn from the India experience. Over to you, Dr. Tanu Singhal.
Yes. Okay, you can see me. Okay. So thank you, Dr. Arvind, for that kind introduction. And so we are going to move from a very, very basic science lecture to a rather kind of epidemiologically lecture. Can you see my screen?
It's visible. It's visible.
Okay. So I'm going to talk about the condition in our country. And before I go to that, I just want to say that globally so far, the only silver lining in the epidemic has been less affection of children. So all through the world, throughout the world, we've seen that the COVID-19 infection in children is milder and it does not cause a lot of fatalities. And this is the same experience that we have from India as well. Now, before we move on to the childhood burden, let's talk a little bit about the disease burden in India. And as you know, we had these two waves during the past 1.5 years. And the second wave was one of the most devastating, where we reached a peak of 400,000 cases per day. And even now we are about at 40,000 cases per day. And I think Kerala is also one of the states which is really reeling under the second wave still. And this was also paralleled by an increased number of deaths, which in the first wave was reached a peak of 1,000 deaths a day. And now in the second wave was 4,000 deaths a day. So the second wave was just 4 times the size of the first wave. And it is believed that we've had about 31 million cases and 400,000 deaths. But whether these are the real numbers, nobody knows, because current estimates place that for every 1 case that is reported, there have been 30 cases which have gone unreported. So we've had maybe about 900 million cases already in the country. And this actually also corresponds with the serosurveillance data, which shows that 67.5% of the country's population has been infected with COVID-19. And in fact, there was a recent publication which placed the number of deaths in India as about 4 million, which is 10 times that of the reported number. So I think the true number is somewhere between 400,000 to 4 million. But when we look at pediatric COVID infection in India, we really don't have much published data even from the government. So what I could really find is one tweet from the Ministry of Health and Family Welfare, which showed the age bifurcation of cases in the first and second wave. And it's surprising to see that both the first and second wave had almost a similar age distribution. And in both the waves, children actually contributed to about 12% of the total number of infections, while they contribute to 37% of the total population in India. And when you compare this with the global data, there also children contribute to 12% of the cases, while they make up 25% of the population. So does it mean that children have been less infected than adults? And in fact, there are some studies which talk about the transmission risk to children being half of that of adults. So that means children, despite being exposed to COVID-19, don't get infected because of, the immaturity of their ACE receptors, innate immunity, etc. But when you actually look at the seroprevalence surveys, they don't tell us that children have been less affected. And in fact, the most recent survey in 28,000 people from 70 districts and 21 states was just published a week ago. And this survey is as recent as June to July 21, where when you look at the percentage seroprevalence in children between the ages of 6 to 9 years, it was 57%, and 10 to 17 years, it was 62%, as compared to a prevalence in people above 18 years at 74%. So that gives us an overall prevalence of 68%. So the prevalence of antibodies in children is not significantly different from adults, which tells us that, yes, children have also been infected. And in fact, while this sero survey does not talk about younger children below 5 years, we had another small study which was done in 4,500 people in 4 areas between March to June 2021, in which there were 700 children, where they found that the affection of children between the ages of 2 to 5 years was also 42%. So that means that the lesser contribution of children to the case burden in India is probably due to lower testing. And that is really true because children tend to be less symptomatic or they're asymptomatic. And if there are multiple family members who are infected and the child also has mild symptoms, the child is not tested and is assumed to be COVID positive. And sometimes we've also found that there is reluctance of parents to test children. And this is kind of a personal observation, which I found that when you tell parents that the child could be having COVID and we'll test the child, they would prefer to wait, as if they have this kind of escapist mentality that they rather not test the child because they're really worried about the disease in children, though you keep telling them that disease in children is mild. Now, moving from infection, let us look at COVID-19 disease in hospitalized children. Now, what percentage of children need hospitalization? That data is not available from India, but it is believed to be very low. So there were two relatively large publications in this area. One was actually a media publication from the Lancet India Commission COVID-19 Task Force, which reported the outcomes of 2,600 hospitalized children at 10 centers across India during the first wave between March to November 2020 and then later too. And what they found is that 95% of these children were asymptomatic or mild illness. And you would wonder why these children are in hospital. So the reason why these children were in hospital was because their parents were admitted or they were admitted for isolation precautions. So therefore, when you look at data of hospitalized children with COVID, it does not indicate the spectrum of severe disease. Because in this 2,600 children, only 9% had moderate to severe illness. That means only about 260 children, and the death rate was 2.4%, and 44% who died had comorbidities. And in fact, this was one of the main studies which showed that the findings were similar across the two waves, and therefore the spectrum of the severity of the disease in children did not change in the second wave as compared to the first wave. There's another recent publication which looks at 402 hospitalized children from 5 sites in 5 different regions of India, and it does not include MISC. And here again, of all the hospitalized children, moderate to severe disease was present in only 10% and deaths were in 3%. And all patients who died had a comorbidity. So if we kind of extrapolate this, we know that maybe less than 5% of all children who have COVID need hospitalization, and among those that are hospitalized, the case fatality rate is maybe less than 2 to 3%. So the actual death rate in children is very, very low. Now, coming to COVID-19 related deaths in children, we know that globally children contribute to 0.3% of COVID-19 deaths, and that is data from the UNICEF. And actually, the case fatality rates in children are less than 0.1%. And this is really remarkable, because in adults, you are looking at case fatality rates between 2 to 5%. So we know that there have been 400,000 deaths in India due to COVID-19. But what percentage of these have been in children? That data is not available for the country. But we have data for Mumbai, and where we've had a good reporting system with the Mumbai Municipal Corporation, and we've had about 7.5 lakh cases since the epidemic started, with about 15,000 deaths. So the overall case fatality rate was 2%, whereas there were only 59 deaths in children amongst a total population of 46,000 cases. So the case fatality rate was 0.1%, and the contribution of children towards all deaths was 0.3%. So this data from Mumbai is actually very similar to data which has been reported globally. So we know that deaths in children due to COVID are very rare, and most of them happen in children with comorbidities. The other big question in the minds of people is that what about children being preferentially affected in the third wave in India? And this is unlikely, because affection of children, even with variants, is mild, because one would think that the original virus did not affect children. But what if there's a mutant virus, but even with the Delta variant or Alpha variant, etc., the disease has been mild. And childhood disease in second wave was similar to the first wave. And we also know from the national seroprevalence surveys that the degree of natural immunity in children is same as adults. So even looking or allowing for the fact that children will not be vaccinated by the time the third wave comes, we know that they will be largely protected. But still, we should prepare and we should build infrastructure, because whatever we build now will help us with future pandemics from other pathogens. So that was about the direct effects of COVID-19 in children, and that makes people to think that, there's not a major problem as far as children is concerned. But then if you look at the indirect effects, it's an eye-opener. And I think the most important is this recent modeling study, which was published in the Lancet, which looked at the estimates of children affected by COVID-19 associated orphanhood and deaths of caregivers. And the study modeled that about 1 million children all across the world have actually either lost one of their parents or one of their custodial grandparents or one of their co-residing grandparents. And Indian children contribute to about 10% of this burden. That means about 100,000 children have been indirectly affected by the pandemic because of loss of parents or grandparents. And the National Commission for Protection of Child Rights estimated that 30% or reported that 30,000 children have lost a parent during the pandemic, and there have been children who have lost both their parents. And this has been particularly seen in the second wave, which affected young adults. As compared to the first wave, where most of the deaths were seen in the elderly population. The other impact or indirect impact in children has been a major backsliding on childhood vaccination. So globally, it is estimated that 23 million children missed out their vaccines in 2020 and more than what was in 2019 because of the COVID pandemic. And in India also, it is estimated that about 1.5 million extra children missed their first dose of DTP, and the DTP3 coverage fell from 91% to 85%. Measles coverage fell too, and the performance of the pulse polio program was also affected. And this is in the backdrop of a surge of CVD-BV and wild poliovirus cases in our neighboring Pakistan and Afghanistan. So, while we're talking about COVID vaccination in children, we must not forget that children are not receiving their basic vaccines due to the COVID pandemic. And there is a big learning crisis in the offing because India was one of the first countries to close its schools on 16th March 2020. And the schools have largely remained closed since then, unlike other countries where schools have opened when the number of cases came down and studies moved to the online platform. But we must remember that a large section of our population is challenged as far as access to online learning is concerned. Surveys have shown that smartphones are there only in 50% of the population, and many parents lack the know-how to access digital online or online learning services. The number of laptops per children is abysmally low at 0.8%, and even teachers do not have digital literacy. And this impact on learning crisis will result in more school dropouts, especially girls. So both the well-resourced families and poorly resourced families have been hit by the learning crisis. And there's so many other indirect effects which we must not forget, and which I also came across when I was preparing for this lecture, that actually COVID-19 has resulted in an increase in child marriages because families which are hit by poverty due to COVID-19 would rather marry off their girl child so as to avoid the financial burden. Domestic and other crimes have increased. There have been increase in the number of calls to the childline services. There are reports of cyberbullying of children. There is an increase in domestic workload because, even families report that, in one survey, 42% of older children and adolescents reported increase in workload more in girls as compared to boys. There has been a drop in menstrual hygiene due to lack of access to sanitary pads, undernutrition, lack of physical activity, increase in screen time, and obesity, the exact burden of which is not known. And we don't commonly think about it, but there has been increase in the child labor also because of the COVID-19 pandemic. India already has 10 million child laborers, and because of the COVID pandemic, an increase in poverty, dropout from school, many parents are pushing their children for child labor. And of course, there are various surveys which have looked at the prevalence of this problem. And I think we have a separate section on the mental health issues, but I think that is one of the most dramatic effects of COVID-19 on children. And there are multiple reasons for this effect on mental health, like isolation or quarantine, no schooling, excessive screen time, no socializing, loss of a family member, abuse, poverty, etc. And while we don't have large studies which have looked at the impact of COVID-19 on mental health in children, there is one study from AIMS, which was a systematic review of behavioral problems in children globally, and it found that maybe 22% had fear of COVID-19 and 30 to 40% of the children exhibited anxiety, depression, etc. And these effects on mental health will be seen for decades to come. So I think that I would like to stop here and summarize my talk saying that India has been one of the worst affected nations with COVID-19. Infection rates in children actually parallel those of adults, but pediatric disease has been mild and in line with global experience. And since I deal with both adult and pediatric COVID, I can, while I've seen so many cases of severe adult COVID where we've not been able to do anything, the severe cases in pediatric COVID have been very few. I have not really talked about MISC and neonatal COVID because we have lectures there and we look at that impact as well. But finally, the indirect effect far outshadow the direct effects in children. And that is the important message which I want to give. And therefore, even the government or as pediatricians, we need to have a more holistic approach to this problem of pediatric COVID because it's as much of a social problem as a medical one. Thank you so much.
And thank you, Dr. Tanu, for the lucid and brilliant lecture as usual. And thank you for taking us through the Susan Hill's modeling paper on Lancet. Actually, in that article, they did describe the indirect effects of this COVID in children as a pandemic within a pandemic. You told that the case fatality rate in Mumbai Municipal Corporation is 0.1%. No, what percentage is actually contributed by MISC?
No, actually, there is no, we don't know about whether these cases were acute COVID or they were MISC. So we don't have that information. We just have information on their website that 59 children have died since the pandemic started due to a COVID-related diagnosis. So we don't have how much could be the burden of MISC. But yes, some of these patients could be MISC as well.
Yes, well, in your because you have been catering to a large lot of kids in Kozhikode hospital, right? So in your hospital, what is the mortality among kids?
So actually, we've not had a lot of admissions due to acute pediatric COVID. And we just lost one child who was a neonate who was operated for congenital heart disease and then developed COVID. And amongst our cases of MISC, we didn't have a single death so far. So, you know, whereas we must have lost about 20% of our adult admissions due to COVID. So you can really see the difference, you know, in the same hospital as far as between pediatric and adult COVID.
Definitely, that 20% will also indirectly affect the kids.
Yes.
That paper they did describe like this HIV or Ebola devastated rainbow kids like that. So in future we'll be having the kids without parents, right? And we had one question in chat that is, given the fact that the disease is mild in children, why are we closing down schools, causing much more indirect long-term effects?
Yes, so I think there are multiple reasons for that. And one of the biggest concerns amongst them is that these children would probably get infected and then they would transmit the infection to their family members. And that is the fear which is in the minds of the authorities, which has triggered this. And also, if you look at surveys, parents are also not willing to send their children in the school. So, I mean, you know, to school, even if they were to open. So I think a lot of it is driven by, you know, emotion and fear rather than true science. And what we did see also in UK, etc., is that the second wave was also, you know, kind of fired by children getting infected when they were in school because we know that the variants are more likely to cause children as compared, unlike the original virus, because, you know, you need lesser load of the virus and lesser virus binding to the ACE receptors to cause infection. So that is a difference between the variants and the original virus, that while the spectrum of disease or severity of disease is not more, but the affection of children or the transmission to children is increased with the variant viruses. And, you know, the other reason is that this is a kind of place where it is very easy to enforce a lockdown. They can't enforce a lockdown in workplaces, etc., because, you know, that will impact the economy. But this is lower down on the priority list of the government also because they'd rather not think about it. So I think it is time where we start thinking about opening of schools, because even if we were to open for a couple of months and then shut it down when the third wave starts, at least children will get some breather and they will get to meet other children, and we may have some fewer mental health issues to deal with.
Another question in the same line is, if you are considering a staggered opening of schools, which age group will you prefer? Means the preference for age group for school reopening in a staggered fashion.
Yeah, so I think it would be the older children first, because especially for 2 or 3 reasons, because one, they are more likely to adhere to precautions, including masking. And second, because some of them are in classes like 9th, 10th, 11th, 12th, where they do need to go to school and do practicals, etc., and have some time. And what probably they're thinking is of a hybrid model where they would come to school maybe 2 to 3 times a week in batches for 2 hours, just for that physical touch. And then maybe we would move down to smaller children.
Thank you, Dr. Tanu, for the eye-opening lecture regarding the indirect effects of COVID. We would like to thank you for taking your time from your busy schedule. And I would like to hand over to my co-chairperson for leading us on to the third talk.
Thank you.
Thank you for that excellent lecture where you have stressed more on the indirect effects of COVID. And from the global perspective, Indian perspective, now we are coming down to Kerala situation. And as you know, even in Kerala, the epidemiology is very important, I believe, because there is a lot of difference between different regions of Kerala, especially regarding the incidence of MISC and other things. And we have one of the best speakers in Kerala to deal with this topic, Dr. Santosh Kumar, who had been the HOD of Pediatrics, Trivandrum Medical College, who is right from the beginning of this outbreak. He is closely associated with the governmental agencies in deciding the policy matters and studying this issue of COVID. I request Santosh to take over the session. Thank you so much.
Thank you, Dr. Jayaraman. And good morning to all. I thank the organizers for giving me this opportunity. And I'll discuss some of the data that is available to me, and then briefly touch upon the government preparedness for the spike, if at all it is to come. Okay, this slide shows that as the age band gets older, your chance of getting infection is more frequent, which means cases are more as age band goes older to the older age group. So if you assume the same exposure, of course, there is a confounder. The older child may be going out and getting infection from somewhere else, but keeping it apart, if we assume the same exposure, then the susceptibility is more as the age increases, and the older children are more susceptible to symptomatic infection. And when you look at the last column, the number of cases actually decreased, and from April onwards, there is a very abrupt increase in number of cases, and peaked in May, and now it is on the downhill course. But the downhill curve is quite slow. Now, regarding this table, 16.6% is the contribution by below 19 age group, which means of the total of about 31 lakh plus cases in Kerala, 16.4% works out to be 5 lakhs. So 5 lakhs children under 19 got affected so far. So the proportion of children affected has increased in the second wave, as you can see in the last column. It is progressively increasing as the second wave progresses. And this is the split up of deaths. You can see the number of deaths in the second wave in 4 months is actually more than the number of deaths in full 1 year in the first wave. So the number is not very huge or something, but actually there is an increase. And this is the age-wise proportion of deaths. So what does this 0.2 means? Out of 100, 0.2 will die out of 100 COVID patient deaths. Or out of 1,000 COVID deaths, 2 children are dead, which means 998 are adults who are dying. So that is the difference between the chance of death between a child and an adult. In the second wave in the 4 months, we have had more child deaths than 1 full year that I discussed in the previous slide. But when we take the proportion of deaths, it's the same, or if at all, it is less. So increasing the number of the death is possibly due to the absolute increase in number of cases rather than any increase in virulence of the virus. But obviously, it is more transmissible, and that's why a lot more of cases in the second wave. And this another way to look at it is the case fatality rate, where in the other slide, we actually determine how many children out of total COVID deaths were children. But here, what we are looking at is out of 100 children who have had COVID, how many are likely to die? It is 0.006, very meager, which translates itself into if 1 lakh children are affected, then 6 are likely to die. Now, regarding some discussion on susceptibility of children in Kerala. The population of Kerala is 3.5 crore plus, and under 19 population is 25%, something like developed countries. In India, it is 35 plus. So it turns out to be about 90 lakhs, and 5 lakhs are already infected, as we have seen in the previous slide. So Kerala children are unlikely to have an extra familial exposure because they are sort of cocooned. And assuming 2 children per house, and assuming that the one child gave the infection to the other also, so maybe 10 lakhs got infection and possibly became immune by now, and no vaccine in this age group. So 80 lakhs out of 90 lakhs of children are still susceptible if we go by this calculation. So what does Sero survey say, whether it is ICM or AIMS? Government of Kerala had a Sero surveillance in February, but after the second wave, we are yet to start. Now, will the third wave affect children preferentially? This concept is basically because children are not vaccinated, but the other age groups are progressively getting vaccine protected. And children are cocooned, so they are naive to the infections or more likely to get infected. And vast majority is susceptible as per my previous slide. And lastly, the school may reopen. And ICMR recommendation is to start opening school in 1 to 5 class. So basically, because possibly they're thinking older children are more infected, which is true in Kerala scenario also, as I have shown this slide. Assuming the same exposure, equal number of young children also must have got infected, but possibly remain asymptomatic. That is more likely. In that case, asymptomatic also can cause MIS-C. So asymptomatic infection can cause MIS-C to the tune of, say, 1 in 2,000 or so. So the Kerala school opening policy, the current policy is possibly better to open school for the older age group and wait for the opening shall wait for the younger age group. And whether what does Sero survey say? Again, Sero survey, we do not have much information on child particularly. And in this, the test positivity rate, you can just forget the symptomatic, because symptomatic anyway are likely to be more positive. But asymptomatic, look at the asymptomatic. See, in asymptomatic also, test positivity rate is around 20 in less than 10, which is actually very high. And this is another week statistics. We have weekly statistics. Again, here also you see it is hovering around 20, which is pretty high. And this is the graph from ICMR. This is not really child. This is basically adult and child together. So from December onwards, there is a gradual increase, not really gradual, an abrupt increase in antibody. So it is like in India, it is 2/3 of population, that is 67%. And Kerala is maybe some 20 points less, but still it is quite high. And regarding ICMR 0 survey, okay, this is the graph that I've shown in the previous slide. And the district that are surveyed is given in the bottom. There also, it is not child, it is total population. And the Indian statistics disaggregated shows that the childhood population is almost as seropositive as adult. So we can possibly assume the same in Kerala. And because the trend of seroprevalence over a period of time has been a steep increase both in Kerala and India. And whether it is contributed, because the table contains adults also, whether it is contributed by vaccine. Even in unvaccinated, the seroprevalence is above 60. So it is not exactly because of vaccine, although in vaccinated group, the seroprevalence is higher. Now, just a look at what Kerala has done as a preparation for handling any spike. As we know, in child, we are not really worried about COVID pneumonia. We are worried about MIS-C, which can be which can follow even mild or even asymptomatic infection. And it is a treatable condition, and the early detection is the most important point. So what we have planned is we will keep a line list of infected children with JPHN, and she is supposed to follow after recovery for a few weeks over telephone, so that MIS-C can be picked up early and treated early. And regarding the management part, even if it is category A, child, this is regarding child, even if it is category A, if they need admission, they will be in Taluk Hospital. And the reason is, in Taluk Hospital, there is always a pediatrician once a day for rounds, and that is ensured. And any category B will go into a hospital where there is a HDU. What HDU I'll come to. And category C can be moderate or severe. Any category C, moderate or severe, will go to a center with ICU facility. And all MIS-C will also go into a situation of having ICU facility. And this home care, that is an empowered home care. There will be communication between healthcare worker and the affected family. And the regarding this, where to keep category A and B, physician discretion is allowed also. For example, a malignancy, if physician decide, malignancy definitely cannot be category A, but if physician decides that the chance of infection is more in hospital, he can keep the child at home. So that is it, the physician discretion is given. Now I said about HDU. What is HDU? It is very simple. One healthcare worker for monitoring, and this monitoring is very simple. I'll show you the chart. Oxygen delivery, cylinder oxygen is enough, and pulse oximeter monitoring. And we are preparing HDUs in each and every district, and in many districts we will have more than one HDU. Calicut, I think, is having 3, and each HDU will have a 30-bedded facility with oxygen. PICU means, ICU means multipara monitors, infusion pumps, ventilators, and most important, dedicated staff, not staff that is given just as a stopgap arrangement. Somebody who has been working in ICU will have to continue working there. And this is the simple monitoring chart that we are insisting on HDU, which anybody can fill up. Now, state perspective on investigation. We do not encourage any unnecessary investigation. No investigation for the mild. And what investigation to be done as first line or second line and whom to do, it is clearly mentioned in the state guideline. And perspective on discharge, will discharge the patient 72 hours asymptomatic and afebrile and continue home isolation as per state policy, which at present is 17 days. No need for routine retesting at discharge. but we tend to retest those who have been in ICU, basically because we assume that there is something wrong either with the virulence of the organism or with the immunity of the child that keeps it, tilted him into ICU requiring COVID. And we have actually detected one case of SCID with continued rapid antigen positivity. So similarly, we may be detecting occasional reasons why they landed up in ICU. And the perspective for referral of a mild case is also clearly mentioned in the state guidelines, because a fever or symptomatic child beyond 5 to 7 days means viral multiplication is no longer happening. So something is happening to the child. So before referral, examination for alternate diagnosis. It is not a big thing. For example, a child with fever with no focus, it's usually urinary infection. So we can always exclude that. And if we are referring because of danger sign, make sure that you stabilize and refer. So these are the two conditions that is given. And regarding COVID-19 related MISC, we tend to err towards methylprednisolone, basically because there are enough number of studies now showing that it is as effective as IVIG and much, much less costly. And more important, suppose we insist on IVIG all over India, we will use up all the IVIG available in no time. And IVIG is to be procured from volunteers, so it is not easily replaceable also. So it is always better that we go on methylprednisolone rather than IVIG if they are of equal efficacy. And that's why we are thinking more in terms of methylprednisolone. And preparing for COVID capacity building, we have already started. We have had online classes regarding our state protocol, and then 3-day hand-holding of 2 pediatricians and 2-3 staff nurses for COVID caring institution. And that is very important because what is given in an online lecture or online classes will be generic, but which ventilator is available in that particular district, hands-on on that makes a lot of difference. And that's why this hands-on is being insisted upon. And strengthening of PICUs, especially non-COVID, because we are more worried about MISC. And MISC can be cared in non-COVID setting because most of them will be COVID negative by then. And children with, this is something that Dr. Singhal has already mentioned, like caregiver death, whether the child will be orphaned. Less likely in Kerala because the family ties, but more important would be job loss of the parent and the effect of that in the child. And we have had a dip in vaccine last year, and we are picking up now in routine vaccination. And learning crisis extremely correct, extremely important. And these are some of the issues in child apart from actual COVID infection. I'll stop here. Thank you for your time.
Thank you, Dr. Santosh, for that very good session on situation in Kerala and how we are planning to manage a possible third wave affecting more children. Also about the preparedness by Government of Kerala. Since we don't have much time, I think we can close the session and go for the next session. Questions may be discussed with Santosh over personally. Thank you.
That was an elaborate and informative session. Let's move on to our next session. Our next session focuses on COVID-19 infection and newborns. The speakers are Dr. Siddharth Ramji, Dr. Ashraf TP, and Dr. Girishan VK. Our chairpersons are Dr. VC Manoj, Head of the Department of Neonatology, Jubilee Mission Medical College and Research Institute, Thrissur, Kerala, Dr. Babu Francis CA, Professor of Pediatrics, Malabar Medical College Hospital and Research Center, Kozhikode. He was also the former head of the Department of Neonatology, Government Medical College, Kozhikode. Let's welcome them to take over the session.
Thank you. Audible? Am I audible?
Yes, Babu, you are audible.
Okay. So at the outset, I thank the organizers for giving me this opportunity to chair this session with Dr. Manoj VC. So our first speaker, Professor Siddharth Ramchi, he had been the Dean of the prestigious Maulana Azad Medical College, and he was a professor of neonatology, and he's the apt person to discuss on the outcome of neonates, because he has a very important paper, 50 years of neonatology in India, the progress and future. Because in neonates, the problem in neonatology is whatever interventions you do during neonatology, during the newborn period, we are still in the dark about the future effects of those. The seemingly advantageous interventions may be disastrous in long run. So it's an important topic, the outcome of neonatal COVID. So with this short introduction, we are very glad to use such eminent personality to be associated with us. So over to Professor Siddharth Ramchi.
Thank you, Dr. Francis. Is my screen visible?
Yes.
Your screen is visible.
Okay.
It is visible.
So what I'm going to do the next 15 minutes is to give you a perspective of the neonatal outcomes. Of course, focus is India, but I will also like to kind of touch upon what's known in the global scenario and to know whether India is any different. So I will cover three issues. One is the concern of the vertical transmission from a COVID-infected mother to her baby. Two is to look at what are the clinical manifestations of children who become symptomatic and their outcomes. And I will very briefly touch upon MIS in the newborn. I'm sure there is another greater talk on MIS in general. So this is probably the largest systematic review that has been published at this moment. We have, it was, this had 62 studies which had been published up to February 21. It included 44 countries, and it had a total of about 31,000 pregnant women. I think this is the largest we've had, and you can also see there are some studies, some from India also included in this, but I shall share more details about India later. What they observed was from 11 studies which reported on neonatal COVID, the transmission was about 3.5%. And generally, the definitions for vertical transmission is a baby who has been tested positive, usually in the first 48 or 72 hours. And you can see there's a huge variation. It ranges from about 1.6% to 8.5%. So you find there's a great deal of heterogeneity in reporting in cohorts where mother and baby diets have been tested. If you look at preterm births, this is about 23.4. The ranges run from 18.9 to 28.1. But however, we must remember that these preterm births were reported to be higher in women who are more severe COVID-19 infection. And one of the things that actually increase the risk of severe COVID is comorbidities in women, obesity, diabetes, hypertension. So we must remember that the outcomes in neonates soon after birth or in the perinatal period to a large extent dependent on the maternal severity. If you looked at the number of babies who needed NICU admissions, it's about 23%, ranges from 17 to 31. But remember, most of these kids were shifted to NICUs not for COVID. They were shifted for primary problems like prematurity with RDS, or they had meconium aspiration or asphyxia. And CS deaths was reported in 35 studies, and this is about 48%, and majority were due to obstetric reasons, not due to primary COVID. So we must remember that what we see here is the overall transmissions are less than 10%, hovering around 3.5%. Well, you know that the NNF India had a registry, and this was published in June this year. It had 1330 intramural births, and the vertical transmission in this study was about 8%, which is, you remember, little on the upper end of what is reported in the systematic review. And the horizontal transmission of those who were detected negative in the first 72 hours but became positive thereafter is about 1.5%. You know, ours was a for the entire duration, almost up to January end. And we had during that period from March end, April to, we had about 505 women who delivered, COVID positive, who delivered in our hospital. And the vertical transmission was only about 3.3%, and the horizontal transmission was about 1.5%. So the numbers, as you see, are all very, very similar to what other systematic reviews have shown. Preterm birth rates were 11% versus 4.3. The CS births were 68, 42, again, predominantly very similar to what is reported elsewhere. And the primary reasons still were obstetric and less to do with COVID as a problem. So one thing is clear, that we don't see too much of vertical transmission, but then the question is that what happens? Are they all symptomatic? What happens to these kids? You know, the largest surveillance data that's available to us is from the UK. This UK national cohort reported only 66 COVID positive neonates. And they provided an incidence of only 5.6 per 10,000 live births. You can clearly see that it's very low. It's extraordinarily low, much less than 1%. So neonates getting COVID positive are very, very low. And that's a fact that we must remember. And I think, as was alluded to by our previous speakers, the fact that as they get younger, the immaturity or absence of the ACE receptors probably has a role to play. If you look at the median age of diagnosis in the UK, it was about 9.5 days, and this ranged from about 7 to 11 days. But our 68% of these were all diagnosed later. And what they reported was that if you look at the classification for severity class with COVID, about 40% had severe infection, but only one died. And that too was non-COVID related. What has been the experience from India? Okay, before that, well, this is the symptomatology that they had. You can clearly see that of the 66 kids, fever, poor feeding, upper respiratory, running nose, respiratory distress, lethargy. These were the primary symptoms, which is no different from, you know, any other sick child or sepsis. And if you look on the right-hand side, we looked at the clinical care they received. You will realize that actually very few kids actually required, you know, invasive ventilation, barely 5%, and a good majority required nothing. You know, they were all quite minimal settings, no serious NICU care. And so clearly, even though you do get some neonates who become sick, a third of them probably are serious, but they never get into high-end NICU support, unlike what we have seen in adults. This is data from the India NNF registry. There were only about 20, you know, there are about 182 neonates in that cohort of 1330 who were positive, and only about 23% were symptomatic. But when they compared this 182 versus the remaining neonates who were asymptomatic or COVID negative, the symptom rates were much higher, RR was about 5. So that means if you are testing positive for COVID, you're more likely to have sickness and clinical symptoms as compared to if you're COVID negative but born to a mother who's COVID positive. And the registry also showed similar figures. About 34% had severe disease. You can clearly see that the number who needed mechanical ventilation among COVID positive neonates only about 5%, very similar to what was seen in the UK. The non-COVID is only 1.2. The number who needed oxygen therapy or CPAP was slightly higher. So clearly saying that if you are COVID positive, born to a mother who's COVID, you are likely to be more sick. But whether all this attributable to COVID itself is unclear. And there were only 3 deaths reported in the registry, and all of them were due to non-COVID conditions, prematurity or asphyxia. We looked at our own data, which was done till January end, as I said. We had about 18% babies who were symptomatic, and about 37% had severe disease. We had 1 case with COVID pneumonia, and this baby survived and went. And this baby presented on the 7th day of life. And we've had only 2 deaths, and both of them were unrelated to COVID. Just to get an insight, as is already published between the registry, look at what happens between the babies who were COVID positive and those who are not COVID positive. You can clearly see neither birth weight nor gestations are very different. There is a tendency for preterms being more preterm if you were a COVID positive baby, though these were not statistically significant. And of course, more of these babies were born by cesarean section than by those who were COVID negative. So again, I said, this is probably related to severity of maternal illness. So if mothers are more sick, they go more often into preterm births. They more often require cesarean births, and these babies tend to be sicker because of the primary disease that they have. This is just to give you an insight about the numerous other publications that have come from India. This is not exhaustive. There are many which are small, many which were, some of them were reported for the registry. But just to give an insight, we have studies from Agra, we have from Pune, from Bihar, Orissa, Mumbai. Mumbai, of course, has had the largest share, 2 very large studies from Mumbai. Almost 1,000 babies they have, and mother pair they have reported. And in all of them, you can see clearly that the vertical transmissions are all low. You can say a median of about 4%. Very few babies had neonatal sickness, and if they did, you can see in bulk of them, it was all respiratory or poor feeding. Deaths were reported in very few of them. And again, in most of them, the deaths were fewer. And Mumbai, of course, they did report 3 deaths due to COVID. And in Orissa, they had 1 due to SARS-CoV. So deaths primarily due to attributable COVID seems very uncommon, because most often you often find other problems. And since you can't exclude the other problems as a cause, we are unsure as to what's the direct role of COVID infection. But clearly mortality overall has not been very high, and the number of babies who become very sick are much lower. So experience from India across states, public sector, the private sector, if you look at what we have, is probably no different from the global experience. So I think that's an important message, that there's no reason to believe that the Indian neonates are ethnically any different from the rest of the world when it comes to their vertical transmission and the risk of clinical symptomatology, severity, or death. I want to spend a minute on the neonatal MIS. This is something which is very rare. There was a very large systematic review published on MIS-C, which looked at 662 children, and in that only 1 neonate was reported. However, while I was scanning the literature for this presentation, I came across 1 Indian data. This was a series of 20 neonates published from Solapur. And Maharashtra has had a big chunk of COVID cases. And they reported all these 20 neonates to be MIS-N, or likely to be A, because none of the babies tested positive for for SARS-CoV, but they all had antibodies just as their mothers had. In fact, I think if I remember right, none of the mothers also had, at that time of birth, any tested positive. So they were all antibody. Other causes were unlikely. Most of these neonates presented around the second day of life, in contrast to what has generally been reported in children, which is a little later. But the only assumption I have to make here is that these fetuses might have got affected in utero, and therefore the lag time is, we don't know the exact time, but they might have got infected. But they had a lot of clinical picture and lab data, which is very consistent with MIS. So 90% had cardiac involvement, including coronary involvement. 55% had respiratory problems, 10% with thrombosis, and they also had a few which had neurologic and renal manifestations. However, death was very low. Only 2 babies of the 20 died. And this, I think, is the only series that I could lay hands on. There might have been a smattering of their case reports of MIS in the newborn, but essentially MIS in general is low, and we believe even if they occur, it should be possible to treat them well, and mortality is low, as has also been reported for children. So summing up, I think the message for all of us is that perinatal transmission of COVID is relatively low. It harbors around maybe 4%. And most neonates are essentially asymptomatic, almost 80%. And those who do present with symptoms are usually after day 5, which suspects that they have all got horizontal transmission, either from some other adult family member. And they usually have fever, respiratory symptoms, which are the most common. They present like any other sepsis-like manifestation. And only a third of those who ever have symptoms are really seriously ill. But very few of these, only maybe 10% or less of these severe illness actually need invasive ventilation. Most of them respond to oxygen therapy, maybe CPAP. Death is an uncommon feature, and we must remember when it occurs, it's mostly related to the primary condition with which the newborn has been admitted. It could be prematurity and its complications, fetal growth restrictions, severe birth asphyxia, or sepsis. And so primary SARS-CoV infection causing death is an uncommon phenomenon, and it doesn't seem that the presence of a coexistence, co-infection with COVID actually increases your mortality risk. And of course, MIS as a problem is reported. It seems to be uncommon with low mortality. And so the message for all pediatricians is that, we must continue to do what is good for newborn. Breastfeeding must continue. There's very little evidence that it's actually transmitted from breast milk. There have been 2 studies from India too, which showed that they could not detect any SARS-CoV antigen in the breast milk. We must continue rooming in, though of course, if you look at the Indian registry data, it did say that the positivity rate is slightly higher in babies who are roomed in, but it did not increase the symptomatic rate or illness rate or their mortality. So clearly, I think we must continue to do what we always did for newborns. Don't separate them from mothers, continue skin-to-skin care, continue breastfeeding. Of course, mothers and adult caregivers must continue to follow COVID-appropriate behavior. But I think as long as we continue that and continue our standard care and even our existing NICUs, we are quite okay with newborns. And so I think by far and large, neonates do well and should not be a cause of concern as it has been for children. I'll stop here and be happy to answer any queries that may be there. Thank you so much.
Thank you so much, Professor Siddharth Ramji. Sir, your talk was, as usual, excellent. And I think we'll just take only one question for the lack of time. It is regarding the treatment. Somebody has posted a question on how COVID is treated, the role of steroids and IVIG in neonates.
Well, there is no standard protocol available. The standard thing is that since most of the babies are admitted for a primary problem, which is not COVID. For example, if an RDS with prematurity or if a birth asphyxia, you need to treat that. So I don't think that at this moment we have an answer, though of course people have used a variety of potpourri, as you saw on the NNF registry also, and even in the UK protocol. But I would say that you should treat newborns for the primary problem. And I think this is true, very, very true. And we should not jump the wagon and say, I'm treating him for COVID and push them on steroids and other drugs or IVIG or whatever it may be. Except if you have nothing else to explain and you believe this is COVID and the child is not responding, you may try it.
Thank you. So the message is very, very clear. Treatment of COVID, miss or no miss, neonates, sick neonate to be treated as per the routine protocol. COVID, role of COVID and miss and all that make much of a difference. Your talk was real eye-opener to the road ahead for all of us. Thank you so much, sir.
Thank you.
Now may I request the second speaker for the session, Dr. Ashraf. Professor Ashraf does not require any introduction for any of us. He was a previous in charge of neonatal SU at Medical College Calicut, but more than that, we know him as a loving person. His administrative skills have been proved at various levels when he was a state mission director and all that. Now, without any more words, may I invite Dr. Ashraf for his talk. He's going to talk to us about the Calicut experience of COVID-19 in neonates. Are you there?
Yeah. Thank you, Dr. Manoj, for the nice words. Whether my screen is visible?
Yes, it is visible. Please go ahead.
Dr. Siddharth Raju sir has an extensive review on neonatal COVID situation in India with a particular reference to the Delhi. Next 10 to 15 minutes, I will try to. My screen is not moving, Dr. Manoj. 1 minute.
Just take. Yes. It is moving.
Now it is okay. Now it is okay. I will share our little experience with the newborns exposed to COVID situations. We had 1,012 babies admitted in our isolation or NICU as COVID suspects. Out of this 1,012, 972 babies, the mothers had COVID during antenatal period during pregnancy. And rest of the babies are exposed postnatally. Either mother had a postnatal infection with COVID or a bystander or a family member. Out of this 1,012 babies who had admitted in isolation as COVID suspects, 248 turned COVID positive. That is 31.3% of them become COVID positive. 10% of them, that is 98 out of 972 babies born to COVID positive mothers become positive in the first week of life. The routine practice in Kerala, we are doing RT-PCR after 24 hours of birth. And another 14.8% who either exposed to COVID during the antenatal period or exposure in the postnatal period. 150 out of 1,012 turned positive during the postnatal day 8 to 28. That is 14.8%. So out of 248 positive newborns, 60.4% of them became COVID positive after 1 week. We had one death. That baby is having congenital diaphragmatic hernia, died within 24 hours of birth. Mother was RT-PCR positive and baby TrueNat positive, RT-PCR negative. Most probably the cause of death may not be COVID. It may be due to severe congenital diaphragmatic hernia. Out of these 248 babies, most of them are asymptomatic, but 6 babies had a stomy course in our NICU. Actually, out of this 972 babies, 51% of them delivered through the LSCS. Our gynecologists are not scared to do LSCS in COVID positive mothers. And the incidence of preterm delivery is nearly 8%. That are already discussed about that points. I already said we had 6 babies having various clinical manifestation and a stomy course in our NICU. I am discussing that 6 cases briefly. The first case is a 26-weeker with a birth weight of 930 grams. The routine preterm care was given. The baby was improving. Changed to the room air on 7th neonatal day, but that baby developed apnea, requiring bag and mask ventilation, CPAP, and went into shock, treated with inotropes on 8th neonatal day. And baby developed gangrene of the left toes of the left leg on the same 8th neonatal day. To our surprise, both the mother and baby turned RT-PCR positive on the same day. The septic screen was also positive, culture grown Acinetobacter. The Doppler showed flow till bifurcation of the popliteal artery, no thrombus visualized. This is the 8th neonatal day picture, gradually developed into a full-blown gangrene. And the first picture is at the time of discharge, and this is the picture taken last Friday when came for the follow-up. A baby with a temporal association with the COVID developing gangrene. Whether it is due to COVID, whether it is due to neonatal sepsis, whether it is due to shock, it is debatable. But this is the first case we saw with the gangrene, and there is a temporal association with the COVID positivity. There are some case reports about the thrombosis in children, but not much case reports in newborns. Then, that is already mentioned about the multisystem inflammatory syndrome in children. And this is a presumptive case of multisystem inflammatory syndrome in a neonate. We had a baby, term IUGR baby. Mother was COVID positive at 3rd month of pregnancy. Naturally, no RT-PCR was taken after birth. But on 17th neonatal day, child presented to us with respiratory symptom and RAT was positive. Gradually progressed into a category C case. We had intervened with non-invasive ventilation initially, later invasive ventilation, and after a stomy course, we were able to do a confirmatory echo on this child only on 36th neonatal day. And the echo findings, there is a large VST, small PDA, small AST, and pulmonary vein stenosis, and coronary arteries are dilated. We sent investigation for the multisystem inflammatory syndrome, and all investigations are suggestive of MIS. So this is the echo report. Is it a multi-system inflammatory syndrome neonate, or this mother had COVID during the first trimester of the pregnancy, whether the COVID can lead to congenital heart disease, that is IUGR, etc. These are the questions. There are some studies about the multi-system inflammatory, some studies and case reports about the multi-system inflammatory syndrome in infants. Then another 3 babies with the classical radiological features of interstitial lung disease. One baby is a term baby with a birth weight of 2.45 kg. Other 2 babies are preterm babies. All the mothers had COVID during the early months of pregnancy. One mother had it 3rd month, other mother 4th month, and the other mother 5th month of pregnancy. Then all these 3 cases, mothers were composite during the initial months of their pregnancy. All these babies had persistent respiratory distress and prolonged oxygen dependency. First-time baby did not have any obvious cause for respiratory distress, and X-ray showed interstitial pattern. CT showed ground glass appearance with septal thickening. Usually, ILD due to various causes will not improve with time. This baby improved gradually over 1 month period. Then, second preterm baby had prolonged oxygen dependency, which made us to think some other reason other than RDS. This baby also showed an interstitial pattern in X-ray, and CT showed ground glass appearance with the septal thickening. The third baby actually have some confounding factors. The X-ray is not very much suggestive of interstitial lung disease, but CT picture showed ground glass appearance. Our radiologist is comparing this CT picture with the pictures of the post-COVID fibrosis in adults. And COVID antibody titers are high in all these babies. These babies gradually improved with minimal intervention over a period of time. Clustering of similar cases with the temporal association of antenatal COVID infection in early months of pregnancy. Radiological findings highly suggestive of interstitial lung disease, intrauterine transmission of infection in early pregnancy, or an inflammatory reaction to maternal cytokines in utero may be the reason for this interstitial lung disease-like patterns. These are the X-rays, first baby, second baby. These are the CT findings, first baby, second baby, and third baby. Then we had another baby with the congenital limb ischemia. A term AGA born to preemie with a COVID infection in 3rd trimester, presented with right upper limb ischemia, gangrene below elbow at birth, except 3 lateral fingers. CT angiography revealed right axillary artery thrombosis. CT head revealed left MC and PCA territorial infarct. Even though with this amount of infarct, child was active except that gangrene. The thrombophilic workup of both mother and baby is unremarkable. Baby was initially we thought of amputation, but later we managed it conservatively under a multidisciplinary team. Serial Doppler exam. The last week we had a Doppler, which revealed an improved vascularity to affected limb. Because of the lateral 3 fingers are spared, we decided to wait. The baby had a positive COVID antibody titer, but RT-PCR was negative. This is the first day picture of the baby. Later, the lateral 3 fingers are almost normal. Thanks to God, this is yesterday's picture. There is a good recovery of the limb. Our decision to salvage is the right thing, I think now. Then this is the imaging of the brain. You can see infarct there. Even with this infarct, the baby is very active, moving all other limbs normally, feeding well, and there was no infection. There is no. We are afraid of DIC, but nothing happened luckily. There are another case report about the limbic ischemia and gangrene in a newborn with a COVID exposure. Then we are actually learning from our failures. Rather than presenting this case, the objective of this presentation is discussion in the group. What is the role of follow-up echo in neonates with a severe clinical manifestation of COVID? Is it indicated? The interstitial lung disease in neonate could be a manifestation of a fetal inflammatory response, which needs further discussion as well as the research. Intrauterine thrombotic event and consequent neonatal morbidity, though rare, can occur even in asymptomatic maternal COVID infection, as well as in newborn with severe COVID. Need for multicentric database research and registry. The session is open for discussion. Over to you, Dr. Manoj and Dr. Babu.
Thank you so much, sir. It was really interesting and frightening. If this is going to be the future for us, but hopefully it won't be that bad with the next the third wave. But some of the questions that you really posed to the audience may not have answer now, but they are all really thought-provoking. Thank you so much, and it's a treasure of information there about the various types of variants of Miss N that we can have are also explained. Thank you so much.
Thank you.
Dr. Babu, you're there?
We have.
Thank you, Manoj. Luckily, most of our newborns are asymptomatic. But
that is there. We always consider that COVID, what are sudden and Miss N is a very rare thing, and then when you have it, also you somehow get away. And even though you, the majority, all these babies now, I think all the centers, when you suspect in that scenario, we all do echo and all that. But then the implications are just beyond that. Actually, that is very, very nice. Actually, nicely brought out. Actually, thank you. Dr. Babu, over to you.
So we are going to start with the inaugural session now. So Dr. Girishan's talk will follow the inaugural session. Dr. Geeta?
Okay, Babu. We will move on to inaugural session.
Okay. After that, we will have the Dr. Girishan session. Okay, Manish.
Yeah, sure. That's good.
Dr. Ajit, whether the principal joined?
Yeah, we have joined. Principal and joined. Yeah.
CM as well as the CM office already joined. I think CM will come soon. Please contact Ravindra sir. Ajit.
മാഡത്തിന്റെ GEP
രവീന്ദ്രൻ സാറിനെ ഒന്ന് വിളിച്ചോക്കെ തുടങ്ങാൻ പറഞ്ഞല്ലേ? കൊടുക്കാം. പ്രിയമുള്ളവരെ, കോഴിക്കോട് മെഡിക്കൽ കോളേജിലെ ശിശുരോഗ വിഭാഗവും ഇന്ത്യൻ അക്കാദമി ഓഫ് പീഡിയാട്രിക്സും ദേശീയ ആരോഗ്യ ദൗത്യവും സംയുക്തമായി സംഘടിപ്പിക്കുന്ന കുട്ടികളിലെ കോവിഡ് ദേശീയ സെമിനാറിന്റെ ഹ്രസ്വമായ ഉദ്ഘാടന ചടങ്ങാണ് നടക്കാൻ പോകുന്നത്. ഉദ്ഘാടനം നിർവഹിക്കുന്നത് കേരളത്തിന്റെ ബഹുമാന്യനായ മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ അവർകളാണ്. ഈ സെമിനാറിലേക്ക് വിശിഷ്ടാതിഥികളെയും അതുപോലെ തന്നെ പ്രതിനിധികളെയും സ്വാഗതം ചെയ്യാൻ കോഴിക്കോട് മെഡിക്കൽ കോളേജിന്റെ പ്രിൻസിപ്പൽ ഡോക്ടർ രാജേന്ദ്രൻ സാറിനെ സ്നേഹപൂർവ്വം സ്വാഗതം ചെയ്യുന്നു.
ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ, ബഹുമാനിയായ ആരോഗ്യവകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ്, പ്രിയപ്പെട്ട MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ, മറ്റു വിശിഷ്ട വ്യക്തികളെ, കേരളത്തിൽ നിന്നകത്തും പുറത്തും സെമിനാറിൽ പങ്കെടുക്കുന്ന പ്രതിനിധികളെ, കോഴിക്കോട് മെഡിക്കൽ കോളേജിലെ ഏറ്റവും മികച്ച വകുപ്പുകളിലൊന്നാണ് ശിശുരോഗ വിഭാഗം. പഠന, ചികിത്സ, ഗവേഷണ രംഗങ്ങളിൽ മികച്ച സേവനം കാഴ്ചവെക്കുന്ന ശിശുരോഗ വിഭാഗം ഇന്ത്യൻ അക്കാദമി ഓഫ് പീഡിയാട്രിക്സും ദേശീയ ആരോഗ്യ ദൗത്യവുമായി ചേർന്ന് സംഘടിപ്പിക്കുന്ന ദേശീയ സെമിനാറിനെത്തിയ നിങ്ങളേവരെയും സ്വാഗതം ചെയ്യുക എന്നതാണ് എൻ്റെ കർത്തവ്യം. തിരക്കുകൾക്കിടയിലും ഈ സെമിനാർ ഉദ്ഘാടനം ചെയ്യാൻ സമ്മതിച്ച ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രിക്ക് നന്ദി രേഖപ്പെടുത്തുന്നതിനോടൊപ്പം പ്രതിസന്ധി ഘട്ടത്തിൽ കേരളത്തിന് ശക്തമായ നേതൃത്വം നൽകി മുന്നോട്ട് നയിക്കുന്ന കേരളത്തിൻ്റെ ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയനെ ഈ ചടങ്ങിലേക്ക് സ്നേഹപൂർവ്വം സ്വാഗതം ചെയ്യുന്നു. ആരോഗ്യവകുപ്പിന് ശക്തമായ നേതൃത്വം നൽകുന്ന ബഹുമാനിയായ ആരോഗ്യ, വനിതാ, ശിശു വികസന വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് ആണ് ഈ ചടങ്ങിൽ അധ്യക്ഷത വഹിക്കുന്നത്. ബഹുമാനപ്പെട്ട ആരോഗ്യവകുപ്പ് മന്ത്രിയെ സ്നേഹപൂർവ്വം സ്വാഗതം ചെയ്യുന്നു. ചടങ്ങിലേക്ക് നമ്മുടെ തന്നെ MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രനെ സ്വാഗതം ചെയ്യുന്നു. വിശിഷ്ടാതിഥികളായ IAP ദേശീയ പ്രസിഡന്റ് ഡോക്ടർ രമേഷ് കുമാറിനെയും കേരള പ്രസിഡന്റ് ഡോക്ടർ ജയറാമിനെയും ഡോക്ടർ സുധീർ ഗുപ്ത, ഫൗണ്ടേഷൻ ഓഫ് പ്രൈമറി ഇമ്മ്യൂൺ ഡെഫിഷ്യൻസി ഡിസോർഡേഴ്സ് ഫ്രം USA സ്വാഗതം ചെയ്യുന്നു. സമയക്കുറവ് കാരണം മറ്റു വിശിഷ്ടാതിഥികളെയും സഹപ്രവർത്തകരെയും പ്രതിനിധികളെയും ഒറ്റവാക്കിൽ സ്വാഗതം ചെയ്തുകൊണ്ട് നിർത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, Rajendran sir. Now I invite Dr. Ajit Kumar VT, കോഴിക്കോട് മെഡിക്കൽ കോളേജിലെ ശിശുരോഗ വിഭാഗം മേധാവിയും ഓർഗനൈസിംഗ് കമ്മിറ്റി ചെയർമാനുമായ ഡോക്ടർ അജിത്തിനെ ഹ്രസ്വമായ ഒരു ആമുഖം പറയുന്നതിന് വേണ്ടി ക്ഷണിക്കുന്നു.
Honorable Chief Minister Sri Pinarayi Vijayan sir, Honorable Minister for Health and Family Welfare Srimati Veena George Madam, our Honorable Chief Guest Dr. Ravindran sir, our dear Principal Rajendran sir, Superintendent of IMCH Sri Kumar sir, Guest of Honor Dr. Ramesh, IAP President-elect of the Nation, Dr. TP Jayaraman sir, President of IAP Kerala, Dr. Naveen DPM, other dignitaries of IAP, and dear teachers, senior pediatricians, my colleagues and students in the department, and dear friends. And it's a real honor to have our beloved Chief Minister inaugurate the National Pediatric COVID Conference. And as we all know, that we are in the midst of a changing times, and this conference is a meeting place to take stock of the changing paradigm in COVID arena, and where experts from all over the world share their experience for the betterment of the child with COVID. Yesterday, the first day, there were more than 25 papers, scientific papers on pediatric COVID from all over India. And today's deliberation will definitely improve the way the pediatric COVID is being treated. Our dear Honorable Chief Minister has always given priority to health, which is evident in the way the second wave has been managed. When all other states' health facilities were collapsing, our health system and infrastructure was resilient and stood firm, and there was less debt. And our department has been very active during this last 1.5 years. and because of our faculty and residents who have stood strong during these days. And sir, we are ready to face any further waves and challenges head on. And we request our Honorable Chief Minister, as well as our Minister of Health and Family Welfare, to include our requirements in the next 5-year plan so that we can achieve the status of a center of excellence in the lines of All India Institute of Medical Science. I fervently hope that an advanced pediatric care center, a dream of our teacher, will come true. Thank you. Jai Hind.
Thank you, Ajit. ഈ ചടങ്ങിൽ അധ്യക്ഷം വഹിക്കുന്നത് കേരളത്തിലെ ബഹുമാനപ്പെട്ട ആരോഗ്യ മേഖലയ്ക്ക് ശക്തമായ നേതൃത്വം നൽകുന്ന ബഹുമാനപ്പെട്ട ആരോഗ്യ വനിതാ ശിശു വികസന വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് അവർകളാണ്. മാഡത്തെ ബഹുമാനപൂർവ്വം അധ്യക്ഷം വഹിക്കുന്നതിനായി ക്ഷണിക്കുന്നു.
ആദരണീയനായ CM ഉദ്ഘാടനം ചെയ്തതിനു ശേഷം നടത്തിക്കൊള്ളാം. ബഹുമാനപ്പെട്ട CM എത്തിയിട്ടുണ്ട്. നമുക്ക് ഉദ്ഘാടന പ്രസംഗത്തിലേക്ക് പോകാം. ആദരണീയനായ
സഹോദരീ സഹോദരന്മാരെ, ലോകം മുഴുവൻ കോവിഡ് പ്രതിസന്ധിയിലാണ്. അതുണ്ടാക്കുന്ന ആരോഗ്യ, സാമൂഹ്യ, സാമ്പത്തിക, പാരിസ്ഥിതിക പ്രശ്നങ്ങളെപ്പറ്റി സംവാദങ്ങളും ചർച്ചകളും നടക്കുന്നു. ഇത്തരം ചർച്ചകൾ പൊതുവെ മുതിർന്നവരെ മനസ്സിൽ കണ്ടുകൊണ്ടതാണ്. എന്നാൽ കോവിഡ് കുട്ടികളിലുണ്ടാക്കുന്ന ആരോഗ്യ പ്രശ്നങ്ങൾ മുതിർന്നവരിൽ നിന്നും വ്യത്യസ്തമാണ്. അതുകൊണ്ട് തന്നെ കുട്ടികളിലും കൗമാരപ്രായക്കാരിലും കോവിഡ് ഉണ്ടാക്കുന്ന ആരോഗ്യ മാനസിക പ്രശ്നങ്ങളെപ്പറ്റി വിശദമായ ചർച്ചകൾ ഇനിയും നടക്കേണ്ടതുണ്ട്. ഇത് മുൻനിർത്തിയാണ് കോഴിക്കോട് മെഡിക്കൽ കോളേജിലെ ശിശു ചികിത്സാ വിഭാഗവും ശിശുരോഗ വിദഗ്ധരുടെ അഖിലേന്ത്യാ സംഘടനയായ ഇന്ത്യൻ അക്കാദമി ഓഫ് പീഡിയാട്രിക്സും ദേശീയ ആരോഗ്യ മിഷനും സംയുക്തമായി കുട്ടികളിലെ കോവിഡിനെ പറ്റിയുള്ള ഈ ദേശീയ സെമിനാർ സംഘടിപ്പിച്ചിരിക്കുന്നത് എന്ന് കരുതുന്നു. കോവിഡിൻ്റെ പശ്ചാത്തലത്തിലാണ് ഇത് സംഘടിപ്പിച്ചിരിക്കുന്നത്. ഇപ്പോഴാകട്ടെ കോവിഡിൻ്റെ 3ാം തരംഗത്തെ കൂടി നമുക്ക് നേരിടേണ്ടി വരുമെന്നാണ് വിദഗ്ധർ അഭിപ്രായപ്പെടുന്നത്. 3ാം തരംഗം കുട്ടികളിലേക്ക് എത്തിച്ചേരുന്നതിനുള്ള സാധ്യതകളും പ്രവചിക്കപ്പെടുന്നുണ്ട്. ഈ അവസരത്തിൽ കുട്ടികളിൽ നല്ല ആരോഗ്യശീലങ്ങൾ വളർത്തിയെടുക്കുക എന്നതാണ് നാം ലക്ഷ്യം വെക്കുന്നത്. അതിനായി പ്രത്യേക വീഡിയോ ബോധവൽക്കരണ പരിപാടി സർക്കാർ സംഘടിപ്പിക്കുന്നുണ്ട്. കോവിഡ് കാരണം കുട്ടികൾക്കുണ്ടാകുന്ന പ്രതിസന്ധികളൊക്കെ തന്നെ ഇവിടെ സജീവമായി ചർച്ച ചെയ്യപ്പെടും എന്നാണ് കരുതുന്നത്. സർക്കാർ സജീവമായി പരിഗണിക്കുന്ന ചില വിഷയങ്ങളിലേക്ക് കൂടി നിങ്ങളുടെ ശ്രദ്ധ ക്ഷണിക്കാൻ ഈ അവസരം ഞാൻ ഉപയോഗിക്കുകയാണ്. ഈ വിഷയങ്ങളിൽ കൂടുതൽ ക്രിയാത്മകമായ അഭിപ്രായങ്ങളും പ്രതീക്ഷിക്കുന്നുണ്ട്. കോവിഡിൻ്റെ 3ാം തരംഗം കുട്ടികളെയാവും കാര്യമായി ബാധിക്കുക എന്ന ആശങ്ക പലരും പ്രകടിപ്പിക്കുന്നു. അത് പരിഗണിച്ച് സാധ്യമായ എല്ലാ മുൻകരുതലുകളുമാണ് സർക്കാർ എടുക്കുന്നത്. കുട്ടികൾക്കുണ്ടാവാനിടയുള്ള മൾട്ടി സിസ്റ്റം ഇൻഫ്ലമേറ്ററി സിൻഡ്രോം കണ്ടെത്താനുള്ള മുൻകരുതൽ നടപടികൾ എടുത്തു. കൂടുതൽ ICU സംവിധാനങ്ങൾ ഏർപ്പെടുത്തുന്നു. ഇത്തരത്തിൽ ചെയ്യാവുന്നതെല്ലാം ചെയ്യാനാണ് ഉദ്ദേശിക്കുന്നത്. 5 വയസ്സ് വരെയുള്ള കുട്ടികൾ, അവർക്ക് നമ്മുടെ നാട്ടിൽ ഈ ചെറിയ കുട്ടികളുടെ പ്രശ്നം പറഞ്ഞാൽ പുതിയ സ്കൂൾ ദിനങ്ങളും ചങ്ങാതിമാരും ഒക്കെയായി ജീവിതത്തിലെ പ്രത്യേക ഘട്ടമാണ് നഷ്ടമായിരിക്കുന്നത്. ഒരു 2ാം തരത്തിലെ കുട്ടി സ്കൂളിൽ എത്തിയാലുണ്ടാകുന്ന മാനസിക പ്രശ്നം നമ്മൾ ഇനി ആലോചിക്കണം. കാരണം കുട്ടി ഇതേവരെ വീട്ടിലാണ്. ആ കുട്ടിക്ക് സാധാരണഗതിയിൽ കൂടിച്ചേർന്ന അനുഭവമില്ല. വീട്ടിലെ അച്ഛനും അമ്മയും സഹോദരങ്ങളും അപ്പൂപ്പനും അമ്മൂമ്മയും അങ്ങനെയുള്ളവരെ കണ്ട അനുഭവം മാത്രമേ ഉള്ളൂ. കുട്ടികളുമായി കൂടിച്ചേർന്ന അനുഭവമില്ല. ഒരു പുതിയ കാലം നമുക്ക് നേടേണ്ടി വന്നിരിക്കുന്ന അർത്ഥം. അങ്ങനെയുള്ള എത്രയോ കുട്ടികളല്ലേ 2ാം തരത്തിലെത്തുന്ന കുട്ടികൾ ഇപ്പൊ 2ാം തരത്തിൽ പോകാൻ കഴിയുന്നില്ല. ഇനി എത്ര കാലം നീണ്ടു നിൽക്കുമെന്ന് പറയാൻ പറ്റും. അപ്പോ അത്തരത്തിൽ ജീവിതത്തിലെ ഒരു പ്രത്യേക ഘട്ടം എല്ലാവർക്കും സംജാതമായിരിക്കുന്നു. അതിന് കുട്ടികൾക്കാണ് ഏറ്റവും വലിയ നഷ്ടം സംഭവിച്ചിരിക്കുന്നത്. ഇതിന് പരോക്ഷമായ മറ്റൊരു വശം കൂടിയുണ്ട്. അത് സാമ്പത്തികമായതും ആരോഗ്യപരമായതുമാണ്. അവശ്യ വസ്തുക്കൾ പോലും ലഭ്യമാക്കാൻ കഴിയാത്ത രീതിയിൽ പല കുടുംബങ്ങളുടെയും സാമ്പത്തിക അടിത്തറ വരെ തകർന്ന കാലഘട്ടമാണിത്. കോവിഡ് വ്യാധിയുടെ ആരംഭം മുതൽ നമ്മുടെ നാട്ടിലെ ഒരു മനുഷ്യനും പട്ടിണി കിടക്കരുത് എന്ന നിഷ്കർഷ സർക്കാർ പുലർത്തിയിരുന്നു. അതിൻ്റെ അടിസ്ഥാനത്തിലാണ് ഭക്ഷ്യക്കിറ്റുകളും മറ്റും വിതരണം ചെയ്യുന്ന നിലയുണ്ടായത്. മറ്റു സ്വീകരിച്ച നടപടികൾ നിങ്ങൾക്കറിയാം. അതിലേക്കൊന്നും ഞാനിപ്പോൾ വിശദമായിട്ട് പോകുന്നില്ല. കുട്ടികളുടെ താല്പര്യങ്ങൾ കണക്കിലെടുത്തുകൊണ്ടുള്ള വിഭവങ്ങൾ, അവർക്ക് പോഷകാഹാരം ഉറപ്പുവരുത്തുന്നതിനുള്ള ഇനങ്ങൾ എന്നിവ കൂടി കിറ്റിൽ ഉൾപ്പെടുത്തുന്നുണ്ട്. 5 വയസ്സിന് മുകളിലുള്ള കുട്ടികൾ അവരുടെ വ്യക്തിത്വ വികാസത്തിൻ്റെയും സാമൂഹ്യ ജീവിതത്തിൻ്റെയും സുപ്രധാന ഘട്ടമാണ്. മഹാമാരി മൂലം സാധാരണ നിലക്ക് എടുത്തു മാറ്റപ്പെട്ടു. കായികമായ ഉല്ലാസങ്ങൾ, വ്യായാമങ്ങൾ, അതെല്ലാം കുട്ടികൾക്ക് നിഷിദ്ധമായിരിക്കുന്നു. ഇതിനൊന്നിനും കഴിയാത്ത അവസ്ഥ കുട്ടികൾക്ക് സംഭവിച്ചിരിക്കുന്നു. കുട്ടികളുടെ സ്വഭാവ രൂപീകരണത്തെ സ്വാധീനിക്കുന്ന ഇടങ്ങളാണ് സ്കൂളുകൾ. അവിടെ പോകാൻ പറ്റാത്ത അവസ്ഥ. ഈ പ്രതിസന്ധി ഘട്ടത്തിലും അവരുടെ വ്യക്തിത്വ വികസനം എങ്ങനെ സാധ്യമാക്കാം എന്നതിനെക്കുറിച്ച് വിശദമായ ചർച്ചകളും നിർദ്ദേശങ്ങളും കൂടി നിങ്ങളിൽ നിന്ന് ഉണ്ടാകുമെന്ന് പ്രതീക്ഷിക്കുകയാണ്. നമ്മുടെ ആരോഗ്യ സംവിധാനങ്ങൾ കോവിഡിലേക്ക് ശ്രദ്ധ കേന്ദ്രീകരിച്ചപ്പോൾ തന്നെ നാളുകളായി തുറന്നു വന്ന കുട്ടികളുടെ രോഗപ്രതിരോധ പ്രവർത്തനങ്ങളും പരിചരണവും മുടക്കം കൂടാതെ തുടരുന്നുവെന്ന് ഉറപ്പുവരുത്തേണ്ട ഉത്തരവാദിത്വവും നാം ഏറ്റെടുത്തു. ലോകമാകെ ഈ 2 കാര്യങ്ങളെയും ഒരുമിച്ച് കൊണ്ടുപോകുന്നത് എങ്ങനെയെന്ന് സംശയിച്ചു നിന്നപ്പോൾ കേരളത്തിലെ ആരോഗ്യ സംവിധാനം മാതൃകയായി. ലോകത്ത് 26ഓളം രാജ്യങ്ങൾ കുട്ടികൾക്കുള്ള 5ാം പനി പ്രതിരോധ കുത്തിവെപ്പ് നിർത്തിവെച്ചു എന്ന വാർത്ത നാം എല്ലാവരും കണ്ടതാണ്. ഈ ഘട്ടത്തിലും നമ്മുടെ സംസ്ഥാനത്ത് കുട്ടികൾക്കുള്ള പ്രതിരോധ കുത്തിവെപ്പുകൾ കൃത്യമായി നടത്താൻ കഴിഞ്ഞു എന്നത് അഭിമാനകരമാണ്. ശിശുരോഗ നിർണയത്തിലും ചികിത്സയിലും കേരളം മെച്ചപ്പെട്ട നിലയിലേക്ക് എത്തിയത് നിരവധി പടവുകൾ ചവിട്ടിയാണ്. ചരിത്ര പുസ്തകങ്ങൾ മറിച്ചു നോക്കിയാൽ എത്രമാത്രം ശിശുമരണങ്ങളാണ് അവയിലുള്ളതെന്ന് നമുക്ക് കാണാൻ കഴിയും. ഫ്രെഡറിക് ആംഗൽസ് തൊഴിലാളികളുടെ അവസ്ഥയെക്കുറിച്ച് ഒരു പുസ്തകത്തിൽ പ്രതിപാദിക്കുമ്പോൾ പകർച്ചവ്യാധികൾ വന്നും അപകടങ്ങൾ കൊണ്ടും മരണപ്പെട്ട കുഞ്ഞുങ്ങളെക്കുറിച്ച് പറയുന്നുണ്ട്. കാർൽ മാർക്സും എബ്രഹാം ലിങ്കണും മഹാവ്യാധി വന്ന് മരിച്ച സ്വന്തം കുട്ടിയുടെ ചേതനയറ്റ ശരീരത്തിനു മുന്നിൽ പൊട്ടിക്കരഞ്ഞതിനെക്കുറിച്ച് നാം വായിച്ചിട്ടുണ്ട്. നിസ്സഹായരായി തങ്ങളുടെ കുഞ്ഞുങ്ങളെ മരണത്തിന് വിട്ടുകൊടുക്കേണ്ടി വന്ന അച്ഛനമ്മമാർ ചരിത്രത്തിൽ എമ്പാടുമുണ്ട്. നാസി തടവറയിൽ രോഗാതുരയായി മരിച്ച ആൻ ഫ്രാങ്കിനെ ആവട്ടെ വേദനയോടെയല്ലാതെ നമുക്ക് ഓർക്കാൻ കഴിയില്ല. നമ്മുടെ നാട്ടിലും സ്ഥിതി വ്യത്യസ്തമായിരുന്നില്ല. ഒരേ സമയം വിവേചനങ്ങളോടും രോഗങ്ങളോടും നമുക്ക് പൊരുതേണ്ടതായി വന്നു. കോളറയും പ്ലേഗും വസൂരിയും വന്ന് മരണപ്പെട്ട കുഞ്ഞുങ്ങളെ പനമ്പായിലും ഇലകളിലും പഴം തുണിയിലും പൊതിഞ്ഞു കെട്ടി കൊണ്ടുപോകുന്ന കാഴ്ച നമ്മളിൽ ചിലർ കണ്ടും ചിലർ വായിച്ചു കേട്ടും അറിഞ്ഞിട്ടുണ്ട്. നമ്മുടെ ക്ലാസ് മുറികളിൽ കണ്ണുനീർ വീഴ്ത്തിച്ച ഒരു കവിതയുടെ ആശയം തന്നെ ബാലമരണമാണ്. വൈലോപ്പള്ളിയുടെ മാമ്പഴം. ഈ അവസ്ഥകളിൽ നിന്നാണ് നാം മുന്നേറിയെത്തിയത്. ആ മുന്നേറ്റം വ്യക്തമായ ലക്ഷ്യബോധത്തോടെ നടത്തിയ കൂട്ടായ പ്രവർത്തനങ്ങളുടെ ഫലമാണ്. അതിൻ്റെ ചൂണ്ടുപലകകളാകാൻ കഴിഞ്ഞവരാണ് നിങ്ങൾ ഓരോരുത്തരും. കോവിഡ് കാലത്ത് കുട്ടികളെ കൂടുതൽ കരുതലോടെ ചേർത്ത് പിടിക്കേണ്ടതുണ്ട്. മഹാമാരിയുടേതായ ഈ പ്രതിസന്ധി ഘട്ടം ശിശുപരിപാലന മേഖലയ്ക്ക് മുന്നിൽ ചില വെല്ലുവിളികൾ ഉയർത്തുന്നുണ്ട്. കുട്ടികളിൽ കോവിഡ് ഏൽപ്പിക്കുന്ന ശാരീരികവും മാനസികവുമായ ആഘാതങ്ങളുടെ ആഴവും പരപ്പും ഇനിയും പഠിക്കേണ്ടതുണ്ട്. ഇനിയും മുന്നോട്ട് എന്നതാണ് നമ്മെ നയിക്കുന്ന മുദ്രാവാക്യം. ആ കാഴ്ചപ്പാടിന് കരുത്തേകുന്ന വിധത്തിലുള്ള ആശയങ്ങൾ ഈ സെമിനാറിൽ നിന്നും ഉരുത്തിരിഞ്ഞു വരുമെന്ന് പ്രതീക്ഷിക്കുന്നു. അത് സർക്കാരിൻ്റെ ശ്രദ്ധയിൽ കൊണ്ടുവരാൻ സംഘാടകർ ശ്രദ്ധിക്കുകയും വേണം. അത്തരത്തിൽ ശിശുപരിപാലന രംഗത്ത് നവീനമായ ആശയങ്ങൾ ഉയർന്നു വരാൻ ഈ സെമിനാർ കാരണമാകും എന്ന പ്രത്യാശയോടെ കുട്ടികളിലെ കോവിഡ് സംബന്ധിച്ച ഈ ദേശീയ സെമിനാർ സന്തോഷപൂർവ്വം ഉദ്ഘാടനം ചെയ്തതായി പ്രഖ്യാപിക്കുന്നു. എല്ലാവർക്കും എൻ്റെ സ്നേഹാഭിവാദനം.
Thank you, sir. Thank you for your presence as well as the thought-provoking speech, which touched the hearts of the everybody present in this meeting. Thank you, sir. Really, thank you, sir. Now I invite our Health Minister for the presidential address.
ഏറ്റവും ആദരണീയനായ മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ, ബഹുമാന്യനായ ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ MLA, ഈ പരിപാടിയിൽ പങ്കെടുക്കുന്ന വിശിഷ്ട അതിഥികൾ, ഡോക്ടർ രമേഷ് കുമാർ, ഡോക്ടർ ജയരാമൻ, ബഹുമാന്യരായിട്ടുള്ള എന്റെ പ്രിയപ്പെട്ട സഹപ്രവർത്തകരെ, പ്രിയപ്പെട്ട ഡോക്ടേഴ്സ്, മറ്റ് ആരോഗ്യ പ്രവർത്തകർ, പ്രിയപ്പെട്ടവരെ, ആദ്യമേ ഈ രീതിയിൽ നാഷണൽ പീഡിയാട്രിക് കോവിഡ് കോൺഫറൻസ് കോഴിക്കോട് മെഡിക്കൽ കോളേജിലെ ശിശുരോഗ വിഭാഗവും ഇന്ത്യൻ അക്കാഡമി ഓഫ് പീഡിയാട്രിക്സും അതുപോലെ NHM ചേർന്ന് നടത്തുന്നതിലുള്ള അഭിനന്ദനവും സന്തോഷവും ഞാൻ ആദ്യമേ അറിയിക്കുകയാണ്. ഈ കോവിഡ് കാലത്ത് കുട്ടികളിലും ഗർഭിണികളിലും കോവിഡ് ഉണ്ടാക്കാവുന്ന മാറ്റങ്ങളെ കുറിച്ച് അല്ലെങ്കിൽ ആ കോവിഡ് രോഗബാധയെ കുറിച്ചുള്ള ആധികാരികമായിട്ടുള്ള പഠനങ്ങളും ജേർണലുകളും ഒക്കെ ഇനിയും പ്രസിദ്ധീകരിക്കേണ്ടിയിരിക്കുന്നു. ഈ രീതിയിലുള്ള ഒരു അക്കാഡമിക് ചർച്ച നമ്മുടെ സംസ്ഥാനത്ത് നടത്തുവാൻ അങ്ങനെ ഒരു ആശയം ഉണ്ടായി എന്നുള്ളതും അതിനു വേണ്ടിയിട്ടുള്ള പരിശ്രമം ഉണ്ടായി എന്നുള്ളതും അത് സംഘടിപ്പിക്കുന്നു എന്നുള്ളതും വളരെ സന്തോഷമുള്ള ഒരു കാര്യമാണ്. ആദരണീയനായ മുഖ്യമന്ത്രി ഇവിടെ സൂചിപ്പിക്കുകയുണ്ടായി, നമ്മൾ 2ാം തരംഗത്തിലൂടെ കടന്നു പോവുകയാണ്. കേരളത്തെ സംബന്ധിച്ചിടത്തോളം 2ാം തരംഗം ഇന്ത്യയിൽ മറ്റ് ഭാഗങ്ങളിൽ 2ാം തരംഗം ആരംഭിച്ചതിന് ശേഷമാണ് ഏപ്രിൽ മാസം പകുതിയോടുകൂടി കേരളത്തിൽ 2ാം തരംഗം ആരംഭിച്ചത്. നമ്മുടെ 2ാം തരംഗത്തിലെ ഒരു പീക്ക് നമുക്കുണ്ടായത് മെയ് മാസം 12-ാം തീയതിയാണ്. 43,500ഓളം രോഗികൾ കേരളത്തിൽ ഉണ്ടായി. ഈ വേവിന്റെ ഒരു പ്ലാറ്റോയിലൂടെയാണ് നമ്മൾ കടന്നുപോയത്. കേരളത്തെ സംബന്ധിച്ചിടത്തോളം അതൊരു എക്സ്പെക്റ്റഡ് ആയിട്ടുള്ള ഒരു ഫേസ് ആയിരുന്നു. കാരണം ഇപ്പോ സെറോ പ്രിവലൻസ് സ്റ്റഡി പുറത്തു വന്നപ്പോൾ, ദേശീയ തലത്തിൽ നടത്തിയ സെറോ പ്രിവലൻസ് സ്റ്റഡി പുറത്തു വന്നപ്പോൾ ഏതാണ്ട് 42% ആളുകൾക്കാണ് കേരളത്തിൽ രോഗബാധ ഉണ്ടായത്, അല്ലെങ്കിൽ ആ രീതിയിൽ ആന്റിബോഡി അവരിൽ ഉത്പാദിപ്പിക്കപ്പെട്ടത്, അങ്ങനെ രോഗപ്രതിരോധ ശേഷിയുള്ളത് എന്നുള്ളതാണ് കണ്ടെത്തിയത്. അപ്പൊ സസെപ്റ്റബിൾ ആയിട്ടുള്ള ആളുകളുടെ എണ്ണം കേരളത്തിൽ വളരെ കൂടുതലാണ്. അതുകൊണ്ട് വരാനുള്ള സാധ്യതയും നമുക്ക് വളരെ കൂടുതലാണ്. ഒരു മൂന്നാം തരംഗം ഉണ്ടാവുകയാണ് ആരംഭിച്ചിട്ടില്ലാത്ത ജനവിഭാഗമായിട്ടുള്ള 18 വയസ്സിൽ താഴെയുള്ള നമ്മുടെ കുഞ്ഞുങ്ങൾക്ക് രോഗം വരാനുള്ള സാധ്യത വളരെ കൂടുതലാണ് എന്നുള്ളതാണ് നമ്മൾ കാണുന്നത്. ഇതിനോടനുബന്ധിച്ച് ആരോഗ്യ വകുപ്പ് വളരെ സൂക്ഷ്മമായിട്ടുള്ള നിരീക്ഷണം ഇതുമായി ബന്ധപ്പെട്ട് നടത്തുന്നുണ്ട്. പ്രത്യേകിച്ച് നമ്മൾ മൊത്തം നടത്തുന്ന ടെസ്റ്റുകളിൽ പ്രായം തിരിച്ച് തന്നെ 18 വയസ്സിന് താഴെയുള്ള കുഞ്ഞുങ്ങൾ എത്രത്തോളം അഫക്റ്റഡ് ആയി എന്നുള്ളത് സംബന്ധിച്ച ഒരു സ്റ്റഡി തന്നെ നമ്മൾ നടത്തുന്നതിന് ശ്രമിക്കുന്നുണ്ട്. ഈ കഴിഞ്ഞ കുറച്ച് ദിവസങ്ങളായി തുടർച്ചയായി നമ്മളുടെ റിപ്പോർട്ടുകളിൽ ആ ഒരു കാര്യം കൂടി ഉൾപ്പെടുത്തുന്നതിന് വേണ്ടി നമ്മൾ ശ്രമിച്ചിട്ടുണ്ട്. ഈ ഒരു ഘട്ടത്തിൽ നമ്മൾ കണ്ട മറ്റൊരു കാര്യം, ഗർഭിണികളായിട്ടുള്ള സ്ത്രീകൾക്ക് കോവിഡ് വരുമ്പോൾ അവരുടെ സാധാരണ നമുക്കറിയാം കേരളത്തിൽ ഗർഭിണികളുടെ മരണനിരക്ക് വളരെ കുറവാണ്, ശിശു മരണനിരക്കൊക്കെ വളരെ കുറവാണ്. പക്ഷെ ഈ കോവിഡ് കാലത്ത് നമ്മൾ കണ്ടത് ഗർഭിണികളായിട്ടുള്ളവർക്ക് കോവിഡ് ബാധിക്കുമ്പോൾ അവരിൽ പലരും മരണപ്പെടുന്നു എന്നുള്ളതാണ്. അതുകൊണ്ടാണ് മാതൃകവചം എന്ന ഒരു പ്രത്യേക പരിപാടിയിലൂടെ എല്ലാ ഗർഭിണികളും വാക്സിൻ എടുക്കണമെന്നുള്ള ഒരു നിർബന്ധമായി തന്നെ ആ രീതിയിലുള്ള ഒരു ആഹ്വാനം നമ്മൾ കൊടുക്കുവാൻ ശ്രമിച്ചത് അതുകൊണ്ടാണ്. ഇത് സംബന്ധിച്ച് പല തെറ്റിദ്ധാരണകളും ഉണ്ടായിരുന്നു. 8ാം മാസത്തിൽ വാക്സിൻ എടുക്കാമോ, 9ാം മാസത്തിൽ വാക്സിൻ എടുക്കാമോ, ഇപ്പൊ ഡെലിവറി ആവുകയല്ലേ, അത് കഴിഞ്ഞ് 2ാം ഡോസ് എപ്പോൾ എടുക്കും എന്നൊക്കെ സംബന്ധിച്ചിട്ടുള്ള ആശങ്കകൾ പല ഡോക്ടേഴ്സുമായിട്ടും ഗർഭിണികൾ തന്നെ പങ്കുവച്ച ഒരു സാഹചര്യം ഉണ്ടായിരുന്നു. ഏതായാലും ഇത് സംബന്ധിച്ച് വ്യക്തമായിട്ടുള്ള ഡയറക്ഷൻസോടുകൂടി തന്നെ മാതൃകവചം മുന്നോട്ട് കൊണ്ടുപോകുന്നതിനാണ് നമ്മൾ ശ്രമിക്കുന്നത്. ഇവിടെ കുഞ്ഞുങ്ങളിലെ കോവിഡ് രോഗബാധയുമായി ബന്ധപ്പെട്ട പലപ്പോഴും ഒരു ജലദോഷമോ പനിയോ ഒക്കെ പോലെ നിസ്സാരമാണ് എന്ന് തോന്നുമെങ്കിലും കുഞ്ഞിന്റെ പ്രതിരോധ സംവിധാനങ്ങളിൽ ഈ വൈറസ് ഉണ്ടാക്കുന്ന ആഘാതങ്ങൾ, അത് ദോഷകരമായിട്ടുള്ള ഫലങ്ങൾ ഉണ്ടാക്കുന്നു എന്നും നമ്മൾ കാണുന്നുണ്ട്. അതുകൊണ്ടാണ് ബഹുമാനപ്പെട്ട CM ഇവിടെ സൂചിപ്പിച്ച മൾട്ടി സിസ്റ്റം ഇൻഫ്ലമേറ്ററി സിൻഡ്രോം, അതായത് നമ്മുടെ ഇതിനോടനുബന്ധിച്ച് പല കാര്യങ്ങളും, ഹൃദയവൈകല്യങ്ങൾ, വൃക്കവൈകല്യങ്ങൾ, ശ്വാസകോശ രോഗങ്ങൾ, നാഡീഞരമ്പുമായി ബന്ധപ്പെട്ട രോഗങ്ങളൊക്കെ കാണുന്നു എന്നുള്ളതാണ് ഈ ഒരു നമുക്ക് നമ്മുടെ കയ്യിലുള്ള ഒരു ഡേറ്റ വെച്ച് നമുക്ക് മനസ്സിലാവുന്ന കാര്യം. ഏതായാലും ഈ അവസരത്തിൽ അതുപോലെ കോൺഫറൻസിൽ ഉണ്ടാകുന്ന നിർദ്ദേശങ്ങൾ, ഇവിടെ ചർച്ച ചെയ്യപ്പെടുന്ന വിഷയങ്ങൾ, അത് സംസ്ഥാന സർക്കാരിന്റെ ശ്രദ്ധയിലേക്ക് ഇത് കൊണ്ടുവരികയാണെങ്കിൽ നിശ്ചയമായിട്ടും അത് സർക്കാരിനെയും ആരോഗ്യ വകുപ്പിനെ സംബന്ധിച്ചിടത്തോളം വളരെയധികം സഹായകരമായിരിക്കും എന്നുള്ളതാണ് കരുതുന്നത്. ഈ അവസരത്തിൽ നമ്മൾ പീഡിയാട്രിക് കെയർ സംബന്ധിച്ച് ഈ ഒരു നമുക്കറിയാം 1.5 വർഷത്തിലധികമായി നമ്മുടെ ആരോഗ്യ പ്രവർത്തകർ കോവിഡിന്റെ പ്രതിരോധ പ്രവർത്തനങ്ങളിൽ വളരെ സജീവമായി ഇടപെടുകയാണ്. അതുകൊണ്ട് തന്നെ നമ്മുടെ എല്ലാ ഇൻസ്റ്റിറ്റ്യൂഷൻസിലും, DMEയുടെ മെഡിക്കൽ എഡ്യൂക്കേഷന്റെ DMEയുടെ കീഴിലുള്ള ഇൻസ്റ്റിറ്റ്യൂഷൻസിലും, അതുപോലെ തന്നെ DHSന്റെ കീഴിലുള്ള ആശുപത്രികളിലെയും ആരോഗ്യ പ്രവർത്തകർക്കായി ട്രെയിനിങ്ങും മറ്റും നൽകുന്നതിന് നമ്മൾ ഇതിനോടകം ആരംഭിച്ചിട്ടുണ്ട്. അതുപോലെ പീഡിയാട്രിക് കെയർ ഫെസിലിറ്റീസ് കുറച്ചുകൂടി ശക്തിപ്പെടുത്തുന്നതിന് വേണ്ടിയിട്ടുള്ള പീഡിയാട്രിക് ICU ട്രെയിനിങ് ഉൾപ്പെടെ നടത്തുന്നതിന് വേണ്ടിയിട്ടുള്ള ശ്രമങ്ങൾ നമ്മൾ നടത്തുന്നുണ്ട്. ഈ ഒരു കാര്യം, രണ്ടു കാര്യം കൂടെ ഈ അവസരത്തിൽ പറയണമെന്ന് ഞാൻ ആഗ്രഹിക്കുകയാണ്. നമ്മുടെ സംസ്ഥാനം കേരളം ശിശു സൗഹൃദ സംസ്ഥാനമായി വർഷങ്ങൾക്ക് മുമ്പ് പ്രഖ്യാപിക്കപ്പെട്ട ഒരു സംസ്ഥാനമാണ്. പക്ഷേ വളരെ റീസെന്റ് ആയി കഴിഞ്ഞ ഒരു 2-3 വർഷത്തെ ഒരു ഡേറ്റ പരിശോധിക്കുമ്പോൾ കുഞ്ഞുങ്ങൾക്ക് അമ്മയുടെ മുലപ്പാൽ നൽകുന്നതിൽ കേരളം പിന്നോട്ട് പോകുന്നു എന്നുള്ളതാണ് നമ്മൾ കാണുന്നത്. അതിന് പല കാരണങ്ങളുണ്ടാകാം. അതായത് നമ്മുടെ തൊഴിലിടങ്ങളിൽ ജോലി ചെയ്യുന്ന സ്ത്രീകളെ സംബന്ധിച്ചിടത്തോളം അവർക്ക് അമ്മയ്ക്കും കുഞ്ഞിനും സൗഹൃദമല്ലാത്ത തൊഴിലന്തരീക്ഷങ്ങൾ. ഇപ്പോൾ നമുക്കറിയാം നമ്മുടെ IT മേഖലകളിലൊക്കെ ധാരാളം ചെറുപ്പക്കാരായിട്ടുള്ള സ്ത്രീകൾ ജോലി ചെയ്യുന്നുണ്ട്, ധാരാളം പെൺകുട്ടികൾ ജോലി ചെയ്യുന്നുണ്ട്. ഒരു 6 മാസത്തെ പ്രസവ കാലാവധി ഉണ്ടെങ്കിൽ പോലും പലപ്പോഴും ഇവർക്ക് വീണ്ടും ജോലിയിലേക്ക് തിരിച്ചു പോയില്ല എങ്കിൽ ജോലി നഷ്ടപ്പെടുന്ന ഒരു സാഹചര്യം. ജോലി ചെയ്യുമ്പോഴും കുഞ്ഞിനെ ഫീഡ് ചെയ്യാൻ കഴിയാത്ത ഒരു അന്തരീക്ഷം. അപ്പം മദർ ചൈൽഡ് ഫ്രണ്ട്ലി അല്ലാത്ത ഒരു സാമൂഹിക നാട്ടിൽ നിലനിൽക്കുന്നുണ്ട് എന്നുള്ളതൊരു യാഥാർത്ഥ്യമാണ്. അതിലേക്കൊരു ഇടപെടൽ നടത്തുന്നത് ഈ ഓഗസ്റ്റ് ആദ്യ നമ്മുടെ ഹോസ്പിറ്റൽസ് എല്ലാം മദർ ചൈൽഡ് യാത്ര ചെയ്യുന്ന സ്ത്രീകളെ സംബന്ധിച്ചിടത്തോളം പാൽ നൽകുന്നതിന് വേണ്ടിയിട്ടുള്ള ഒരു ഇതിൽ ഇൻസ്റ്റിറ്റ്യൂഷൻസിനെ മദർ ചൈൽഡ് ഫ്രണ്ട്ലി ആക്കുന്നതിനൊപ്പം തന്നെ നമ്മുടെ പൊതു ഇടങ്ങൾ, നമ്മുടെ തൊഴിലിന്റെ വിവിധ വകുപ്പുകളെ ഏകോപിപ്പിച്ചുകൊണ്ടുള്ള ഒരു വലിയ പരിശ്രമത്തിലേക്ക് നമ്മൾ കടക്കുകയാണ്. അതോടൊപ്പം തന്നെ ഈ ഇപ്പൊ വാക്സിനേഷന്റെ കോവിഡുമായി ബന്ധപ്പെട്ട വാക്സിനേഷന്റെ കാര്യം നമ്മൾ പറഞ്ഞു. പക്ഷേ കേരളത്തെ സംബന്ധിച്ചിടത്തോളം ചിലയിടങ്ങളിലെങ്കിലും ഈ കുഞ്ഞുങ്ങൾക്ക് വാക്സിൻ നൽകുന്നതിൽ ഒരു ചെറിയ പിന്നോട്ട് പോക്കലുകൾ ഉണ്ടോ എന്നുള്ള പരിശോധന കൂടി ഇതിന്റെ ഭാഗമായി നമ്മൾ നടത്തുന്നുണ്ട്. ഞാൻ എൻ്റെ വാക്കുകൾ ദീർഘിപ്പിക്കുന്നില്ല. ഈ ഒരു കോൺഫറൻസ് നിശ്ചയമായിട്ടും നമുക്ക് മുന്നോട്ടുള്ള പ്രവർത്തനങ്ങൾക്ക് ദീപമാകട്ടെ എന്ന് ഞാൻ ആഗ്രഹിക്കുകയാണ്. പ്രത്യേകിച്ച് ഇത് കോവിഡ് റിലേറ്റഡ് ആയിട്ടുള്ള ഒരു കോൺഫറൻസ് ആണ് എന്നുള്ളത് കൊണ്ട് കൂടി അതിന് വളരെയേറെ പ്രാധാന്യമുണ്ട്. നാഷണൽ പീഡിയാട്രിക് കോവിഡ് കോൺഫറൻസ് ആണ് എന്നുള്ളത് കൂടി വളരെയധികം പ്രാധാന്യമുണ്ട്. എല്ലാവിധമായിട്ടുള്ള ആശംസകളും വളരെ ക്രിയാത്മകമായിട്ടുള്ള ചർച്ചകളും ഉണ്ടാകട്ടെ എന്ന് ആശംസിച്ചുകൊണ്ട് എന്റെ വാക്കുകൾ ചുരുക്കുന്നു. നന്ദി, നമസ്കാരം.
താങ്ക് യു മാഡം. സാന്ദർഭികമായിട്ട് ഒരു കാര്യം മാഡത്തോട് പറയുകയാണ്. മാഡം സൂചിപ്പിച്ചതുപോലെ ഈ ഒരു കോൺഫറൻസിന്റെ സയന്റിഫിക് ഡെലിബറേഷന്റെ ഒരു റിപ്പോർട്ട് ഞങ്ങൾ ഗവൺമെന്റിലേക്കും മാഡത്തിനും അയക്കുന്നതാണ്. ഒപ്പം തന്നെ ശിശു സൗഹൃദ കേരളത്തെ പറ്റി മാഡം സൂചിപ്പിച്ചു. ഇന്ത്യൻ അക്കാദമി ഓഫ് പീഡിയാട്രിക്സ് പറഞ്ഞാല് ശിശുരോഗ വിദഗ്ധരുടെ അഖിലേന്ത്യാ സംഘടനയാണ്. അപ്പൊ ഞങ്ങള് ബേബി ആൻഡ് മദർ ഫ്രണ്ട്ലി ഹോസ്പിറ്റൽ എന്ന് പറഞ്ഞൊരു ഇനീഷ്യേറ്റീവ് തുടങ്ങിയിട്ടുണ്ട്. മാഡത്തിനെ സംഘടനാ നേതാക്കള് കാണുന്നതാണ്. അപ്പൊ അത് ഗവൺമെന്റിനും കൂടി അപ്രൂവൽ അതിന് ആവശ്യമുണ്ട്. ഒപ്പം തന്നെ ഗവൺമെന്റ് 5 years പ്ലാനിന് വേണ്ടി പ്രപ്പോസൽസ് ക്ഷണിച്ച ഈ സമയത്ത് ഞങ്ങൾ പ്രിൻസിപ്പലിന്റെ നേതൃത്വത്തിൽ കോഴിക്കോട് ശിശുരോഗ വിഭാഗത്തെ പറ്റി പറയുമ്പോൾ കേരളത്തിലെ ഏറ്റവും അധികം പ്രസവം നടക്കുന്ന ആശുപത്രിയാണ് ഞങ്ങളത്. അപ്പൊ ആ ഡെവലപ്മെന്റ് പ്ലാനുകൾ ഗവൺമെന്റിന് സമർപ്പിക്കുന്നുണ്ട്. അനുഭാവപൂർവമായ പരിഗണന ഉണ്ടാവണമെന്ന് അഭ്യർത്ഥിക്കുകയാണ്. താങ്ക് യു മാഡം.
നിശ്ചയമായിട്ട് താങ്ക് യു വെരി മച്ച്.
ഈ ചടങ്ങിൽ മുഖ്യാതിഥിയായി എത്തുന്നത് നമ്മുടെ പ്രിയങ്കരനായ MLA തോട്ടത്തിൽ രവീന്ദ്രൻ സാറാണ്. മുൻ മേയർ കൂടിയായ തോട്ടത്തിൽ രവീന്ദ്രൻ സാറെ സ്നേഹപൂർവ്വം ക്ഷണിക്കുന്നു. രവീന്ദ്രൻ സാർ. രവീന്ദ്രൻ സാർ അൺമ്യൂട്ട് ചെയ്യണം. MLA സാർ.
ഹലോ, കേൾക്കുന്നുണ്ടോ?
കേൾക്കുന്നുണ്ട് സാർ, പറയാം.
സോറിയേ. കേരളത്തിന്റെ ആദരണീയായ ആരോഗ്യ വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ്, എത്രയും ബഹുമാന്യനായ നമ്മുടെ മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ, ഈ പരിപാടിയിൽ സംബന്ധിക്കുന്ന പ്രിൻസിപ്പൽ തുടങ്ങി നമ്മുടെ പ്രഗത്ഭരായിട്ടുള്ള ഡോക്ടർമാരെ, സുഹൃത്തുക്കളെ, വലിയ സന്തോഷമുണ്ട്. കോഴിക്കോട് മെഡിക്കൽ കോളേജിനെ പറ്റി പറയുമ്പോൾ നമുക്കൊക്കെ അഭിമാനമുള്ള ഒരു കോളേജാണ്. ഒരുപക്ഷെ കേരളത്തിൽ എന്നല്ല, ഇന്ത്യയിൽ തന്നെ ഏറ്റവും കൂടുതൽ പ്രസവം നടക്കുന്ന ഒരു ആശുപത്രി. നവജാത ശിശുക്കളെ സംരക്ഷിക്കുന്ന, പരിപാലിക്കുന്ന ഏറ്റവും വലിയ ആശുപത്രികളിലൊന്ന്, പറയാതിരിക്കാൻ വയ്യ. അത്രയധികം ഉൾക്കൊള്ളാൻ കഴിയുന്നതിന് അപ്പുറത്തേക്കുള്ള ചികിത്സ നടത്തിക്കൊണ്ടിരിക്കുന്ന ഏറ്റവും പ്രഗത്ഭമായ ഒരു ഇൻസ്റ്റിറ്റ്യൂട്ടാണ് അത്. സംശയമൊന്നുമില്ല, കാര്യം എല്ലാവരും അംഗീകരിക്കപ്പെടുന്നതാണ്. അത്തരം ഇൻസ്റ്റിറ്റ്യൂട്ടിൽ വെച്ചിട്ടാണ് ഇന്നിപ്പം നമുക്കറിയാം ലോകം മുഴുവൻ ഉണ്ടാക്കിയിട്ടുള്ള പ്രതിസന്ധിയെക്കുറിച്ച്, സമസ്ത മേഖലകളെയും തകർത്തിട്ടുള്ള, ഒരുപക്ഷെ ലോകത്തിൽ ഇതുവരെ ഇത്തരം ഒരു സംഭവം ഉണ്ടായിട്ടുണ്ടോ എന്ന് എനിക്ക് തോന്നുന്നില്ല. അത്രയും അധികം പ്രയാസങ്ങൾ സൃഷ്ടിച്ചിട്ടുള്ള ഒരു മഹാമാരിയാണ് COVID-19 എന്ന് നമുക്കൊക്കെ അറിയാം. എങ്ങനെ നമുക്കതിനെ പ്രതിരോധിക്കാൻ വേണ്ടി സാധിക്കും? അത് ലോകം മുഴുവൻ ചർച്ച ചെയ്തുകൊണ്ടിരിക്കുന്ന വിവിധ മേഖലകളിൽ ഏറ്റവും പ്രഗത്ഭരായിട്ടുള്ള നിരവധി പേർ ശ്രമിച്ചുകൊണ്ടിരിക്കുന്ന ഒന്നാണെന്നും നമുക്ക് കാണാൻ വേണ്ടി കഴിയും. ഒരുപക്ഷെ ലോകത്തിൽ ഇത്രയധികം മരണങ്ങൾ നടന്ന മറ്റൊന്നുണ്ടോ എന്ന് തോന്നുന്നില്ല. അത്രയധികം മരണങ്ങൾ സംഭവിച്ചിട്ടുണ്ട്. നമുക്ക് തന്നെ നമ്മുടെ ഉറ്റവരും ഉടയവരും നമ്മളെ ബന്ധുക്കളും ഒക്കെ സ്നേഹിതന്മാരും ഒക്കെ മരണപ്പെട്ടു പോയിട്ടില്ല. എന്തൊക്കെ പ്രതിസന്ധികളാണ് ഇതിന് സൃഷ്ടിക്കുക എന്ന് തന്നെ നമുക്ക് പ്രവചിക്കാൻ പറ്റാത്ത ഒരു അവസ്ഥയാണ്. അപ്പൊ അതിലാണ് ഈ ഒരു അവസരത്തിലാണ് മെഡിക്കൽ കോളേജും ഇന്ത്യൻ അക്കാഡമിക് പീഡിയാട്രിഷ്യന്റെ ചേർന്നുകൊണ്ട് വലിയൊരു പരിപാടി ഇവിടെ സെമിനാർ നടത്തുന്നത്. കുട്ടികളുടെ കോവിഡ് ദേശീയ സെമിനാറാണ് നടത്തുന്നത്. പ്രഗത്ഭരായിട്ടുള്ള ഒട്ടനവധി ഡോക്ടർമാരുടെ ഇതുമായിട്ട് സംബന്ധിക്കുന്നുണ്ട്. തീർച്ചയായിട്ടും നമുക്ക് ചർച്ച ചെയ്യപ്പെടേണ്ടുന്ന നമ്മുടെ ഭാവിയാണ് ഈ കുട്ടികൾ എന്ന് നമുക്ക് ഒരിക്കലും മറക്കാൻ വേണ്ടി പാടില്ല. നമ്മളെ ഭാവിയിൽ നമ്മളെ വലിയ പ്രതീക്ഷകളാണ് അവർ. അവർക്ക് ഒരു തകരാറും വരാതെ എല്ലാ വിഭാഗം ആളുകൾക്കും വന്നുകൊണ്ടിരിക്കുന്ന ഒരു അസുഖം. അപ്പൊ എങ്ങനെയൊക്കെ അതിനെ നമുക്ക് നിയന്ത്രിക്കാൻ സാധിക്കും, എന്തൊക്കെ തരത്തിൽ പ്രതിരോധിക്കാൻ സാധിക്കുമെന്നാണ് ചർച്ച ചെയ്യപ്പെടാനുള്ളത്. തീർച്ചയായിട്ടും വലിയ സന്തോഷമുണ്ട് നമ്മുടെ ഡോക്ടർമാർക്ക്, ഇന്ന് ഈ മേഖലയിൽ പ്രവർത്തിക്കുന്ന പ്രഗത്ഭരായിട്ടുള്ള ആളുകൾക്ക് ഒരുപാട് ഉത്തരം. കാരണം ചികിത്സിച്ചു കൊണ്ടിരിക്കുമ്പോൾ നമ്മൾ പഠിച്ചതിൽ നിന്ന് വ്യത്യസ്തമായിട്ട് പല അനുഭവങ്ങളും പലർക്കും ഉണ്ടാവും. അപ്പൊ അതൊക്കെ ഇവിടെ പങ്കുവെക്കാൻ വേണ്ടി സാധിക്കും. അതിലൂടെ ഉരുത്തിരിയുന്ന നല്ല വശങ്ങൾ മുഴുവൻ സ്വീകരിച്ചുകൊണ്ട് നമുക്ക് എങ്ങനെ നമുക്ക് ഈ ഒരു മഹാമാരിയെ തടുത്തു നിർത്താൻ കഴിയുമെന്ന് നോക്കാവുന്ന ഒരു സെമിനാറാണിത്. എല്ലാ വിജയങ്ങളും ആശംസിക്കുന്നു. ഇത് ഒരു നമ്മുടെ ലോകത്തിന് തന്നെ ശ്രദ്ധ ആകർഷിക്കുന്ന നിലയിലുള്ള ഒരു വലിയ സെമിനാറായിട്ട് ഇത് ഉയർന്നു വരട്ടെ. ഒരുപാട് മാർഗനിർദ്ദേശങ്ങൾ ഇതിലൂടെ ഉരുത്തിരിഞ്ഞു വരട്ടെ എന്ന് ആത്മാർത്ഥമായി പ്രാർത്ഥിച്ചുകൊണ്ട് ഇതിൽ പങ്കെടുക്കുന്ന എല്ലാവരെയും പ്രത്യേകം ആശംസിച്ചുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ.
Thank you, Ravindra sir, for your inspiring speech. Now I invite Dr. Ramesh Kumar, National President, Indian Academy of Pediatrics, for speech. He is one of the guest of honor in today's function. Dr. Ramesh, over to you.
Thank you, Dr. Ashraf. Most respected Chief Minister of Kerala, Pinarayi Vijayan, Honorable Health Minister and President of the meeting, Ms. Veena George, Chief Guest Sri Thotathil Ravindran, President of IAP Kerala, Dr. Jayaraman, the office bearers of IAP Kozhikode, IAP Kerala and the NHM, and my dear beloved friends. Greetings from the Central Office of Indian Academy of Pediatrics. And we are most privileged to have our Honorable Chief Minister as the chief guest for the day, where we are having the National Pediatric Conference organized by Department of Pediatrics, Medical College Kozhikode, National Health Mission, as well as Indian Academy of Pediatrics Kozhikode, as well as Kerala State Branch. Congratulations to the team for organizing an array of topics which has given a total insight into the present status of pediatric COVID, as well as the newer thoughts where we can take up or equip our members, their capacity building to handle COVID cases in a better manner. And I'm so happy that our Chief Minister as well as our Health Minister has mentioned regarding the challenges faced by the pediatric population here. And we are so happy that our state has been the role model for all the healthcare programs. And we have been in the forefront of immunization, even in the elimination of TB programs. And right now we are in the breastfeeding hospital initiative, where we make up the importance of breastfeeding, and we are taking up the task to declare hospitals as mother and baby friendly. And as our Health Minister has noted, Indian Academy of Pediatrics will be given the due recognition, as well as our advocacy and our initiatives will be taken up by right earnest by the government. And we are so thankful to the Health Minister as well as the CM for all the support given to the child welfare in this country, in this state, as well as the initiatives from Indian Academy of Pediatrics. And the million-dollar question still remains, when to open the schools. We as a country is witnessing a significant drop in COVID-19 cases in other states. I mean, the IAP expert committee is now veering to the guidelines of staggered or reopening of schools, especially in states which have now a positivity of less than 5. And most of the schools in the country have been shut since March 2020 to break the transmission of coronavirus. So what our expert committee feels that the schools can be reopened in places where COVID cases are falling and positivity rates are less than 5%. And mostly in focused districts, for districts that are seeing less virus circulation. So we should explore the option of bringing back children to schools on alternate days or look for other ways of a staggered reopening in the states or where the districts where the surveillance has gone down less than 5%. And if at any time the surveillance incites the spread of infection, classes can be immediately suspended. For us, for our state, we are still having we started our second wave a little late, and still we are trying to manage the test positivity rates and as well as trying to control. But as Madam Veena George has rightly suggested, 43%, 45% in Kerala. Across the country, it is 67%. So with the vaccination, maybe with the zero prevalence going up to around more than 70%, we may be able to push back, consider the reopening of schools in our state also in a different manner. So I am so happy that the deliberations here will turn out to be quite fruitful, and all our our friends across the country have joined for this to participate in the deliberations here, and we have got the experts from the national and the international arena to equip us better on the thoughts regarding COVID and update the status. So once again, my congratulations to the team, especially Dr. Ashraf, Dr. Ajit, Dr. Mohandas, Dr. Ajay, and Dr. Jayaraman, and Dr. Joni, and as well as all the office bearers of Kozhikode IAP, as well as state IAP for organizing the CME, and all my dear friends in Department of Pediatrics, IMCS Kozhikode for taking up all the strains to make up a great show here on the COVID front. Thank you very much and wish you all the best.
Thank you, Dr. Ramesh. Now I invite Dr. Jayaraman TP, President, Indian Academy of Pediatrics, Kerala, for felicitation. He is another guest of honor in this meeting. Over to you, Dr. Jayaraman.
Good morning. Honorable Chief Minister of Kerala, Comrade Pinarayi Vijayan, Health Minister Madam Veena George, Organizing Chairman of the conference, Dr. Ajit Kumar, Chief Guest of the day, Ms. Thotathil Ravindran, MLA, National President, Dr. Ramesh Kumar, Dr. Johnny Sebastian, Secretary of IAP Kerala, Dr. Naveen, DPM, Dr. Geeta, Principal of Calicut Medical College, and my good friend and classmate, Dr. Rajendran, all the other dignitaries on the platform. I am very happy to participate in this National COVID Conference organized by Institute of Maternal and Child Health, Calicut, which is my parent department, from where I did my initiation into Department of Pediatrics. As you all know, COVID-19 is a dynamic process now, and this disease is evolving, and understanding the disease is also evolving. And it is so important to have such conferences and continuing medical education programs, especially. And I'm very happy that you have covered almost all topics, right from the epidemiology, the immunology, the clinical features, management aspects, as well as the complications pertaining to children. And also you have stressed on the indirect effects, like especially the lecture by Dr. Tanu Singhal was very thought-provoking, communicating detailing the indirect effects of COVID-19 on children. And again, you have included another important area, that is the psychosocial dimensions of COVID-19 in the coming sessions. And I'm so happy about this conference, and I thank you for giving me this opportunity as to participate in this event as a guest of honor. And I'm sure this will be an important event in the academic calendar of Indian Academy of Pediatrics of this year. Also, I feel very happy that our Honorable Health Minister has given a very encouraging words to our program on maternal and baby-friendly hospital initiative, which we are all stressing now, and we are coming out with recertification by the first week of August, when we are going to celebrate the breastfeeding week. And in this regard, I like to mention that yesterday we had a very good meeting at the governmental level, the Principal Secretary of Health, and I am thankful to the government of Kerala and Madam Veena George and all others for offering us the wholehearted support for the implementation of this program and to complete the process and to start the process of recertification of hospitals in Kerala as mother and baby friendly hospitals. Thank you for this opportunity, and once again I wish the very best for this program. Thank you all. Thank you all.
Thank you, Dr. Jayaraman. Now it is the time for felicitation. We are having 4 felicitations. So I request all, please keep the time. First I invite Dr. Srikumar, Dynamic Superintendent of Institute of Maternal and Child Health, Medical College, Kozhikode, for felicitation. Over to you, Dr. Srikumar.
Good morning to all. കേരളത്തിന്റെ ആരോഗ്യ രംഗത്ത് മാത്രമല്ല സമസ്ത മേഖലകളിലും നേരിട്ട് ശ്രദ്ധ ചെലുത്തി മാതൃകകൾ സൃഷ്ടിക്കുന്ന ബഹുമാനപ്പെട്ട കേരള മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ സർ, ആരോഗ്യരംഗത്ത് ഈ പരീക്ഷണ ഘട്ടത്തിലും നമുക്ക് മികവുറ്റ നേതൃത്വം നൽകിക്കൊണ്ടിരിക്കുന്ന ബഹുമാനപ്പെട്ട ആരോഗ്യ വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് മാഡം, മെഡിക്കൽ കോളേജിന്റെ പ്രവർത്തനങ്ങൾ അതിൽ എപ്പോഴും നമ്മളോടൊപ്പമുള്ള ബഹുമാനപ്പെട്ട MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ സർ, ഈ ചടങ്ങിൽ പങ്കെടുക്കുന്ന മറ്റ് വിശിഷ്ട വ്യക്തികളെ, പ്രിയമുള്ളവരെ, കോഴിക്കോട് മെഡിക്കൽ കോളേജ് മാതൃശിശു സംരക്ഷണ കേന്ദ്രത്തിൽ പീഡിയാട്രിക്സ് വിഭാഗത്തിന്റെ നേതൃത്വത്തിൽ നാഷണൽ പീഡിയാട്രിക് കോവിഡ് എന്ന തുടർ വിദ്യാഭ്യാസ പരിപാടിയുടെ ഉദ്ഘാടനം ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രി നിർവഹിച്ചിരിക്കുകയാണ്. കോവിഡിന്റെ 3ാം തരംഗം കുട്ടികളിൽ കൂടുതൽ ആരോഗ്യ പ്രശ്നങ്ങൾ ഉണ്ടാക്കിയേക്കാം എന്ന നിരീക്ഷണത്തിനിടയിൽ ഏറെ പ്രാധാന്യമുള്ള ഒരു വിഷയമാണ് നമ്മളിവിടെ ഇന്ന് ചർച്ച ചെയ്യുന്നത്. മലബാറിലെ ഗവൺമെന്റ് മേഖലയിലുള്ള ഏക ത്രിതല ഹോസ്പിറ്റൽ എന്ന നിലയിൽ നമ്മൾ കുട്ടികൾക്കും ഗർഭിണികൾക്കും കോവിഡ് ചികിത്സയോടൊപ്പം തന്നെ നോൺ കോവിഡ് ചികിത്സകളും ഏതാണ്ട് പൂർണ്ണ തോതിൽ നടത്തിക്കൊണ്ടിരിക്കുന്നു. അതുപോലെ തന്നെ ഗവൺമെന്റിന്റെ തീരുമാനപ്രകാരം കോവിഡ് രോഗികൾക്ക് നമ്മൾ സൗജന്യ ചികിത്സയും അതേപോലെ സൗജന്യ ഭക്ഷണവും ഉറപ്പുവരുത്തുന്നുമുണ്ട്. ഇതിനോടൊപ്പം തന്നെ മെറ്റേണൽ മോർട്ടാലിറ്റി, ഇൻഫന്റ് മോർട്ടാലിറ്റി തുടങ്ങിയ ആരോഗ്യ സൂചികകൾ അത് മെയിൻറ്റെയിൻ ചെയ്യുന്നതിന് നമ്മുടെ ജീവനക്കാരുടെ കൂട്ടായ പ്രവർത്തനം കൊണ്ട് കഴിയുന്നുണ്ട് എന്നുള്ളതും എടുത്ത് പറയേണ്ടതാണ്. നമ്മുടെ ഇത്തരം നേട്ടങ്ങൾ കൂടി ചർച്ച ചെയ്യപ്പെടുന്ന ഈ CME പരിപാടിക്ക് എല്ലാവിധ ആശംസകളും നേരുന്നു. ഒപ്പം ഈ പ്രോഗ്രാമിന്റെ സംഘാടകരെ അനുമോദിക്കുന്നതിന് കൂടി ഞാൻ ഈ അവസരം വിനിയോഗിക്കുകയാണ്. ഒരിക്കൽ കൂടി എല്ലാ ആശംസകളും. Thank you. Thank you.
Thank you, Dr. Srikumar, for your nice words. Now I invite Dr. Naveen, District Program Manager, NHM, Kozhikode, a source of support to always to Calicut IAP as well as the department as well as the medical college. Over to you, Dr. Naveen. Support and inspiration. Naveen. Dr. Naveen, you are a co-host now. Yes, okay.
ബഹുമാനപ്പെട്ട കേരള മുഖ്യമന്ത്രി ശ്രീ പിണറായി വിജയൻ സർ, ബഹുമാനപ്പെട്ട ആരോഗ്യമന്ത്രി വീണ മേഡം, IAP ഭാരവാഹികൾ, എൻ്റെ പ്രിയപ്പെട്ട ഗുരുനാഥന്മാരെ, സഹപ്രവർത്തകരെ, എല്ലാവർക്കും അറിയാം, വളരെ ഏറ്റവും കുട്ടികളുടെ ആരോഗ്യം ഒരുപാട് സംശയങ്ങൾക്ക് ഇട നൽകുന്ന ഒരു കാലഘട്ടത്തിലൂടെയാണ് നമ്മൾ കടന്നു പോകുന്നത്. നമ്മുടെ ജില്ലയുടെ ഡാറ്റാസ് തന്നെ എടുത്തു നോക്കിയാൽ ഏപ്രിൽ മുതൽ ഈ ജൂലൈ വരെയുള്ള കണക്കുകൾ ഞങ്ങൾ പരിശോധിച്ച സമയത്ത് കുട്ടികളിൽ കോവിഡ് നിരക്ക് ഏകദേശം ഗ്രോത്ത് റേറ്റ് 50% എബവ് ആണ്. 10 വയസ്സിനു താഴെ 67%, 10 മുതൽ 20 വയസ്സ് വരെ 47% ഇൻക്രീസ് ഏപ്രിൽ മുതൽ ഈ ജൂലൈ വരെയുള്ള മാസങ്ങളിൽ നമ്മൾ കണ്ടിട്ടുണ്ട്. അപ്പൊ അതുകൊണ്ട് തന്നെ ആസ് എ പാർട്ട് ഓഫ് ഡിസ്ട്രിക്ട് അഡ്മിനിസ്ട്രേഷൻ വി ആർ എക്സ്പെക്ടിങ് എ സർജ് ഇൻ മിസ് കേസസ്. Now the cases are low and ICU admissions are less, but we should be prepared for tackling the situation. So we are trying to establish more and more pediatric ICUs and HDUs in IMCH and PMSS5 block, and also in peripheral hospitals.
നമ്മുടെ
ഇങ്ങനത്തെ ഒരു അവസരത്തിൽ നാഷണൽ കോൺഫറൻസ് കണ്ടക്ട് ചെയ്തതിൽ കോഴിക്കോട് IAP-യെ ഞാൻ NHM-ന്റെ ഭാഗത്തു നിന്നും ആരോഗ്യ വകുപ്പിന്റെ ഭാഗത്തു നിന്നും ഹൃദയംഗമായിട്ട് അഭിനന്ദിക്കുന്നു. IAP-യുടെയും ഈ ഒരു നമ്മൾ ഓൾറെഡി ട്രെയിനിങ്സ് എല്ലാം സ്റ്റാർട്ട് ചെയ്തിട്ടുണ്ട്. IMCH വെച്ചുകൊണ്ട് തന്നെ സ്റ്റാഫ് നഴ്സ്, പീഡിയാട്രിക് കെയർ, ICU കെയർ എല്ലാം ട്രെയിനിങ് സ്റ്റാർട്ട് ചെയ്തിട്ടുണ്ട്. സോ we are expecting a huge surge. So this will be beneficial for treating the pediatric population, and all the best. Thank you.
Thank you, Dr. Now I invite Dr. Johnny Sebastian, Dynamic Secretary of IAP Kerala, for felicitation. Over to you, Dr. Johnny.
Good morning, all. Honorable Chief Minister of Kerala, Sri Pinarayi Vijayan sir, Honorable Health Minister, Government of Kerala, Srimati Veena George Madam, Chief Guest of the Day, Sri Thottathil Ravindran sir, MLA, Guest of Honors, IAP National President-elect, Dr. Ramesh Kumar sir, and President of IAP Kerala, Dr. Jayaraman sir, Organizing Chairperson, Professor and HOD, Dr. Ajit Kumar sir, Ashraf sir, Mohandas sir, other dignitaries on this platform, seniors, and my dear friends. At the outset, let me congratulate the organizing team of IAP Calicut, especially the organizing chairperson Ajit sir and organizing secretary Geeta madam, Ashraf sir, Mohandas sir, and Ajay for arranging such a well-structured 2-day National Pediatric Conference with a meticulous selection of topics covering all the aspects of COVID-19 in children and adolescents. That too in view of a possibility of a third wave of COVID pandemic. I wish this webinar all success and all the participants today a great learning experience. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you, Dr. Johnny. Now I invite Dr. Mohandas, President IAP Kozhikode, as well as the Head of the Department, Government Medical College, Idukki, for felicitation. Over to you, Dr. Mohandas.
Respected Honorable Chief Minister, Sri Pinarayi Vijayan sir, Honorable Health Minister Veena George Madam, Thottathil Ravindran sir, Ramesh Kumar sir, Jayaraman sir, other dignitaries. As President of IAP Calicut branch, I am really happy and indebted to the Department of Pediatrics, Government Medical College Calicut, for giving opportunity to be associated with this wonderful conference. And with the combined efforts, I think we will arrive to fruitful solutions in managing the present problem in a better way. Thank you all.
Thank you, Mohandas. The last speech in this session, not the last, it is by Dr. Geeta Govindaraj, the Dynamic Organizing Secretary of this event, actually one of the great pillar of this event. Over to you, Dr. Geeta, for a vote of thanks. Dr. Geeta.
Unmute.
Yeah, am I audible now?
Yeah, you're audible.
Yeah. Most honored Chief Minister Sri Pinarayi Vijayan, Honorable Health Minister Srimati Veena George, our MLA Sri Thottathil Ravindran, dignitaries from the Indian Academy of Pediatrics, our own institution, our beloved principal, Professor V.R. Rajendran, our superintendent, Dr. Sri Kumar, Dr. Naveen from NHM, senior pediatricians and dear friends. On behalf of the organizing team, it's indeed a privilege to deliver the vote of thanks this morning. I consider it a dream come true and a huge motivation for this entire team during these challenging times to have none other than our beloved and honorable Chief Minister to inaugurate this conference. We will always remember your kindness with gratitude, sir. I'm deeply indebted to Honorable Minister of Health and Family Welfare, Srimati Veena George, who found time to grace this occasion. I also place on record my deep sense of gratitude to the chief guest this morning, Sri Thottathil Ravindran, MLA. The Indian Academy of Pediatrics, an organization with enormous social commitment, is represented this morning by the National President-elect, Dr. Ramesh Kumar R., and State President, Dr. T.P. Jayaraman, as well as State Secretary, Dr. Johnny Sebastian. Thank you all for gracing the occasion. Our beloved principal, Professor V.R. Rajendran, has been a tower of support and quiet encouragement. Thank you so much, sir. Our superintendent, Professor C. Sri Kumar, has been leading this COVID effort right from the front for the last 1.5 years. Thank you, sir, for being here with us. I would like to thank all the speakers from across the globe. We have our international speakers, Dr. Sudhir Gupta, founder of Foundation for Primary Immune Deficiency Disorders, USA, who also has accredited our center recently. Dr. Condeno Neto from Brazil, Dr. Kishore Warrior from UK, our own student. And we also have speakers from all across India, Dr. Siddharth Ramji from MAMC Delhi, Dr. Priyankar Pal from ICH Kolkata, Dr. Vinod Skaria, Principal Scientist CSIR IGIB Delhi, who has been in the forefront of organizing a program on primary immune deficiency right here, and Dr. Tanu Singhal from Kokilaben Hospital, Mumbai, and all other speakers from across Kerala. Thank you so much for spending your valuable time and expertise with us. I would like to place on record our gratitude to all the esteemed chairpersons who have been here this morning, who will be with us. And on behalf of NHM, represented by Dr. Naveen, thank you so much. IAP Kozhikode, Dr. Mohandas Nair and Dr. Ajay, President and Secretary, our gratitude to both of you. I would really like to mention the great support from the entire department. All faculty have put in their entire efforts and wholehearted cooperation in making this a reality. I would also like to thank Dr. Vijay Kumar, the President-elect of IAP Kerala 2021, and Professor from GMC Manjeri, and all senior residents and junior residents who were in the forefront of organizing this conference. I'd like to thank our staff, Mr. V.M. Balan, Mrs. Usha Kumari and Mrs. Reena, and Mr. Riaz for technical support, and Alek, our third semester student, for designing the certificates beautifully. I would also like to thank all delegates who have joined us today and those who have presented posters and papers yesterday. Thank you all so much. From all of us, a very big thank you once again. Thanks.
Thank you, Geeta. Now we will move on to scientific session. Over to Dr. Manoj and Dr. Babu Francis to chair the session.
Thanks, sir.
Thank you, Ramesh. Thank you all.
Sir, there's a change in the schedule.
Yeah.
Now we are having announcement of the results for paper and poster presentations conducted yesterday.
Yeah.
Dr. Vinod Kumar and Dr. Rajesh TV, additional professors, Department of Pediatrics, Government Medical College, Kozhikode, to Dr. Rajesh, please announce the results.
Hello. Good morning.
Please go
sir.
for slideshow.
Sir.
Okay.
Actually, please do it from the announcement. Yes.
Yeah.
Okay. So good morning. Happy and privileged to announce the result of free paper presented to us in connection with our National Pediatric Conference. We had total of 12 entries into the free paper session, spread into 3 categories. That is in the faculty group, practicing pediatricians and in the resident group. So all the papers were very good and was judged by Dr. Jayakumar sir from Kochi and Dr. Asma Rahim. They were very much impressed with the way in which the studies were done and the way in which they were presented. Now going to the result. Next slide, please. Out of first, among the faculty group, we had 4 present papers, and the first goes to Dr. Kirti K from Government Medical College, Manjeri. And second prize goes to Dr. Ritu Babasaheb Ambedkar Medical College Hospital, New Delhi. And the third prize goes to Usha Devi, Sri Ramchandra Institute of Higher Education Research, Chennai. Next, among the practicing pediatricians, we had only one entry, and that was presented by Dr. Saeed Sabik, and was a study done in the Shanti Hospital, Omaseri, Kozhikode, guided by Dr. Abdul Latif. Next, we have residents. Among the residents group, out of 7 entries, the first prize goes to Dr. Vinita K. Aniruddhan, Aster Mims, Calicut. Second prize goes to Dr. Aishwarya Danish, TDMC Alapura, and third prize is shared by Dr. Navina S, Government Medical College, Kannur, and Dr. Niyas HR, SAT Hospital, Government Medical College, Trivandrum. Congrats and best wishes to all the prize winners. Announcement desk. Thank you.
Regarding the poster presentation, we had 2 eminent faculties as the judges. One was Dr. Nandakumar, Senior Consultant Pediatrician, Aster Mims, Kannur, and Dr. Abdul Rauf, Pediatric Intensivist, Baby Memorial Hospital, Kozhikode. And of the posters from the faculty, the first prize was won by Dr. Ritu from Babasaheb Ambedkar Medical College, New Delhi. And I think she is the second for the free paper presentation also. And the second prize goes to Dr. Rizwan Ahmad from NKPS Institute of Medical Sciences, Nagpur. Regarding the poster presentation by residents, we had 12 posters. The first prize goes to Dr. Chandini from IMCH Government Medical College, Kozhikode. Second prize to Dr. Sahana, SAT Hospital, Thiruvananthapuram. Third prize, Dr. Georgina Elsa Jose from Noble Hospital and Research Center, Pune. On behalf of the organizing team, I congratulate the winners, and we sincerely thank all the participants and the judges. Thank you.
Certificates to the winners and all the participant certificates will be mailed to them. So now let's continue with the session by Dr. Girishan sir. Sir, over to you, sir.
Good morning all. First of all, let me thank the organizers of this event for giving me the opportunity to present the COVID-19 NICU experience in Government Medical College, Manjeri. See, ours is a government medical college. catering the largest populated district in Kerala. And there are around 3,000 OP cases a day, 350 pediatric OP cases a day, and 5,500 deliveries per year. And there are 75 to 100 NICU admissions per month. And we have a very well-equipped PICU with 6 beds and ventilators, and a well-equipped neonatal ICU with 7 beds and 4 ventilators. And our hospital is converted to exclusively COVID dedicated hospital during this pandemic. And during this pandemic, for the last 16 months, that is from March 2020 to this June 2021, we had around 2,400 deliveries, of which there were 24 IUDs and remaining 2,376 live births, where we got 2,397 babies. And out of this, 1,304 mothers were COVID positive, and 690 mothers were COVID negative, and 406 status was not known. And the data on COVID status of babies are available only when they are admitted to NICU. And but at the same time, we were doing the COVID test for all babies of all positive mothers from the labor room itself, but many of them were transferred to that FLTC before the results were available, or when both mother and babies are asymptomatic, remaining there more than 3 days, but for want of this declaration of results, in such a situation also, we were discharging the babies. So the data of all the babies in our hospital is right now not available. And you can see that delivery, usually it is somewhere around 300 to 400 per month. But in March, to begin with in 2020, it was 311. Then a drastic decline in delivery, because in the next 3-4 months, people were not reluctant. They were reluctant to come to this exclusively COVID hospital. And like that, it went on, but gradually picked up the number. And during the last 16 months, the total tally was 2,400. And the NICU scenario, there were a total of 585 admissions in our NICU during this period, of which 360 were term babies and 225 were preterm babies. And out of this 585, we had 131 COVID positive babies and 407 COVID negative babies. And 47 babies, the status was not known because of so many other reasons. And of the 131 COVID babies, 46 babies were born by LSCS and 85 babies were born by normal vaginal delivery. That means around 1/3 delivered by LSCS and 2/3 by normal delivery. And the COVID status of mothers and babies admitted to our NICU, that is positive. Out of the 495 inborn babies, 271 were COVID positive, and out of the 90 outborn, 39 were COVID positive, and a total of 310 COVID positive babies were there. And the majority, I mean, 310 mothers of COVID positive babies were positive. These mothers of COVID positive babies, 310 were positive out of this 585. And majority, we can see that majority of the COVID positive mothers are giving birth to COVID negative babies, because out of this 585, 310 mothers were positive, but only 131 babies were COVID positive. Other babies were COVID negative. Means majority of the COVID positive mothers are giving birth to COVID negative babies. And the COVID status of the babies in relation to mother, when we look the data in that way, see, you can see that out of the total 330 positive mothers, we got only baby positivity, baby become positive is only in 113, and baby negative in 197. Means that majority of the COVID positive mothers are giving birth to COVID negative babies. And among see, all how we manage the cases in our newborn nursery. All asymptomatic babies are kept with the mother. In all the term babies, all COVID positive or negative, if they are asymptomatic, we were keeping with the mother. And COVID positive mothers are advised strategies to prevent infection to babies. Means that during feeding, they have to wear mask, and babies after feeding are kept in cradle, little separated with the mother in the same room. And NICU admission for all symptomatic babies, that is COVID positive or suspect, and both term and preterm, we were admitting the cases. And NICU admission for preterm babies, even if they are asymptomatic when COVID is suspected. And only symptomatic management for majority of the COVID issues, and complete recovery in all the cases, and except 2 deaths. And how many of them required ventilatory support? You can see that out of this 585 total admission,
ഗിരീഷിന് സ്ലൈഡ് കാണുന്നില്ല കേട്ടോ.
കാണുന്നില്ല.
സ്ലൈഡ് കാണുന്നില്ല.
സ്ലൈഡ് കാണുന്നു. Slide.
Sir, please share your screen.
Okay. One minute. Is it visible now?
അല്ല ഗിരീഷ കാണുന്നില്ല, സ്ലൈഡ് കാണുന്നില്ല. വിസിബിൾ അല്ല.
Is it visible now?
No.
This one.
ആദ്യം കണ്ടിരുന്നു.
ഗിരീഷ ഞങ്ങളെ പ്രശ്നം. No, it is okay.
ഇപ്പൊ കാണുന്നുണ്ട്.
Okay, it is okay. Go for the slide show.
Okay.
സ്ലൈഡ് ഷോയിൽ ഇതേപോലെ പോയാൽ മതി.
Okay.
Yeah.
Yes. ശരിയാണ്.
See, out of this 585 admissions, 131 were positive, of which only 15 babies required CPAP and only 5 babies required mechanical ventilation. And regarding the number of hospital days for these babies, we were having majority of the babies required 5 to 10 days. That is 67 of this out of this 131 required 5 to 10 days of hospital admission. Only very few, that is only 3 required hospital admission for more than 20 days. That is for one case was in neonatal meningitis, and 2 others were severe perinatal asphyxia, survived for more than required more than 20 days. And what about this MISC C or MISC N cases? There were no cases of MISC in newborn so far, and at the same time, we had 4 reported cases of MISC among older children in our hospital. All of them recovered, whereas in newborn there were no cases suggestive of MISC. And the outcome, majority of the neonates are discharged and went home without any issues. A few of the cases were referred to other higher centers on account of technical and strategic reasons. Out of that, one baby with both mother and baby positive COVID status having anorectal malformation now on follow-up from IMCH Calicut, and 6 cases where the mother was positive but the baby was negative. So we can call it as COVID related, and all of them recovered from the referred centers. And only 4 COVID related deaths, out of them 2 cases were both mother and baby positive with severe perinatal asphyxia, and other 2 where the mother was positive and baby was negative, and both were preterm with respiratory distress syndrome. And none of the these babies had features of MISC at admission, nor had readmitted so far with the features of MISC. And at a glance, out of total 585 babies, COVID positive babies were 131, and out of them 129 babies recovered, so far no readmission, and 2 babies expired out of this COVID positivity, and another 2 COVID negative babies of COVID positive mothers also expired. We can probably take these death also into account because there may be some COVID relation in that situation where, because the mothers were positive. And the deaths little in detail. The first case was a 2nd of teen female born on April 30th, and the baby was severely asphyxiated. And the baby was 30 weeks, 6 days of gestational age, and birth weight was only 1.2 kg, and delivered by foot limb presentation and severely cyanosed. And mother and baby were COVID positive, and there were no congenital anomalies, and baby was given all possible treatment, and baby was ventilated and given antibiotics and other supportive measures, but expired on 2nd May after around 56 hours of NICU stay. And the second baby again was an term baby, AGA, and birth weight was 3.3 kg, and the mother and baby was positive, and there was severe perinatal asphyxia, and here also there was no dysmorphism or congenital anomalies, and there was metabolic acidosis, and baby was given all treatment including antibiotics and other supportive measures, and there was shock which was managed with ionotropes, and baby expired on 21/4/21 after about 85 hours of NICU care. So these were the 2 COVID positive babies died in our NICU, and 2 more COVID negative babies expired whose mother was positive, and both of them were LSCS babies and preterm babies around 31 weeks. Both of them were having features suggestive of respiratory distress syndrome, and these babies expired in our NICU. And the summary, there were around 2,400 deliveries in our hospital, of which we had 2,397 babies, of which 585 were admitted, including 90 babies outborn, and of this 131 babies were COVID positive, and of which we had only 2 COVID positive deaths, and 2 COVID related deaths, we can say like that, COVID related death because mother was positive and baby was negative. And so far, there is no cases readmitted in our hospital with the features of multi-system inflammatory inflammation. And the challenges we faced in our NICU was that being a small medical college, that is, we had very much this space constraint to accommodate COVID positive, COVID suspect and COVID negative babies separately. And there were diagnostic difficulties. A good number of initially RAT negative babies became RT-PCR positive with concurrent samples, and means that at the time of admission itself, we are going for RAT, which is negative, and we may be thinking that it is negative, but at the same time, the sample collected at the same time is coming as positive by the next day or on the second day. And that is one of the thing. And also a few babies of COVID negative mothers are tested RT-PCR positive on day 1 samples. So we are doubtful from where these babies got infection. See, mothers are COVID negative, but babies are becoming positive. And we can't predict the long-term effects, if at all there is any. And so far, there is no readmission with any issues of this admitted babies. Okay. And the contributory role of COVID positivity in deaths of babies is not sure, though we had definite other reasons for this their deaths. One baby had ectodermal dysplasia, whose mother was COVID positive, but baby remained negative and later on expired. And our doubt is that is the baby false negative, and is ectodermal dysplasia the effect of intrauterine COVID-19 infection? These are all the questions or challenges we face in our NICU. Thank you.
Thank you, Dr. Girishan. Unfortunately, I was muted by the host, so I could not introduce him. Dr. Girishan is Professor of Pediatrics, presently working in Government Medical College, Mancheri. That is an epicenter of COVID, I should say. And I think probably we had the maximum number of COVID positive deliveries probably in the state. And with departure from the usual observation, we had, I think, more percentage of vertical transmission recorded in from Mancheri. And Dr. Girishan, he has made a mark in all institutions where he worked. A person with a lot of innovative ideas. So this is a real wealth of information he has provided us from a center where many babies were looked after with COVID positive deliveries. So I would ask Dr. Girishan whether the incidence of preterm delivery was slightly more common, during the COVID season, and also the incidence of cesarean section, whether it went up.
See, we had correct data on this NICU admission only, and out of that, 225 babies were preterm. Around that is out of this 585, 225 were preterm, and the rest of them means around 40% were preterm, and the 60% were term babies. And LSCS, we had 46 LSCS babies. Out of this 131 COVID positive babies, 46 were around 1/3 were born by LSCS, and the rest by normal vaginal delivery.
Okay. And with maybe of significance in the newborn period. And basically we understand that the problems in the newborn is more of the aftermath of the maternal condition rather than the COVID, the direct effect of COVID in the newborn period. But of course, we are probably with some concerns like raised by certain case reports from elsewhere and even from our like Calicut Medical College, whether passively transmitted antibodies can create problems in newborn, or intrauterine infection can cause any inflammatory issues in the newborn and resultant issues in the newborn. Though it may be rare, but it is going to be a reality. And more than that, whether these infections may be asymptomatic, whether it can have a long-term effect on the newborn, like epigenetic alterations or the long-term neurodevelopmental outcome, that yet to see. I think with this, probably we can conclude the session. Thank you, the speakers, for their active involvement in this. Thank you. And Doctor, I am thanking on behalf of Dr. Manoj. He is otherwise engaged in another meeting. Okay, thank you.
Thank you. That was indeed an excellent session. The next hour, we have three distinguished speakers to enlighten us on the various aspects of multi-system inflammatory syndrome in children, popularly known as MIS-C. The speakers for the session are Dr. Kishore Warrior, Dr. Priyankar Pal, and Dr. Geeta P. This session will be co-chaired by Dr. K.K. Purushothaman and Dr. C.K. Shashidharan. Dr. K.K. Purushothaman is the Professor of Pediatrics, MES Medical College, Perindalmanna. He was the former Head of Department of Pediatrics, Government Medical College, Thrissur. Dr. C.K. Shashidharan is the former Head of Department of Pediatrics, Government Medical College, Kozhikode. He has served for nearly 3 decades in the Institute of Maternal and Child Health, Kozhikode. Currently, he is working as a senior consultant in Baby Memorial Hospital, Kozhikode. Over to you, respected teachers.
Sir being my teacher, let him start.
Purushothaman sir, unmute yourself.
Sir,
Sir, you are audible.
Okay. Shall I kick off the ball? Then Purushothaman will take over. Okay. Right. This is a very important hot topic.
Sir, രണ്ട് mobile phone login ചെയ്തിട്ടുണ്ടെങ്കിൽ അതൊന്ന് close ചെയ്ത് കളയാം. Reflection ഉണ്ട്.
Pardon?
You have logged in from two
Sir, രണ്ട് മൊബൈലിൽ ലോഗ് ചെയ്തിട്ടുണ്ട്, രണ്ട് ഡിവൈസിൽ ലോഗ് ചെയ്തിട്ടുണ്ട്, ഒന്ന് ഓഫ് ആക്കണം.
കളഞ്ഞേക്കാം. Sorry.
Yes. Okay.
Okay, that's fine. Okay, this is a very hot topic, very close to our heart, and we have 3 eminent persons to deliver on this. And it is nothing other than Dr. Kishore Warrior, our own alumni and my own student. I'm really proud to have him and listen to him the next few minutes. Next is Dr. Geeta, again Calicut alumni, our own student. Both of them are rheumatologists and really interested and going ahead with these problems. And the third person, she's from outside, and we understand that she's also working on these MAC problems. Now, just a word of introduction. After the onset of this pandemic, we come across so many things which we were not aware or which we were not seen earlier. But the rapid transmission of knowledge and information and interaction with the experts in the field, we get enriched. And exactly same type of findings, same type of management we carry out throughout the world, with maybe some degree of difference. But basically, it is aimed at improving the condition of the patients and delivering good health care to them. And that is what we have been doing. I have with me Professor Purushothaman, my own dear student. He has been retired from Thrissur Medical College, and now he has joined MES Medical College as head of the department. I think he is following my own footstep. I also did exactly the same thing. Nice to see you, Purushothaman. And I wish all the participants very good time. Please enlighten us on this topic. And over to Purushothaman, please take care of.
Thank you, sir, for the nice words. Without wasting time, I invite Dr. Kishore for this experience. At the beginning of this session, we are sharing the experiences with the international, national, and Kerala experience by the expert teachers about the COVID scenario in pediatrics. It's now a group of major problems leading to a little higher mortality. And Dr. Santosh has already told us the preparedness on the government side. And after hearing Honorable Chief Minister and the Health Minister's attitude and the receptiveness of how much they are valuing our input from this conference, really happy. So there should be a sharing of experience from the world level, national level, and from the Kerala experience. From there, we move forward. So let us hear from Dr. Kishore, the UK experience. Inviting Kishore.
Thank you very much, sir. Am I clearly audible? Thank you.
Yes,
It's an absolute pleasure to obviously collaborate with anything to do with my alma mater. And it's I'm even more honored that two of my professors. So when I was doing my post-graduation Calicut, CK sir was a professor. And when I did my DNB and lectureship in Thrissur, Purushottam sir was my friend, philosopher and guide. It's such an honor that they both were kind enough to introduce me for this meeting. So without any further delay, I shall share my slides if that is okay. Are you able to see the slides? Okay, so
okay, Dr. Kishore.
Yeah, thank you. So I think I will. I would not have been sat here doing this presentation about 18 months back. So the whole world, medical world, has turned upside down following the outbreak of COVID-19 in the fag end of 2019. And for the same reason, I have been missing my annual trips to Kerala, which I have not been able to do for 2.5 years, because if the first wave here is finished, the first wave in Kerala starts. And by that time, the second wave here starts. And by the time I'm ready to come, the second wave starts in Kerala. And now it's the third wave in UK. So it's been an absolutely difficult time of the year. And we as pediatricians were not sure what to expect. And I will confine my discussion to the topic assigned to me about how the mystery of Miss C or PIMS TS unfolded in Britain. So I will leave to other esteemed speakers, especially Priyankal, who was the president of the Pediatric Rheumatology Society of India, to deal with the nitty-gritty of the topic. So mine is more an epidemiological journey along how this evolved. I would like to take exception to the title given to me about how the mystery of Miss C unfolded in Britain. Miss C did not unfold in Britain. What unfolded in Britain was PIMS TS. These cases were first reported in Britain, and it was the Royal College of Pediatrics and Child Health who gave the name PIMS TS, Pediatric Multisystem Inflammatory Syndrome temporarily associated with COVID-19 infection. And when this same thing unfolded in America a few weeks or months later, CDC, for whatever reason, chose to change the name to Miss C. And so Miss C did not really unfold in Britain. It was PIMS TS which is unfolded in Britain. So I'm taking the liberty to change the title of my talk to reflect the same. So I think it's probably appropriate to start with a very brief timeline of COVID. We all know about it. The cases started coming up in China in December, and it was on the 31st of December that China alerts the World Health Organization about several cases of pneumonia, clusters of pneumonia, whether this could be something more serious than what has happened. And then subsequently, we know that the food market, seafood market in Wuhan was shut, and COVID-19 was first identified in early January. And then things just I can give you a simple example. Said China recorded the first death officially in January 2011. And by the end of the month, they had about 132 deaths, which kind of showed us that this is not a condition which is going to go away. And the rest of the world sat and took attention. While this was going on elsewhere in the world, what was the situation in Britain? The first 2 cases of COVID-19 in Britain was not reported until the 31st of January. And we had a period of uneasy calm between 31st of January and 5th of March, as the cases were spreading like wildfire, first in Italy and then in Spain. We were still thinking that UK would not be hit as hard. So it took us till the end of 12th of March, by the time the government came out, said, now we need to be cautious. We are not locking down at this point in time. And at that point, it was obvious that until that point, the rule was anybody who experienced symptoms suggestive of COVID should take a PCR test. And if the test is positive, they should isolate. It was obvious that by the 12th of March, the system was getting overwhelmed, that the government took a decision that anybody having these symptoms should not get a test, but just self-isolates. So from then on, the numbers of infections you can find in UK will not be a true reflection of the actual number of cases. There were only patients who came to the hospital who were tested. So the numbers are not truly accurate from this point in time. But it was not until the 26th of March that UK did the lockdown. The complete lockdown came to force on the 26th of March, which was legally enforceable. Now, we could spend a whole day debating whether that was timely or not, but I'm not going to get into that at this point in time. So the lockdown was not the beginning. It was not the end, but it was just the beginning of the number of cases we had. So as you can see in this graph, the cases and deaths in UK plummeted after the lockdown. So we all know that hospital admissions follow the infections by 2 weeks, and the deaths follow it by further 2 weeks. So it takes about 4 weeks for the infection rate to be converted into death rate, which you can see very clearly in this graph. So it was not until the end, or probably the 3rd, 4th week of April, that the infection rate and the death rate peaked in UK. Now, at this stage, what was going through our mind? So it was clearly uncertain times because we knew very little. But as a pediatrician, I felt reassured because the data from elsewhere suggested that children were very mildly or perhaps not at all affected by this COVID-19, or the COVID-19 disease, as it was called, in adults. So that was very reassuring. But as a rheumatologist, I was concerned because most of my patients are immunosuppressed. We don't know, or we didn't have any significant data at that time to say that how COVID-19 would affect immunosuppressed children. So we know that it did not affect children, immunocompetent children, very well. But the jury was out at that point as to how badly immunosuppressed children would be affected. So we were very scared about the patients. For example, we had 2 patients who were diagnosed with what we used to call Wegener's granulomatosis, so it's GPA, who had shed loads of steroids and cyclophosphamide at that time. So how are we going to protect these patients? How cautious should we? Should we be shielding them? So there are lots of questions going through our minds as to how careful we should be with the immunosuppressed patients. So those are the 2 questions going through our minds, but nothing other than that. Fast forward in time, 24th of April, Friday, this message appears in the WhatsApp group of all pediatric intensive care consultants UK. And that was actually the first description of PIMS-TS in any medical forum. So as you can see in that message, this is a consultant in London who said that we are seeing several cases of previously well children with abdominal symptoms and warm shock with typical blood picture of COVID. So he has summarized PIMS-TS very nicely in the first sentence. And he very clearly said there is little in way of respiratory symptoms. Some of the patients were initially negative and some have come back as positive subsequently. One of them had a negative laparotomy last night and he crumbed after the surgery. This was the typical picture because many of these patients had high fever and abdominal presentation to the extent that they all ended up, or at least some of them ended up being laparotomy, which was then negative. The fact that all this is happening now, 4 weeks after the lockdown, when the R number has gone to less than 1 is worrying. So that is a very important observation. So lockdown had been in force for exactly 4 weeks, and the R number, which showed the transmissibility, was actually going down. So to have observed this when things are actually getting better was indeed a matter of worry. And someone else commented that I was referred as a similar patient. So the thoughts continued like this. So there are people who came up saying that we have seen many over the weekend and recently. An interesting observation was that most of them were teenagers. So that again was something that worried us. Another person commented, wonder the rheumatologist may be the first to understand this. Is this some kind of vasculitis? Should we speak to them? And then another person said, I think this is what the rheumatologists call MAS or macrophage activation syndrome. Whereas one of the other people commented whether this is Kawasaki's disease. So these are the things that crossed their minds when they first discussed about this in open forum. However, this group did not delay things. Within 2 days, they decided to collaborate. They decided to compile all the cases, put them to a clinical database, and one of the consultants took the initiative to send around a questionnaire. So it was sent to all the pediatric intensive care units in UK. It essentially focused on two things. One is service evaluation about these conditions and asked the people to collect the individual patient data if the families consented to that. And within 4 weeks, they identified 78 eligible patients who then went on to meet PIMS-TS criteria. Now, what are PIMS-TS criteria? So the Royal College of Pediatrics and Child Health brought out the criteria or the guidance on, gave the name PIMS-TS and brought out the guidance on 1st of May 2020. So it took only 5 days from when this was flagged as something of concern for them to bring out this guidance, which is very unusual because we sit on guidances usually for weeks and months before we come out. And that was a very swift multidisciplinary team action, which was highly commended. And part of that was prompted by this thing. So a lot of national media, for whatever reason, had some leaked information that there is a kind of inflammatory Kawasaki-like illness affecting children because of COVID. So that was actually sending panic in the, or spreading a lot of scaremongering in the whole of the country. So before the situation got out of hand, they had to do something about this, which is why Royal College worked with double speed and brought out the guideline within about 5 days. And that was such an important thing to do to kind of put paid to all the unnecessary talk that was going on at this point in time. The first case report, medical report, came in the correspondence section of Lancet. And as you can see, that happened on the 6th of May, where they described the first few cases. One of the hospitals in London, St. Thomas Hospital, they described the first few cases of PIMS-TS. Interestingly, most of these cases came from one particular small hospital who all got then referred to this big hospital. So it was actually not even London, but it was confined to one particular place of London. So if you remember, in the first wave of COVID-19 in early March or mid-March, London was at the epicenter. And this was reflective on PIMS-TS incidents as well 4 weeks later. And this is very clearly reflected on this graph. So this is how the COVID-19 infections numbers went up in UK. And you can see that the PIMS-TS cases, which is the blue line, followed it by exactly 4 weeks. So there was a clear temporal association in the incidence of PIMS-TS when compared to COVID-19 infection. So what happened was, once this came out in the public domain, the hospitals which were seeing these patients held a lot of national webinars to disseminate the information very quickly. So these webinars were attended by pediatricians, pediatric rheumatologists, pediatric immunologists, infectious disease specialists, intensivists, cardiologists. So the information was disseminated very quickly. And as you can see in this graph, when this was first reported exclusively in London, which is that big red dot at the bottom, and then like COVID-19 infections, it started spreading elsewhere. So then it spread to Midlands and South, and then the farthest it went to was the north of England. So this followed exactly the pathway the COVID-19 infections had followed demographically about 4 weeks earlier. So we knew that although we were relatively immune at that point in time and London was getting badly hit, we knew that it was a matter of time before these patients came to Midlands where I work. And that was not until the middle of May when I got a call at 10 p.m. by one of my intensive care colleagues about this 6-year-old boy. It was a very interesting story. He was completely previously fit and well, so there is no underlying medical conditions. He presented just like any child would, with the pain in lower abdomen and left side of scrotum. So understandably that they felt that this is an acute scrotum, for which he was explored, and they found a torsion of left hydatid of Morgagni, which was excised and particular fixation was done. And they thought that was it, it's fixed. But unfortunately, during the post-operative period, his abdominal pain persisted and he was found to be tachycardic. And when the surgical registrar examined, he clearly had peritonealism. He was peritonitic, which prompted them to re-explore. So they found an ileal perforation because of Meckel's diverticulum, which was resected, and he ended up needing an ileostomy. Now, what was worrying was the fact that he was profoundly hypotensive after the procedure that left him having to get admitted to PICU, pediatric intensive care, intubated and ventilated. He required about a total of 120 mils per kilogram of fluid bolus over 24 hours, plus quickly escalating inotropic support, which quickly went from adrenaline to noradrenaline to vasopressin and hydrocortisone over a period of 48 hours. So his blood pressure was described as extremely sensitive. I still remember the consultant telling me that even if you went up by 0.1 mils per hour of noradrenaline, his blood pressure would be sky high. Similarly, if it dropped it down by 0.1, he would be profoundly hypotensive. That was how sensitive his blood pressure was, which often is a feature of these patients. What worried them also was the fact that his echocardiogram showed impaired left ventricular function, although he did not have any coronary dilatation. The two important features of the blood film was lymphopenia. So you would expect somebody who has had a recent infection or sepsis to have leukocytosis, but whereas the only thing which was he had actually lowish neutrophil count and lymphopenia, and his CRP was quite spectacularly raised at 241, which was actually very significant at that point in time. His investigations revealed he was on broad spectrum antibiotics. Blood culture was negative. His peritoneal fluid had a mixed growth, which was not thought to be significant. But despite 48 hours after antibiotics, he was still spiking temperatures more than 40 degrees, which prompted the team to change antibiotics. And his blood tests were progressively getting worse. His ferritin was more than 500. His D-dimer came up as 8,000, because at that point, we rightly suspected PIMS TS. And the CRP had gone from 250 to 380, and his liver function was getting worse too. However, fibrinogen and triglycerides were normal, kind of confirming that he did not have the full-blown picture of macrophage activation syndrome. So the question is this septic multi-organ dysfunction syndrome, or is this PIMS TS? So is there any kind of contact with SARS-CoV-2 infection? So there was no symptoms to suggest SARS-CoV-2 infection in this particular boy. There was no obvious history of contact with any family members, and his COVID PCR was negative. The rest of the infective screen was negative too. But while this was going on, his blood tests were getting worse, and he continued to spike temperatures. The CRP had gone to more than 400, ALT had almost doubled, and ferritin was more than 500, and D-dimer had doubled from 8,000 to 15,000. So, sorry, 150,000. So the question then again, what is this? So that is when I get a call. So this is how I saw it. He has got no rashes. He has got no mucocutaneous features of Kawasaki's disease. His infection screen is negative. Although there is no contact history with suspected COVID patient, this looks like a barn door PIMS TS with a toxic shock syndrome phenotype. So the other question is, there is no features of Kawasaki's disease. Is there an element of macrophage activation syndrome? In any case, I said we should start him on steroids. The standard dose of methylprednisolone we would use in rheumatological conditions is 30 milligrams per kilogram, maximum 1 gram. Now, at that point in time, I was reluctant to use that because of how sensitive his blood pressure was. So we gave him 10 milligrams per kilogram the first day, And because he's tolerated well, the next day we gave it 20 per kilo, and the third day he had full 30 per kilo. Now, interestingly, he had an absolutely dramatic response. So I had the call from, so the consultant who led this consortium of pediatric consultants was actually my colleague, and he rang me the next morning saying that it looks like we have won the battle, because he became aparexial. He was extubated within 48 hours, and he was off all inotrope within 72 hours. And this echo was completely normal at 72 hours. So this is a prototype PIMS TS with TSS presentation who responded to steroids. I was brave enough not to give IVIG, partly because there were no clinical stigmata of Kawasaki's disease at this stage. And 2 to 3 weeks later, so we had a 2 to 3 week turnaround to have COVID serology at that point in time. He came back as IgG and IgM strongly positive. And you can see that how dramatically his CRP responded once we gave the first dose of steroids. So the original set of 78 patients identified in that questionnaire was subsequently published in Lancet in July. It was published in July 9th, which was amended subsequently later. And I will confine my rest of talk to this cohort of patients, the first set of PIMS TS patients reported comprehensively worldwide. So the first question the group raised is this actually real? Are we just seeing an increased number of patients for whatever reason? So what they did is they looked back at the previous 5 years and looked at the number of patients with toxic shock syndrome, macrophage activation syndrome, and Kawasaki's disease who had to get admitted to intensive care in the same amount of time. And that was the blue line. Can you see the blue line? This is the number of a combination of these conditions which you would expect in a year. But here, from the green line, you can see that the admissions had rocketed. So they convinced themselves. The first question was, this is real. There is a sudden surge in a hyperinflammatory presentation in the form of toxic shock syndrome or Kawasaki's disease or macrophage activation syndrome for whatever reason. Then if you go back to the old slide, you can see that this corresponds extremely well with the increase in the COVID cases, except that it follows it or lags by 4 weeks. And looking at the demography, about 2/3 were boys. But what was interesting was it was more common in older children. So the most important age group, up to half of the children were 11 to 15 years. Now, this is a quantum shift from the classical Kawasaki's age group we are used to, or even if it's a primary HLH, hemophagocytic lymphohistiocytosis, you expect them in the first 5 years of life. So this was a quantum shift in that age group. The other thing was, it was found that all the children, you couldn't call them obese. Many of the children who were affected had a mean body weight, which was more than expected. So they were more on the overweight or heavier side when compared. And the other thing was up to 78%, 80% of these patients had no comorbidities at all. So the initial concern, whether this was more common in children who are immunosuppressed or who have an underlying problem, was thrown out of the window because most of these patients had no comorbidities at all. This was another important finding. So most of the children, or about up to 50% of the children, were Afro-Caribbean, and next came Asian, and next came Caucasian people. Now, this was in stark contrast to the demographic split of these ethnic communities in British population. So if you were to for the population split expected, you would have expected most of these patients to be Caucasian, then Asian, and Afro-Caribbean. So we realized that there was a disproportionate involvement of a group which we call BAME. So basically, it means Black, Asian, and other ethnic minorities. So there was a clear predilection for involvement of BAME, so Black and Asian patients because of. So we didn't know what the reason is. There was theory that was because of vitamin D, that there was a theory that was because of their genetics, it was because of their immune makeup and stuff like that. There was even BCG thrown into the mix. But anyway, we have not cracked it yet, but it was very obvious that it was more common in not white children. Again, looking at the relation to SARS-CoV-2 infection, about 80% of patients were PCR negative. Amongst those patients, still about 9 out of 10, 90% of patients who had serology sent were positive. And the patients who were negative, about 96% of them were serology positive. So we could prove a temporal serological association with SARS-CoV-2 in most of these patients. Now, the clinical patient presentation, as one would expect, all of them had fever, and about 87% of them had shock, and most of them had warm shock. So they never had the shutdown cold peripheries, they had warm vasodilated shock. And again, the most important thing we would fix it up to 90% of them had some kind of abdominal symptoms. It may be abdominal pain, diarrhea, vomiting, peritonitis, whatever it is. 90% of them had abdominal symptoms, which is again not something which you would expect in a classical Kawasaki's disease or macrophage activation syndrome. So those are the odd things. About 50% of them had rash, and about 1/3 had conjunctivitis. Now, looking at the blood parameters, the most drastic thing was lymphopenia. Most of these patients were significantly lymphopenic. And again, we would expect people with Kawasaki's disease to have thrombocytosis, because we use even platelet as a reliable diagnostic criteria in patients with Kawasaki's disease, whereas most of these patients actually had thrombocytopenia. The CRP was very high to the extent we use milligram per liter, and we had about anywhere between 250 to 300 to sometimes even 400. CRP was very high in these patients. They also have elevated D dimer, which kind of explained an inherent susceptibility to clot formation. It is described as a type of endothelitis, which kind of caused that. And they also had significant ferritin. But one comment I would make is, having managed patients with macrophage activation syndrome, when we had a CRP of as high as 200, 300, you would expect the ferritin to be more than 10,000. So the ferritin, I would say, although it was elevated, was disproportionately low for the amount you would expect with that kind of hyperinflammation. So that is something which was quite significant. And some of these patients also had elevated troponin levels suggestive of myocardial dysfunction. Now, what was the outcome in these patients? Now, 96% of these patients got discharged from intensive care. So that was very good. Only 2 children died, and one of them died while they were in ECMO. And one person is still in the critical care. And the median length of stay in intensive care was about 5 days. And what intervention did they need? About half of them had to be ventilated. And it needs to be said very clearly that they were ventilated because they were unstable more than any respiratory. Most of them had clear lungs. So it was not like the COVID-19 adult picture. They were intubated and ventilated because they were so unstable, and not because they had any respiratory problem. They all needed very minimal ventilatory setting for management. But 80% of them required inotropes, and 3 of them ended up needing ECMO support. And 1 patient had a renal failure, needing temporary renal replacement treatment. What were the complications? About more than 1/3 of these patients, and most of them had Kawasaki-like presentation, had coronary abnormalities. However, they compared the group with coronary abnormality and without coronary abnormality. And there was no significant difference in either the demography, the clinical presentation, or other lab parameters that would help us predict who would develop coronary disease and who would not. So there was no significant useful data from that point of view. And 3 patients also had clot formation in various sites. Drug therapies, as one would expect, 100% of them had antibiotics, because the first thing we had to rule out was infection. About 75% of them had steroids plus or minus immunoglobulins, IVIG slightly more than steroids, and only about 1/4 required biologic treatment. So most of them would respond to first or second line treatment. So some centers used like IVIG first and then steroids, and vice versa. In my thinking, if it had a Kawasaki presentation, I would like to go IVIG first. If they had a toxic shock syndrome presentation, I would like to go steroids first. That's what I personally used, or our center used in our practice. And the biologics used varied from anakinra, mainly for MAS presentation, infliximab, which is mainly for Kawasaki presentation, and to a small extent of tocilizumab and rituximab. More than half of these patients were put on aspirin, and some of them required anticoagulation, and most of it was prophylactic, although some of them had clots. So it's very obvious at this point that antiviral therapy, especially remdesivir, had no role in the management of PIMS TS. You can see the treatment progression over time. So you can see that the red line is IVIG, which is by far the number one, the one which most patients had, and equal almost most of them got steroids as well. So the shift in this shows that we started knowing more about this condition. So we were more streamlining the treatment, for example, towards the end of May when compared to how things were in end of April. So we clearly knew more about these conditions and we were getting more, which is why the treatment was more streamlined. And most of these patients got antiplatelet therapy. And as I said, only a small percentage required biologic treatment. So next question is, what is in the name? So it was described as PIMS-TS in Britain. And the COVID first wave in America has followed us by about 4 to 8 weeks. And New York City, just like London, was the epicenter. And they had a huge influx of patients with PIMS-TS, which for whatever reason, they renamed as MIS-C. And CDC came out with a criteria for that. So it's interesting that there were a lot of international webinars, especially one which was run by the Boston Children's Hospital, which was an extremely useful, up-to-date, and which shared information by people all across the globe about how they have been dealing with this condition, which was helpful learning experience for all of us. So, and then we had subsequently WHO brought out their criteria, and so did the Center for Disease Control in America. So we ended up having slightly three different guidelines for the diagnosis of the same condition, but they were all remarkably similar to one another. So in short, what did we know at the end of the first wave? It was clearly temporarily associated with COVID-19 infection. There was a higher incidence in non-white population. It could be because there may be slightly high BMI may a cofactor. We are not sure, but it looked like higher BMI did predispose to you to at a slightly higher risk. All these patients had febrile onset, sick patients requiring intensive care, mostly for hypotension, especially warm shock. They all had laboratory evidence of hyperinflammation, especially very high inflammatory markers in CRP and ESR. They had much involvement. We were particularly
kindly reminding that we have already overshot the time, sir.
Yeah, this is my last couple of slides.
Okay, sir.
So and we had multi-system involvement, and especially the worry was about cardiac. It was myocardial dysfunction or coronary involvement, and none of them, interestingly, had respiratory involvement. And overall outcome was very good in these conditions when they were picked up early. The important thing is to make an early diagnosis and start managing them. So towards the end, once we went to July, August, there were lots of PIMS-TS patients who did not even have to go to PICU because they were picked up early in the wards and managed early. So as we know, the clinical phenotypes would include Kawasaki's disease, toxic shock, multisystem inflammation or hyperinflammation or macrophage activation syndrome. And one of the most important things in the management is the management of multidisciplinary team involvement that would include PICU, renal doctors, pediatricians, infectious disease, immunologists, cardiologists, and even psychology and physiotherapy have their role in these patients because it's a sudden life-threatening condition. And I think I'll probably slip these slides because for lack of time. And what happened next, just an addendum to that, we had controlled the first wave very effectively by the lockdown, but then you can see that there was a second wave in August, September time. Then we had a mini lockdown, which brought it down significantly, but did not cut it down completely. And we had a very significant third wave in December, January time. And that resulted in this. In February, March, there was a real epidemic going on with PIMS-TS to the extent that the media reported up to 100 children were being admitted across the country in a week with this PIMS-TS syndrome. But we think, I wouldn't say for sure, we think that we know the condition slightly more than what we knew a year back. I hope on the note that we would be able to successfully stop COVID-19 from affecting our children in near future. And on that positive note, I would like to thank the organizers once more for giving this opportunity. And thank you very much for your patient listening. Thank you.
Thank you, Dr. Kishore, for sharing your experiences at the international level, UK. And having three pediatric rheumatologists to talk about this complication, I would like to interested very much in the developed countries' experiences. Why? Because our Honorable Chief Minister and Minister are ready to set up anything which is very likely to save kids in the coming phase of MISC in children. And we had a few kids dying because of the intractable shock. One kid we lost last month. There are a few cases of very non-responding cases in Cochin, Trivandrum, where they saved with ECMO. What we lack is those facilities in the government setup here, and national level also we lack Anakindra. Just by seeing your reports of the 78 cases, there were 3 cases only you needed ECMO. But you use of the biologicals, so it is 10% of Anakindra, and all the other biologicals you used. So, in the recommendation at the end of this session of the experts, should we be asking for the setting up of this ECMO in at least 2 of the the big medical colleges, maybe in Trivandrum and in Calicut is one. Whether we should make some measures to get Anakindra. It's not a message to go for the ECMO and Anakindra right and left, but we should not be in such a difficult situation. The right time, we should have that access. That is one thing we should be thinking of. And that's the way the pediatric rheumatology, the management, maybe in a developed country you are having, but at the national level and the state, it may not be. So we should be taking those steps to procure these things if possible. Okay, thank you, Kishore. If Cesar is here, there's some connectivity issue, I think. If not,
I would just like to say one thing, because anti-IL-1 is an important thing in the management of autoinflammatory diseases. And I know the Pediatric Rheumatology Society of India have been making most, but I think we need to mobilize this at national level, at government level, and from a policy point of view, to get these multinational companies to actually bring this medicine to India, and hopefully at a subsidized price, because there are certain conditions where you cannot have a replacement for anti-IL-1. And I hope that day will come. And I have tried my best from our end, with speaking to those medical companies here to see how we can get that. And then there are other doctors, likewise, we have tried that. But it's not been an easy job. But if there is an initiative from the government point of view, things will be much quicker. And I hope that is the case too. Thank you.
Cesar, sir.
Sir, Shashidharan sir has some connectivity issues.
Okay. Then I will introduce the next speaker. Thank you, Dr. Kishore. We'll come back at the end of the session for the interactive session. I'm happy to introduce another expert at our national level, Dr. Pendapal. He's a professor in Institute of Childhood, Kolkata. He is interested, and he's running the pediatric rheumatology clinic there. He's a consultant in other institutions, and he's president of Pediatric Rheumatology Society, and he has a lot of publications to his credit. We'll hear from him that about the national status of the MISC. Over to you, sir.
Thank you, sir, for that nice introduction. And thanks.
Sir, you are not audible, sir. Your sound is not enough.
Oh. Am I audible now?
No, no, sir, not enough, sir.
Still not audible?
Okay, it's fairly better.
No, it is okay to others.
Okay, then okay.
Okay. I thank the organizers for inviting me, and thanks for the introduction. So, I've been asked to discuss on the Indian perspective of things. So let us start with the scenario. So that was an excellent presentation by Dr. Kishore. So he took us from the origins, from where it originated. So we got so front eyesight into what was really going on. So where it originated, where it all began. So as I say that the world was passing through as a deja vu. So they have seen some things like this before. They have seen Kawasaki disease, and they were seeing something which resembled the disease, but not totally. So they were a little confused. And of course, the UK people brought out, they described, the NHS described the disease by end of April 2020. And you can see by the May 2020, there was a flood of publications, international publications from both sides of the Atlantic. So UK, US, and other European countries, there was a lot of publications so describing the conditions. So what about the Indian journey? So you can see it was sometime around May 2020 that there was a publication in Indian Pediatrics from Chennai describing a hyperinflammatory syndrome in a child with COVID-19 treated successfully with IVIG and tocilizumab. So possibly this was the first literature on MISC from the Indian subcontinent. So our journey from Calcutta started a little later. So we have been attending all the seminars, all the international webinars. So we are anxiously waiting to see our first case. And since Calcutta also peaked a little later, the first wave started a little later. So of course, the MISC cases also started happening a little later in Calcutta. So we had our first patient in July, beginning of July 2020, when she presented with high fever, bilateral non-purulent conjunctivitis, and a strange looking rash. She had coronary artery lesions, and she also presented with hypotension. And since we were already sort of trained by the global flood of webinars, so that was not difficult for us to pick up. So, and in fact, we published this also in IGP, the first patient. So it was a very exciting time for every one of us that time. And so by that time, by June 2020, when we were seeing 1 or 2 patients in Calcutta, Mumbai had already seen a lot of patients of MISC. And you can see, so they had a publication on 23 patients again in India Pediatrics. So this was a big series from Mumbai. So possibly this was the first series of from 4 hospitals. This was from 4 hospitals in Mumbai, tertiary hospitals, that this was a series published in July 2020. So this was the first series from India. So let us concentrate on Calcutta. So actually, we lag behind. We do not have a uniform national data. So of course, I think a lot of centers have individually maintained their data, but in Indian centers, we do not have a collective Indian data. So we had publications from different parts of India. So I'll be just taking you through our own experience of the first wave now. So July to December 2020, so we had 75 children, and you can see the peak occurred somewhere in the month of November. So it was a little delayed because, again, as I said, so West Bengal, the part of Eastern India, it peaked a little later. And again, it was around 6 to 8 weeks that we saw the peak of MISC patients or the PIMS TS patients. So again, as it was observed globally, the patients were a little of the higher age group. Our median age was 11 years, and 42.5% of the patients had a history of contact, and about 91% were COVID IgG positive. So if you look at the spectrum of the disease, so all of them had fever. So that was a uniform thing, that all of them had fever. We had 86% of patients who had rashes. So you can see a varieties of rashes. So annular looking rashes, erythema multiforme like rashes, so erythroderma like rashes. So we had a variety of rashes, and rashes also involving the palms and the soles. So 95% had bilateral non-purulent conjunctivitis. So this was definitely much more, this these rashes and than the global data that was described. So a significant number of them had CNS infection, ranging from extreme irritability to sometimes drowsiness and obtundation. A lot of them had meningitis resembling, neck stiffness resembling meningitis, and some also presented with complete delirious behavior resembling an acute encephalopathic syndrome. But again, the most important aspect was the affection of the heart. So it's a matter of the heart, and that was the most important cause of morbidity and intensive care admissions. So 28% developed hypotension, and almost 17% of patients required inotropic support. So you can see almost 20% of patients had low ejection fraction, and 27% had coronary artery affections. But luckily, none of our patients had dilatations exceeding a Z-score of 5. So regarding the lab investigations, the overwhelming thing was a very, very high CRP. So we had neutrophilic leukocytosis. The platelets are normal to low, but very high CRP. And procal was also raised in a lot of patients. The median procal was 18.5. So you can again understand that procal is a marker of inflammation and not a marker of infection, because none of these patients had any sepsis associated with it. So it was just a marker of inflammation which caused the very high procal values. Almost uniformly, we had hyponatremia and hypoalbuminemia, and it was present as early as day 3 in majority of the patients. So hyperferritinemia was there, but not very high. And again, we had a lot of patients with very high NT-proBNP values, usually much more than the Kawasaki disease patients. The mean was something around more than 10,000. And IL-6 was raised in about 95% of the patients. So this was a new condition, multi-system involvement, and sometimes because the criteria was entirely clinical, there was a lot of diagnostic dilemmas. Sometimes we had patients presenting with lymph nodes mimicking suppurative lymphadenitis. You can see big lymph nodes in this MRI resembling a suppurative lymphadenitis. And again, we had a patient which presented with a retropharyngeal phlegmon. So this was a condition that was described in Kawasaki disease, but this was again something new for us in PIMS or MISC, and we had published it also as a clinical picture. So again, the purely encephalopathic presentation. So acute encephalitis beyond the usual. So again, patients presenting with encephalopathy, with delirious behavior, with very high CRP again. And if the CSF is normal, think of this condition. Rashes resembling HSP-like rashes, vasculitic-like rashes. And again, some of them presented with thrombosis. You can see this patient had thrombosis of the brachial vein. And this child also had transient APLA positivity, which was negative subsequently. We had a couple of newborn babies who really gave us a nightmare. So this was one baby who presented on day 21 of life, initially suspected to be sepsis, subsequently went on to develop these rashes, went on to develop hypotensive shock, had to be ventilated, put on IVIG, methylprednisolone, extubated, and again went on to develop a second bout of hypotension and myocarditis. So this was a really stormy neonatal period this baby had to, but subsequently the baby went home. Arthritis of large joints. So this was again something that was sometimes we are seeing this in these patients. Some of the X-rays were really confounding. Majority of the X-rays were normal, but you can see sometimes you can see this X-ray over here. There was effusion. A lot of them have polycerocytis, and this was again a very confounding X-ray, but you can see following therapy. So it was basically secondary to a heart failure. So because again, the condition is completely a clinical diagnosis. There's a lot of mimics. So conditions like systemic arthritis can occasionally mimic because of this high TLC, high neutrophil, high CRP, and occasionally you can have coronary artery dilatations also. So, and antibody positivity is now quite rampant. So you can have conditions like systemic arthritis mimicking this condition. So gastrointestinal complaints, as Dr. Warrior already pointed out. So in our country, enteric infections sometimes mimic, and occasionally we have patients presenting with abdominal pain mimic an acute appendicitis. And not to forget, with the onset of monsoons presently, another condition, scrub typhus, because again, you have patients presenting with fever, rash, counts, neutrophilic counts, not very high platelets, high CRP, and occasionally encephalopathy and serositis. So do not forget, scrub can mimic this condition. So one must remember that now that antibody positivity is quite rampant. In fact, ICMR said that almost 60% of the children are now antibody positive. So febrile child with COVID antibody positivity is not equivalent to an MISC, presently, especially now. So we had treated majority at that time with IVIG. A lot of them received steroids as well. The doses of steroids varied from 2 to 30 mg per kg. The rule of thumb was the sicker the patients, we would use higher the dose of steroids. And none of the patients succumbed to the illness last year. We were lucky last year. So what about the second wave? So second wave, May, June, we had around 50 patients this time. Now, if you have a comparative analysis we did, so now the median age somehow or the other came down in the second wave. So the median age came down to 6 years, and a lot of patients we saw, in fact, less than 2 years, resembling Kawasaki disease. We had some infant patients also this time. And so the rashes were again a little less this time with the second wave, and coronary artery dilatations were more because there was more of that KD phenotype presenting. The PICU admissions were more, and a lot of these patients presented with the only febrile phenotype. So just nothing else, but just fever and raised inflammatory markers. And unfortunately, in fact, although we had thought that we had really tackled the first wave and MISC well, we had 3 deaths this time. So one was due to a macrophage activation, and 2 who had presented late with late referrals. So treatments, again, this time we have been a little more, we have learned the use of steroids much more. So we have been using steroids even more than IVIG, and 3 of the patients who had refractory Kawasaki disease like precipitation or aneurysms required infliximab this time. So this was a paper recently which came out in Indian Pediatrics from Kerala, which said that yes, methylprednisolone can be a good alternative again, and it has favorable short-term outcomes. This is just a comparative study of the treatment guidelines proposed by the ACR and by our own Indian Academy of Pediatrics. So you can see again Indian IAP guidelines that shows that patients presenting with shock or multi-organ dysfunction, you can straight away go to methylprednisolone and IVIG. So awareness. What saved us was awareness. So we were already trained about the condition. So this, everyone, all pediatricians, including physicians, because there is something which is known as the MISA. Adults also are getting this MIS. So majority again are more than 5 years. You can have protein presentations from acute abdomen to encephalopathy and shock. So investigate on minimal suspicion. So the classical is normally TC with platelets, neutrophilic preponderance, and very high CRP, low sodium and low albumin. And usually there will be antibody positive, but a negative antibody report does not negate the diagnosis. And again, a word of caution, febrile child with antibody positive is not equivalent to a diagnosis of PIMS. So almost every one of them will require immunosuppression or some immunomodulation. So if affordability is an issue, which is definitely a concern for us, so you can just get away with methylpred. And now that our confidence is also built up with use of steroids. And again, sick children with hypotension or multi-system involvement start with 10 to 30 mg per kg, and the maximum dose is 1 gram. More unstable, higher the dose will be required. And please do not order for any child indiscriminately D-dimer, LDH, ferritin, and NT-proBNP, because these are fancy tests, and most of the times, any febrile child, a lot of people are doing this test nowadays. So it really just creates a lot of confusion. Nothing conclusive comes out from this. And this was this came out last month, I think, from Amrita Institute in Kochi, Professor Suma Balan's team. So child with MIS recovers, and this only goes on to show this child was on ECMO, came in with complete hypotension, the heart was not really beating, and just some support just reverse the situation, and the child went back healthy. So this is I think the entire story of MISC. So it's a very, very acute, stormy presentation, but the right support, right amount of support at the right time can completely reverse the condition without much of residual effects. So the important message would be to think, diagnose, and definitely individualize the treatment. And when you treat, hit hard, hit fast, and often. You need to hit often, because sometimes you need to step up the immunosuppression. You may start off with maybe methylprednisolone of 10. You see that the patient is not responding, go up to 30. So do not shy away from increasing immunosuppression if your patient is not responding. Thank you.
CC sir is there. I think sir has got some connectivity problem. Thank you, Dr. Bringer. It is an excellent talk. And just one or two comments. In Kerala, the point which is stressed is about the mimics. We are all considering all the fever rash situation like lepto, rickets, seals, dengue, everything, staphylococcal toxins, everything was considered here. Here only there is one more thing which has come in the coming month, which are going to have Zika now reported in Kerala few weeks back, and we are having almost 40 plus cases of Zika, and maybe in the coming months it will come in the other districts also. So there is a need to be careful about this also is coming as a mimic. So one thing which we should be careful is the conjunctival congestion is one thing which is to be considered, and the other thing, fever is not that high in case of Zika, and the MISC also fever will be not that high, and the blood counts will be useful because blood count will be almost normal. It's easy to differentiate dengue because the low count and the low CRP will always be helpful, but this is one situation where IgM with a negative NS1 will be helpful, because there's a cross reaction in Zika and dengue, where usually we get IgM positive also, false positivity, and NS1 negativity. So that's the only thing is that Zika need to be considered in the Kerala scenario in the coming months, one of the mimics. That's one point. About the management part, hearing Kishore's talk also, he was concentrating on the initial part, 78 cases. Over time, we are changing the management part. So what about the use of aspirin? Are we using the initial part? It was definitely aspirin, but low-dose aspirin, are we reconsidering based on the phenotype? Especially in the case with the coronary involvement, you are restricting, or should we continue in all the cases of cardiac involvement? And over time, should we restrict the IVIG thing based on the phenotype? Based on the last July 1st, the BAT study, again they recommend steroid plus IgIG, IVIG is a better response, and in a case with the shock. In the other situation, maybe steroid only has got an edge over the sea. Over time, we may be in a situation where more and more cases will be treated with steroids only. And in that situation also, more and more cases will be treated with a little lower steroid rather than going for all cases of bad situation, 30 milligram per kg, 5 days. So more and more reliance and dependability on the steroids, that too on a lower dose may come in the coming months. And one more point about the MISN. We are very likely to mistake many conditions as MISN. One very useful point is, if there is a delay, if there is a lag of onset of the problem after 2 weeks, more and more of the chance that it is an acquired condition rather than the MISN. MISN is nearer the delivery time, more and more chance that it is MISN. That is one thing. Thank you, sir, for the excellent talk.
Thank you. So, with your permission, I have to attend to something personal, so I have to take leave. Thank you, sir.
Thank you, sir. Thank you. If Sir is not there, I'll invite Dr. Geeta. Dr. Geeta is our own pediatric rheumatologist, is additional professor in Calicut Medical College, IMCH. She's in charge of the pediatric rheumatology clinic. He has years of experience. And over to you, Dr. Geeta.
Thank you, sir, for the kind words. Am I audible?
Yeah.
Am I audible and is the screen visible?
Not the screen visible. Screen not visible, you are audible.
Screen is not visible, sir?
No, share it once again.
I can't share it.
You handed over the presentation to the team, IAP.
Is it visible now, sir?
Yeah, it's sharing. It's visible now. Okay, go ahead. Make it full screen.
Okay. So, respected senior members of the profession and dear friends, I think it's very difficult to speak after two eminent speakers who have said whatever is needed to say about MISC. So, in the next 10 to 15 minutes, I'll be just sharing our experiences at IMCH in dealing with this novel, interesting, challenging disease. Actually, the first disease, it was first diagnosed in October 2020 at IMCH. So as we all know that SARS-CoV-2, the initial description of this novel strain of coronavirus happened in December 2019 in Wuhan, China. It is declared as a pandemic by WHO, World Health Organization, March 2020. This beautiful looking virus, it's lethal. It can be potentially lethal. It's, causing havoc in all our lives world over. But thank God, children are affected less commonly than adults. Symptoms are milder, maybe unrecognized. That is one boon. But as we all know, as Dr. Kishore has said, that a novel pediatric disease occurred during the pandemic. Rapid communication started coming in April, May 2020. Initial reports, Annals of Rheumatic Disease, JAMA, NHM started reporting about this disease. He has said all about the history, how it emerged in Britain. And so several nomenclatures, several definitions, several names, so many things. So what we are following here is the WHO criteria. I'm sure every person in this August audience are aware of this criteria. I need not elaborate on this. We are following the WHO criteria for diagnosing MISC in our institution. So this usually occurs 4 to 6 weeks, sometimes even as early as 2 to 6 weeks, 2 weeks after infection with SARS-CoV-2. It's an uncommon disease, 2 in 100,000. That is what the literature says. Antibody test is positive in majority, while only a few have PCR positivity. At IMCH, to date, that is till June 30th, we have had about 111 children diagnosed according to WHO classification of MISC. The first case was diagnosed in October 2020, and there were 3 deaths, 2.7%, which confirms the world data. And among them, RT-PCR positivity was found in 21 children, 18.9%. Maybe it's slightly lower number when you look at the literature, whatever. So this, I think this diagram is familiar to all of us. Inflammatory responses. You can see after the acute COVID-19, there is a delayed systemic hyperinflammation that is occurring after 2 to 4 weeks. So this is the month-wise distribution that we found in our hospital. October, there was a peak. Then December, January, there was another peak of this MISC. And then, you know, it never disappeared. In the last 1.5 years from December 2020, not 1.5 years, 8 or 9 months, you can see that it was there. It was there in the background. February, March, April, cases were there. But then again started peaking in June 2021 after the second wave. You know, it has started peaking again, but now it has again come down. We have about 1 or 2 cases. So last 2 weeks, we have about 1 or 2 cases per week. This is the age-wise distribution because we are taking only children till 12 years. So we have the maximum we have is from 5 to 10 years. And males, as literature says, male predominance is there. And we actually are treating or managing MISC after segregation, that is after classification it into mild and severe MISC. I'm sure that all the other people, other authorities are also doing like this. So we have too far mild MISC is about 49% and severe MISC is about 51%. So how do we define mild MISC? This has come in the commission paper which has published lately, Lancet COVID-19, that is published last month. This we have been following for the last few months. That is fulfilling WHO criteria for MISC, but it's a non-life-threatening condition, stable vital signs, meaning that there is no shock or organ-threatening disease in mild MISC. And this is a very good thing, a clinical spectrum which we can use it practically. So it can be divided into 3 actually: severe MISC, Kawasaki disease phenotype, and mild MISC, which is also known as febrile inflammatory state or FIS. So these are the tier 2 investigations that we usually do. And American College of Rheumatology has given strict guidelines like when should we do tier 1 and tier 2 investigations. They've said that in a child suspected MISC, if CRP and ESR are high, at least one suggestive lab feature like a platelet count less than 1.5 lakhs or hyponatremia or hypoalbuminemia or acute, absolute lymphocyte count less than 1,000 is there, you can go in for a second tier investigation. So we are usually doing it in our suspected cases of MISC, even if it is mild, because we have seen that some mild cases may go into severe if you don't monitor. So coming to some case scenarios, otherwise it'll be boring the talk. Talking about Amar, a 5-year-old child who came to us with a high-grade fever of 5 days duration, increased tiredness, occasional vomiting. He has significant abdominal symptoms also, loose stools, abdominal pain, he had headache. He was taken to a local hospital when he was given antibiotics, no relief. But on the 3rd day, he developed a rash. He had conjunctival congestion on the 3rd day also. But when he came to our hospital on the 5th day, he was in a stable cardiorespiratory status. He had maculopapular rash over the tongue, he had palmar erythema, he had conjunctival congestion, mild hepatomegaly. There's a definite history of COVID RT-PCR positivity a month back. No other significant past history, otherwise normal, well-grown child he was. This was you can see the rash he had, conjunctival congestion. So I'm sure all of us would have encountered these sort of cases. It's a mild MISC the febrile inflammatory state. And the lab showed very high ESR, rocket high CRP, SGPT, SGOT was all low, and see the platelets were low. So we went on with the second tier investigations. Sodium was also on the lower side, in which we found that very high ferritin, D dimer was also high, pro-BNP was high. All the second tier investigations were high, but the child was in a stable cardiorespiratory status. So the child was managed in the ward itself, just monitoring the child with vitals and the for developing organ dysfunction, and the child was treated with antibiotics, because we usually treat the children with antibiotics until the cultures are negative. We started the child was able to take orally. So we started the child on oral prednisolone 2 milligram per kg, continued it for 7 days, repeated the investigations like the ESR and CRP on the 7th day. So that was coming down. It's almost normalized. So we tapered and stopped the steroids. Definitive echo was normal in the first 2 weeks, and this child was followed up till 6 months, and the child is doing fine now. Repeat echoes at 6 months is also normal. 6 to 8 weeks and 6 months is also normal. So this is a typical prototype of a child with mild miss, and we had almost 50% of our children were like this. But some of these children, needed IV methylpred. We did not give IVIG to these children unless it is a KD phenotype. In children with KD phenotype, we gave IVIG. Otherwise, we were giving just steroids. But some children were too sick because of the abdominal symptoms they could not take orally. In such children, we were giving IV methylpred at a low dose of 1 to 2 milligram per kg. Now, KD phenotype is another very interesting, scenario in which you have features of incomplete or complete KD. We had only 22% of children with KD phenotype, of which only very few were, were complete KD. So this, I think all of us are aware, the differences between KD in the pre-pandemic era and KD now. As the age group is usually higher, the present KD, and GI symptoms, cardiac symptoms, shock, coagulopathy, mass, etc. are much more in the present KD illness. Thrombocytopenia is more common. CRP, ferritin, etc. are much markedly raised. D dimers and all the secondary investigations are also raised. And they say that the coronary artery abnormalities are less in the mis-KD phenotype than the KD pre-pandemic era. So these are the marked differences between the KD phenotype now and the KD which was there in the pre-pandemic era. Now, coming to another case, very interesting case scenario. It's a 2-month-old baby who was referred from Manjeri Medical College actually. This child came with the reactivation of BCG site of 10 days duration. Mother said that was the initial complaint. Reactivation of BCG site followed by erythematous lesions surrounding that site. Later, these erythematous lesions spread to the face, became generalized within 2 days. There were well-defined plaques and papules. The photos I'll be showing now shortly. Child also had very high intermittent fever, and the child was taken to a local hospital, was tested RT-PCR positive, and was admitted in the local medical college, Manjeri Medical College. From the 4th day of illness, child started having breathlessness and cough and also GI symptoms. So they isolated the child, they started the child on antibiotics plus dexamethasone. But the fever was unremitting. Fever was persisting, and also the skin lesions, peculiar skin lesions were also persisting. So the child was referred to our hospital. These were the peculiar skin lesions. You can see the large plaques here, and the dermatology people actually diagnosed it as erythema multiforme like lesions. You can see the papular lesions at the back, on the face, on the scalp. And this child from Manjeri Medical College X-ray showed viral picture. So this child was oxygen dependent from there. They gave antibiotics and also steroids, and the child was referred from there. But once the child reached here, child was in a stable cardiorespiratory status. There was no tachypnea, tachycardia during fever, but fever was persisting. But child did not require oxygen. So investigating from here, we found that hemoglobin was low. TC was very high. Platelets were also high. But see this, ESR was low and CRP was 144. ESR from the other hospital was very high, but ESR has fallen. So this disparity actually, put us on our guard. And when we saw the other investigations, SGPT was 80, serum albumin was low, ferritin was very high, 3000. Triglycerides were high, fibroid was low. So this was a mass type. The child had developed mass. So this actually, the diagnosis is, very, very interesting. Like child is RT-PCR positive, had COVID pneumonia. So miss overlapping with acute COVID, also miss overlapping with the Kawasaki phenotype. Child also developed mass. And this child improved very well with IVIG and methylprednisolone IV, which we gave about 30 mg per kg. Child became all right. The fever came down within 24 to 48 hours. And child became well. Child was discharged on the 10th or 11th day. We did a definitive echo, which was normal. And then repeat echo at 6 to 8 weeks was also normal. There were no coronary dilatations. So this was a peculiar child KD phenotype with mass. This was published in a journal of skin and sexually transmitted diseases by the dermatology persons. So they said it is an erythema multiforme like lesions. These type of lesions we could find in some other children also. So this, all of us are aware, the clinical picture of, I need not elaborate. So I'll just go through what we had in our cohort of groups. In our group, we could find that fever was there in 100% of children. GI symptoms were there in a very good high percentage. Almost 90% of children had significant GI symptoms. This was actually concurrent with other studies. And also rash was there 64 to 70%. Conjunctival congestion was there in a very high percentage, which is not there in other studies. Similarly, some unique features the child had. These children had scrotal pain was there in 13 children. Hypertension was there, maybe due to steroids, was there in 6 children. Respiratory symptoms were generally low. Serositis, pericardial inflammation, and ascites were there in 5 children. So this is, to put in a nutshell, are clinical features. CNS symptoms were there in about 33 patients, almost 30% of children. Seizures were there in 5, and most of the seizures were well controlled. Well controlled quickly. Only one child had prolonged seizures. So headache, lethargy, irritability, and confusion were there in some children. Shock was there in 48% of children. Shock, and out of which 24% had a normal cardiac echo. That is, the contractility was normal in about 1/4 of these children with shock. So the echocardiographic findings and all will be discussed in the next session by Dr. Jayakrishnan. Now, these are the clinical features we usually encounter. These are some of the studies came in BMJ. See, cardiac disorders are seen in 75% of children. Shock is 67%. We had only 50 to 52% of shock. This again a systematic review about MISC that is came in Pediatric Infectious Disease Journal. Now, we had some interesting features like acute appendicitis in a few children. That is, we had right abdominal pain, right iliac fossa pain, and they were admitted in the pediatric surgery ward. And some had appendicitis, appendicular inflammation, USG also. One child had acute pancreatitis. 6 children, as I already said, scrotal pain. Few children had serositis. Transaminitis is something which we found in the hospital and also during follow-up. Almost 40% of children in our study had transaminitis either during the hospital stay or after discharge. That is, from 2nd to 4th week of illness, they had increased SGPT, increased SGOT, and some of them had increased echoes in liver, but everything settled within a month. Don't know whether it is due to the disease or to the steroids. Then meningitis, meningeal signs were found in some children. We had to do LP. Erythema multiforme like lesions were there in a few children. Subconjunctival bleeds were also found in a few children, which is one thing which we found. I think the Trivandrum people have also found the subconjunctival. Dr. Sheija from Trivandrum, she has also reported subconjunctival bleeds. So these are some of the eye findings we had. You can see the subconjunctival bleed, which took time to resolve, took about a month or so to resolve. You can see the conjunctival congestion, the KD type, the strawberry tongue, lip changes, the peripheral extremities rash. Palmar erythema was found during the disease and also during follow-up. Rash on the trunk, again another type of rash. The erythema multiforme like lesion which we found in an older child, Palmar erythema. So these were all from our children. Now, coming to the investigations, we found that 100% of children had elevated D-dimer and a very high percentage had elevated procalcitonin and elevated pro-BNP. We could do COVID antibody test only in 60 to 65% of children, and what we could do, 75% were positive for COVID antibody. Now, others, hyponatremia and hypoalbuminemia were also found a significant number, especially in sick patients. Thrombocytopenia was found in 40% of children. And in the KD phenotype, which I forgot to mention, 50% of them were severe variety, and 50% of them had thrombocytopenia also. Now, coming to what happened in the wards, they are generally transferred from ICU. The mean time in the ICU was from 2 to 20 days, depending upon the severity of the illness. In the wards, they were monitored closely. And suppose if there were any investigations which are grossly abnormal, we tend to repeat it. We don't repeat the second tier investigations. On the 7th or 8th day, we do an inflammatory marker. Again, repeat the inflammatory markers, CBC, and all the LFT and RFT are also usually repeated. And once, if the CRP is normal, we usually taper out the steroids, and they are tapered and stopped. And this is what we are following. Oral prednisolone 2 mg per kilogram per day until day 7 or till CRP normalizes. Then 1 mg per kg per day for 7 days and 0.5 mg and 0.25 mg, and stop within 2 to 3 weeks. Follow up, we have an ongoing study in the department. So we follow up these children at 2 weeks, 6 to 8 weeks, 3 months and 6 months, or as and when they come. Echo is done usually during hospital stay at 6 to 8 weeks and also at 6 months. But as you all know, because of the COVID situation, we are not being able to get these children coming regularly to the hospital. So some of them, we ring them up, we ask them to do investigations from local hospital and send them by WhatsApp. That's what we are doing, or talk to them, video call them, any problem. So we are doing like that also because they can't come. They say that they don't have the money to come, they don't have the vehicle to come. So many things, you know, we have to understand that. So when they come, we do a complete physical examination. We do a the GIT, nervous system examination are usually done. And these are the investigations we usually do: CBC, ESR, CRP, LFT, and RFT. And at the end of 6 months, we are also doing a 6-minute walk test. Follow-up data. 43 children of our group have actually gone into 7th month of their illness. They have finished 6 months after disease onset. And 23 children have reported to us, and all these 23 children are essentially normal. We have done a detailed physical examination, that is normal. We have done a 6-minute walk test, that's also normal. And we have been able to do echo in about 18 to 19 children, that is also normal. About 3 children had coronary artery abnormalities, and which also settled. 9 are lost to follow-up, and 11 we have reported at 11 have reported till 3 months. Maybe they will repeat now. Now, they will come to us shortly. 38 children are on to 3 months of follow-up, of which 20 children have reported. And out of these 20 children, you know, we have not done an echo at 3 months. 2 had coronary artery abnormalities, which are not settled. So I would like to talk about a child, you know, this child, 4-year-old child who came to us. Initially, you know, this child was taken as miss, but this child was actually fitting in with all the clinical features, or all the, the criteria for Kawasaki was fitting for this child. This is a 4-year-old child, boy. And this child was IVIG resistant KD. We had to give IVIG twice and also give steroids for the fever to come down. But on the second week of illness, this child developed arthritis of small joints and a recrudescence of fever. Again, the fever, came up. Then we did an echo. Initial echo in the first week was normal. Then we did an echo. Then we found that this child was having aneurysmal dilatation with a huge thrombus in the LAD. So, and COVID antibody was negative for this child, but there was a history of COVID in the family. So this child, we gave infliximab to this child, and we gave heparinized the child, and following that warfarin, clopidogrel, aspirin. But 1 month later, this child was readmitted with tachypnea, tachycardia, and we could find ICU people detected, team detected that there was a left anterior wall MI. for this child, showing features of anterior wall MI, and this child was taken up by Sri Chitra. They actually did a CABG for this child, coronary artery bypass. Initial 12 hours, child was well, but suddenly the child collapsed and died. So actually speaking, this is something that can be discussed because we don't know whether this is actually MISC or whether this is actually KD. This child was fitting with all the features of KD, had giant aneurysmal dilatation with thrombosis. COVID antibody was negative. We have included this child under MISC. So the other child with CAA has mild dilatation. It is still there. We are following up that child. Now, during follow-up, we could find some minor problems. As I said earlier, coronary artery abnormalities were found only in 6 children, contrary to the other studies which showed a very high incidence, 30% incidence. Actually, I don't know what's the cause. Hypertension was detected in 8 children, probably due to steroids. It all became okay. They all became okay with the antihypertensive. One child, developed press. Now, transaminitis, as I already said, was seen in 40% of children. Alopecia, 10%. Fatigue was there in 20%. Headache, vague pains, which all settled, quickly. Headache and abdominal pain. Palmar erythema was something which we noticed 35% of children, which again settled. Minor rash.
Short of time.
Cholecystitis was there in 3 children. Nail changes were there in 6% of children. So this was a 6-month multidisciplinary follow-up study that came in Lancet. Here, normal echocardiogram was found in 96%. Yes, 1 minute more. 13% had GI symptoms. In this study, 39% showed neurologic findings, but here it was not there in our cohort. So these are some of the, posters which are seen in the follow-up. Nail changes, etc. So to conclude, MISC is a highly intriguing, challenging disease. Early recognition is very important. We have to be aware and vigilant. Important to consider the clinical phenotypes that we know. Other diagnoses to be considered. Better not to overtreat. We have had treated children with MISC, which has turned out later to be Sogia, staph sepsis. Because of lack of time, I have not gone into the mimics. So if treated timely, properly, outcome is definitely good. Thank you.
Thank you, Dr. Geeta. We had to interrupt you because we are running short of time. So I think there is no time for an interactive session. Thank you all experts for sharing your experiences. And I think we'll wind up thanking you once again.
Thank you, Purushottam sir. As you said, we are running short of time. So even though we planned a buffer time in between after this session, we are not taking that buffer time. We will move to next session. Shahana, please invite.
Okay. After the elaborate session on MISC, the next session is on the management of MISC in the pediatric ICU. And our speaker is Dr. Jayakrishnan MP. And the chairperson is Dr. Janaki Menon, additional professor in pediatrics and head of the department, Government Medical College, Thrissur. She is also in charge of pediatric nephrology clinic at Thrissur Medical College. Over to you, madam.
Good afternoon. Good afternoon. I'm happy to be here at this big conference to introduce Dr. Jayakrishnan, who is going to talk about management of MISC in the pediatric ICU. Dr. Jayakrishnan is an old friend and colleague, and he heads the pediatric intensive care unit at Calicut Medical College. He is an additional professor in pediatrics. He has had the fortunate or unfortunate experience of having to manage this horrible disease called MISC in more than 100 patients. And we are happy to be here to hear him share his experience. Jayakrishnan.
Shall I start sharing my screen?
Yeah, please do.
Janaki, can you see that?
Okay, Dr. Jayakrishnan. It's visible.
Okay. Thank you. I'll make it the play mode here. Okay, good afternoon, friends. Thank you, Dr. Janaki, for those kind words of introduction. And it's now the same topic again. We have heard this the international perspective from Dr. Kishore, national perspective from Dr. Priyankar Pal, and our own Kozhikode experience from Dr. Geeta. Now, what I plan to do in the next 10 or 15 minutes is to just to give you a very brief overview of what we do in our PICU about these children with MISC, and also discuss the management of MISC proper. Okay. Start with this child, 8-year-old girl who was admitted towards the end of 2020. She presented with 8 days history of fever, vomiting, reddish eyes one day, and rash all over the body for 1 day. She was alert, febrile, but had a very fast heart rate of 146 per minute, tachypnea. Saturation was low in room air, delayed capillary fill time, feeble pulses, and hypotension. I mean, it was actually on the lower side, 90 BP. Compensatory shock this was. And she had all the features of conjunctivitis, generalized rash, and we tried to treat her with fluids. She was fluid intolerant, managed with inotropes, started antibiotics, very poor LV contractility. She required escalating doses of inotropes. We started making the diagnosis of possible MIS-C, IV methylprednisolone and IVIG. She was intubated, mechanically ventilated. Very high inotropes she required. 6 hours, her vasoactive inotrope score was 50. Fluid refractory catecholaminergic resistant shock, and she developed severe hypoxemic respiratory failure. She was already intubated on ventilator. Poorly controlled shock persisted, and she expired at 40 hours post-admission, unfortunately. Okay. So in the PICU, what are the indications? We generally admit all severe cases, and we define severe cases with when any of these signs are there, like tachycardia, tachypnea, any child with respiratory distress, shock, obviously, any neurologic deficits. In fact, that includes extreme irritability also, which is a very common feature in many of our cases of MISC, like what Dr. Geeta mentioned. Altered mental status, altered organ function, very high CRP. I'll come to that again, the cutoff that we, the highest value that we usually get. Abnormal ECG, abnormal cardiac enzymes, or BNP. And basically, as far as a physician working in the intensive care, what we are worried about is the cardiorespiratory status. So the important management issues that we face are shock, respiratory support, respiratory distress requiring in support, and also organ dysfunction. And immunomodulation and other therapy are also there. But mainly it's stabilization of the cardiovascular status that we are worried about. And for shock, we follow, and this is what is to be followed, like standard protocols, like any other child presenting with shock. We have found these children to be, almost all of them, fluid intolerant. Generally, we try with fluid bolus initially, but we are careful not to start too much fluid. Like we generally start with 5 to 10 ml per kilogram over 30 minutes, 20 to 30 minutes, and see if the child is responding to fluid or intolerant to fluid, like looking for increasing respiratory distress or increasing liver size. Generally, we prefer adrenaline, or noradrenaline also can be used. If there is LV dysfunction by echo, we generally start with adrenaline. Because noradrenaline, it can cause further, increased peripheral vasoconstriction, which can sometimes worsen the LV function. And the child is not very hypotensive, we generally start them on additional inodilator like dobutamine also, if there is LV dysfunction. Severe LV dysfunction may require an IV continuous. We generally use this IV continuous furosemide infusion if the child has LV dysfunction and respiratory distress persisting. HFNC or NIV, we mechanical ventilation was required only in 3% of children in our cases. And unfortunately, we do not have ECMO in our hospital. This topic, this point has already been discussed. If that is there, again, it can be given. And immunomodulation, it is a controversial subject. Till now, we do not know which exactly is the preferred mode of immunomodulation these children require. There have been many papers in the month of July. These were discussed by the previous speakers. These two papers, one has mentioned as IVIG plus glucocorticoids to be superior to IVIG alone, and the other one, the second one in NHM again. These three, IVIG alone, IVIG plus glucocorticoids, and glucocorticoids alone were compared, and there is no significant difference between these two. And by paper from our own state, Shrija and her colleagues have had this study on 32 children, where they have shown methylprednisolone alone to be associated with favorable good outcomes. So we do not know yet which is the best possible treatment. Maybe the time will tell us. And this is actually the protocol published by the IAP. And this is essentially the principles are the same. What we follow in our ICU is all the same, like a severe child presenting with, severely ill child presenting with shock, the so-called the non-KD phenotype. We start them with IV methylprednisolone, 10 to 30 milligram per kilogram per day, dose, and also IVIG. Generally, the problem with IVIG infusion is that might sometimes add up to the fluid overload that you are infusing. So we generally do not give it over 12 to 16 hours. We take maybe over 2 days. Start all these children on empiric antibiotics till we get the cultures. And also we start generally on low dose aspirin also. See, the child comes with KD phenotype, we start with IVIG to begin with, and also IV methylprednisolone. If the child is not very sick, we start with a lower dose, like 1 to 2 milligram per kilogram per day of methylprednisolone. Then if the child becomes sick, shock persists, we increase the dose of methylprednisolone to 10 to 30 milligram per kilogram. Aspirin and anticoagulation, I think these have already been dealt with. We start, one point is that we start all the children, sick children getting admitted in the ICU on prophylactic low molecular weight heparin if they present with shock as a prophylactic dose. It's 1 milligram per kilogram as a single dose daily. All children having severe LV dysfunction with ejection fraction less than 35%, large coronary aneurysms with Z score more than 10, visible thrombosis there or DVT, we generally start them on therapeutic dose of low molecular weight heparin 1 milligram per kilogram twice a day. These are some of the experiences published recently in the literature from India. This is from PGI. Just one point is that they had a very high, large number of cases who required invasive ventilation, 23%. And another one from Bombay, total number was only 21, but still almost, more than half, 62% of them required invasive ventilation. Mortality was 14%. We had in the ICU, total of 104 cases till the end of June. Half of them presented with shock. We had to ventilate 5 of them, 5% this. And our mortality, as Dr. Geeta mentioned, is 3%. This is just a comparison of those three from us. I think the mortality is low in our hospital. The number is more, and maybe the problem with other centers in North India and Western India, probably cases are referred late. That's one possibility. That the reason why many of them or a large number of them get mechanically ventilated. Our rate of mechanical ventilation was only 5. And our average duration of ICU stay was 3.5 days. What we have seen in our ICU is that most of them, like Dr. Kishore and all others mentioned, comorbidities very few in these children. 1 or 2 children, or just 2 children had an underlying illness like leukemia or a rheumatic heart disease one child had. And another point that we noted, it is noted by many other people working in the ICU also, like sensorium is normal, even with hypotensive shock. Towards almost the very end, then after that they become, once they become really ill, obviously the sensorium will worsen. And unlike what Dr. Kishore mentioned, what we have seen, at least clinically, is that most of them have cold shock. And many of them, after correction of shock, have these features of respiratory distress persisting due to pulmonary edema on the 2nd or 3rd day. And we have found very good response with low dose infusion of furosemide as a continuous infusion rather than intermittent furosemide. And also use of high flow nasal cannula also in these children, we have found very useful. Urticaria and angioedema are there occasionally, possibly different from many other case series, and subepidural bleed, as Dr. Geeta mentioned, not very infrequent in our cases. Many children have antibody positivity for rickettsial infections, leptospira infections associated. That's the reason I think why we need to consider all these illnesses, especially in our country. But I think false positivity is also there for rickettsial and leptospira antibodies. We have found very interesting ECG abnormalities also in many of these children. I'll come to that again after some time. Nephritis, and as Dr. Geeta mentioned, there have been many cases which actually landed up in the pediatric surgery ward first with the acute abdomen. Appendicitis is a very common diagnosis that is often considered. In fact, many of these children were actually posted for surgery also. And another thing is shigellosis, which is very common in this part of the state. It's Kozhikode area, North Kerala. And shigellosis, sometimes severe shigellosis presents almost like MISC with sometimes encephalopathy, but some encephalopathy may be there only with extreme irritability. And they can present with features of myocarditis also, with shock. And if you do investigations, they will be having CRP and other inflammatory markers elevated like 60 to 80. And also sometimes lymphopenia also. Lymphopenia is a very common association with shigellosis, severe shigellosis. So it's a close DD. And if there is a history suggestive of shigellosis, like other family members also having diarrhea, loose stools, we generally test them on Shigella PCR also, which we found positive in many cases. This was another child, 12-year-old, generalized rash, cracked lips, edema legs, all features suggestive of MIS-C with a fast heart rate, shock, hypotensive shock. And this was a very interesting ECG that we saw, wide complex tachycardia in this. All echo was showing severe LV dysfunction, elevated inflammatory markers, elevated cardiac enzymes, PNP. It's like an LBB pattern. This child had only intermittent episodes of this and responded very well to our usual line of management of shock and immunomodulation. There have been many ECG abnormalities found in these children, not widely, very much published in the literature, but many children have cardiac conduction abnormalities. And sinus node dysfunction is a very common abnormality that we've seen. Almost 30% of our children have this sinus node dysfunction in the form of sometimes wandering pacemaker, sometimes an altered like junctional rhythm, or sometimes coronary sinus rhythm. So, and T-wave changes also. What we have seen generally is initially to begin with, they have this sinus node dysfunction, which progresses gradually to these T-wave changes. They have an abnormal T-wave axis, like sometimes you get global T-wave inversion up to V6. T-wave alternance also, which is actually a dangerous situation. This T-wave alternance is an unstable situation. It can progress to a polymorphic ventricular tachycardia very fast sometimes. So prolonged QT is also a very common association that we have seen in these children. Sinus node dysfunction like this, you can see absent P-waves in many of the complexes there, a junctional rhythm. You can see the abnormal voltages in the T waves, like positive and negative alternating or varying voltages of T wave alternance, which is usually associated with the prolonged QT situation. And this is actually something that precedes the development of a dangerous arrhythmia like a polymorphic VT also. So you have to be very careful about this and need to look for that to recognize that. What I have felt is that unless you look for these subtle ECG abnormalities, you will miss them in these cases. It's not very uncommon. In acute abdomen, we have already discussed this, and this was published in Lancet in 2020. What suggested is that if you do an abdominal CT, it is very easy to differentiate this MIS-C from acute appendicitis. Acute appendicitis will not show this kind of a picture. Like, see this, what is described here is a thickened terminal ileum and also the mesenteric nodes and edema that is seen. But appendix is relatively normal. Like in the second CT scan, you can see that. First one is an ultrasound, but CT actually will tell you whether this is appendicitis or not. In fact, one of our children recently admitted had all features of appendicitis, acute abdomen, but the surgeon actually, he rang me up in the early morning, he rang me up and asked me whether this could be Miss C, because he had seen many children with Miss C presenting like appendicitis. But as I said, we can take an CT abdomen and see, because the child is presented with high fever and severe abdominal pain, and the guarding was there. And the CT actually, in fact, is showing a normal appendix, but then CT, and then if the CT is normal, I said this is more likely to be Miss C. But then what was actually, the report had also mentioned that there are septic emboli seen in the part of lungs that was visible in the abdominal CT, and you need to rule out a staphylococcal infection. So when we actually gone back into the case again and took the history, the child had a history of a wound in his leg some 2-3 weeks back, and also he had blood culture growing staph aureus later. So staph sepsis was there. So you need to look for all other causes, and always remember that Miss C is an exclusion diagnosis before coming to the diagnosis of, starting treatment. That's very important. So early diagnosis and initial treatment, as has been mentioned by all the previous speakers, is the key for survival in Miss C. Meticulous monitoring of severe cases in the PICU makes a difference. You need to look for subtle changes that can happen, like arrhythmias, to anticipate a worse outcome. And always remember that it's a rule-out diagnosis. And other serious infections like shigellosis, staphylococcus sepsis, SLE, infectious and infective endocarditis, all can be missed unless you actually think of all the rollout possibilities. And missing the diagnosis could be fatal. So missing the diagnosis is also dangerous, risky. You need to think of that. Thank you very much. Janaki?
Yeah, thanks so much. Yes, I'm here. Thank you very much. That was an excellent, the 2 cases with so insightful and bringing out things that people do not generally talk about. So you talked about the different kinds of arrhythmias, which yes, we do see, and we do not really talk about much and during these kind of sessions, and very subtle changes which could tell us, which like you said, make the difference between life and death. Thanks very much, Dr. Jayakrishnan. I think we need not take any questions as everyone is running short of time. Is that right, Ashraf?
Yeah, Janaki, your co-chair is there, Dr. Naveen. Dr. Naveen,
is he here? I thought he would not be here. He had told me that he would not be here.
Okay.
He had told
His
me
name
he
is
would not
there,
be here.
but some brain problem. Okay.
He is traveling.
Short of time, there's a rearrangement in the topic. Now the panel discussion will be at the end. Now we will go on to the next session.
The next session is on Let's Talk topic, that is psychosocial challenges among children during the pandemic. And our speaker is Dr. Krishna Kumar P. The chairpersons are Dr. M.K.C. Nair, former Vice Chancellor, Kerala University of Health Sciences, Thrissur, Founder Director, Child Development Center, Trivandrum, who is working now as Director, NIMS Spectrum Child Development Center, NIMS Medicity, Trivandrum. And the second chairperson is Dr. Shaji Thomas John, Senior Consultant and Head, Department of Pediatrics, Baby Memorial Hospital, Kozhikode, who is also the past President, Indian Academy of Pediatrics, Kerala. Over to you, sirs.
So good afternoon. It's a great honor to listen to Dr. Krishna Kumar, particularly on a talk related to the psychosocial problems. We know that COVID has created a lot of psychosocial problems. We are all aware. A systematic review of 17-18 articles have shown up to 40% children having anxiety, depression, other sort of problems. Since the time is only 15 minutes, I will request Dr. Krishna Kumar to initiate, give the talk, and my co-panelists will give the comments immediately. Co-chairperson, rather, sorry. Shaji, you are there?
I'm here. Well, Dr. Krishna Kumar is the director of the Institute of Mental Health and Neurosciences
He has about more than 20 years of experience in child psychiatry research and teaching. He has an MD in psychiatry as well as a DNP in pediatrics. He has many publications to his credit. He has a human service to children with disabilities and psychosocial problems. What I see in him is a totally unassuming person and a very soft-spoken person. So over to you, Dr. Krishnoma, for the topic of psychosocial challenges among children during the pandemic. Dr. Krishnoma.
Thank you. Sir, audible or not? Am I audible?
Yes, you're audible.
Yes, Krishnoma. Yes, you are audible.
Respected Chairperson, Dr. M.K.C. Nair, Dr. Shaji Thomas John, and dear friends. At the outset, I thank the IAP and the Department of Pediatrics, Government Medical College, Kozhikode, for giving me this opportunity. In fact, Dr. Tanu Singhal has made my task easy. In her very lucid presentation, she has pointed the indirect effect of COVID-19 on children. What I try to do here is only to elaborate on what she has already indicated. So we'll be talking on the environmental influences on developing brain and how the COVID-19 affect the brain development and mental health problems in children during the pandemic and some tips to cope with the stress. We all know that developing brain in utero and during the first few years of life is highly vulnerable to environmental influences. What we usually say is the developing brain is in a dynamic interaction with the environment, and all changes in the environment will influence developing brain. And the scars occurring during the early developmental period is difficult to heal most often. And they talk about critical periods or sensitive periods in the life of an individual. For example, the early years, the toddler period is critical period for language development. So during this critical period, if the brain doesn't receive the appropriate environmental stimulation, the development can be affected. We did a study recently. It's actually an association. There is an association between autism spectrum disorder and digital media exposure and early social experience. An interesting finding was that stress in the mothers during the antenatal period, that is more in children with ASD compared to typically grown children. And ASD children, they spend more time in front of digital media and mothers spend less time with them. Now, with this background, we see a 2.5-year-old girl recently came to our OP with delayed speech, 2 words at 1 year. Then there was regression. She was clinging to the mother, not able to keep away from the mother, with impaired social interaction, returned from Gulf, and they were in quarantine for a month. Then again compelled to be in quarantine. And usually when this type of child comes, we advise regarding sensory motor stimulation, remedial therapy like speech therapy, occupational therapy, and all those things. Send the child to a play school so that the child can interact with the peer group. But now what happens is all these things are affected. In most of the centers, group therapy, play therapy, and all are stopped. The Anganwadis, the last 1 to 2 years is remaining closed. And now we see a lot of children like this. In fact, my feeling is that we'll be seeing a lot of children like this in future. 2-year-old, 3-year-old coming with mild autistic features, impaired language, and behavior abnormality. Now, coming to the adolescents, the adolescent brain is considered a work in progress. It is not a fully cooked brain. And all these aspects, bacteria, viruses, nutrition, all these environmental factors influence brain growth during adolescence. So when we think of mental health issues in children related to the COVID-19 pandemic, we should consider these aspects, how the environmental factors influence brain growth, not only during the toddler period or under 5 age group, but including the adolescent age group also. So we'll be seeing there is the effect of vertical transmission, children with COVID-19 disease, children with parents or relatives COVID-19 infection, and the indirect effect of the pandemic, which Dr. Singhal has pointed out. And recently, studies have come that COVID infection can lead to inflammatory changes in the brain, microglial inflammation, and thyroid affecting thyroid in the mother, causing problems in the babies. So it is greatly feared that what will be the long-term impact of COVID-19 infection on the maternal COVID on neurodevelopmental disorders. It is suggested that close monitoring of these children. So what I feel is all children born of mothers with COVID-19 infection should be followed up to the age of minimum 5 years for early identification of neurodevelopmental problems, because we don't know what is happening. And added on that, now we see reports of Zika virus infection. So I'm really scared that we'll be seeing more problems in future. And the indirect effect of COVID is too much. It is not a health crisis, but it is the economic crisis. It is affecting all spheres of society. Children, adolescents form the most vulnerable group. And the previous speaker was talking about orphans. A recent study, they say 1.2 lakh Indian children lost their primary caregivers during the pandemic. And all this, we had actually done a study previously, found that death of a parent before the age of 11 years, there is a strong correlation with depression. So all these things, extended home confinement, lack of social interaction, lack of school routine, domestic violence is increasing like anything, and problems of online education and economic issues. School routine is something many speakers, the audience were commenting about the early reopening of schools. So school routine is something which is essential for the development of the child, for the developing social skills, other skills. So the change in daily routine is there, overuse of internet, and misuse of social media. Last week, I had a 10-year-old child with addiction to video games, firewall, something like that. So very young children now see coming with overuse of mobile, internet, and digital media, video games addictions. It can cause functional impairment as well as social skills impairment. A recent study from NIMHANS, they found that there is 100% increase in the prevalence of domestic violence during the lockdown period due to multiple factors. And all these are going to affect children. And we conducted a survey, a questionnaire survey among parents of children, school-going children. And they reported 86% of parents felt that their children are using digital media over and above the online education. And there is the digital divide also to consider. The Kerala Shastravitya Parishad conducted a survey in Kerala, and they found that 67% only had full attendance on online classes, and 77% of them students felt difficulty in understanding subject through online media. And all this got psychological impact, social impact. The digital divide can cause problems in families, parents, and teachers are also frustrated parents. And coming to the direct psychological problems in children, so many studies have come up from China, Italy, and Spain. So generally around 23 to 37 or 40% of children got problems, anxiety symptoms, depressive symptoms. And an interesting study from China reported that there is greater prevalence of depression and anxiety in children with higher grades. An interesting aspect is during the last year lockdown period, a report among children who committed suicide in Kerala, they reported that most of the children or a significant percent of children are from good families with good academic functioning. So what they say is because these children are more aware, more concerned about the outcome of the pandemic. And most of the time, the worries of children can come out as behavior problems. That is why we see children presenting with behavior problems has increased like anything. And a study from Spain and Italy found higher symptoms of concentration problems, irritability, restlessness, etc. And an interesting observation is they found that problems were more in Spain compared to Italy. And the reason they suggest is Italian government permitted children to go out and play or for short walk for short periods every day. And that created the difference. We also see children coming with psychological problems, behavior problems. We advise them to play outside 1 hour daily. And the parents report improvement in especially behavior issues and obsessive thoughts and all. And these are all we see now. A study from Italy found regressive symptoms, as I was mentioning in the 2.5-year-old child, regression of developmental milestones, again developing nocturnal neurosis, worsening of vocabulary, unknown fears. So we are also seeing these type of symptoms now. An Indian study from North India, they also reported high prevalence of worry, helplessness, fear in children. Another interesting study is Lord Semi et al. They studied the impact of loneliness on children, studying the effect of loneliness on previous studies, extrapolating to COVID period. And they found that loneliness has long-term implications, can develop psychological problems even 8 years, 9 years after the period. And they suggest several tips to cope with the loneliness, which we'll be discussing later on. And we had a 6-year-old girl admitted to pediatric surgery IMCH for trichotillomania. And she told me she was sitting alone, watching TV. There is nobody to talk. So she started picking hair and then started eating it. And he found that it is something stress relieving and continued eating. So it created big intestinal obstruction and a surgical emergency. So in short, COVID-19 short-term psychological impact on children is now well known. There can be adjustment disorder, prolonged grief-related symptoms, depression, anxiety, post-traumatic stress disorder, and also non-specific symptoms. There may not be a categorical diagnosis, but symptoms like excessive fear, regressive behavior, concentration problems, all these things. And in our survey, we found that a significant percent of children had developed scholastic problems after the online education. There is an increase in emotional problems, concentration problems, behavior problems, concern about cleanliness. Obsessive compulsive disorder is now we see in very young children, 5 years, 6 years. And around 48.5% of children developed weight gain during the lockdown period, change in sleep, appetite, physical activity, and 3% started using spectacles as a new. Kishore was talking about there is an association between MISC and weight gain, obesity. And the other group of children who suffer very much is children with pre-existing psychological disorders, children with ADHD, children with ASD because all the special schools are closed down. So children with ASD, they are tuned to a structured environment. Once this is altered, that can lead to problems. Or children with intellectual disability, staying at keeping home, it is very difficult. And that causes family issues. And also there is disruption of treatment. Many of them cannot attend centers, treatment centers. So, and most of the time drugs are costly. So the World Health Organization and the Government of India suggest these tips for coping with stress in children during the pandemic. The most important thing is parents should have a positive attitude that the pandemic will be over, and they should find time to clear children's doubt, listen to them, answer questions, allay anxiety. If the parents are not able to do, they should get help from somebody who knows, teachers or others. And it is very important to maintain the daily routine in children. You get up, but as before, when you are going to school, get up at 6 o'clock, eating breakfast or a daily routine, lunch, sleep. So all this daily routine is now changed. So it is very important to maintain the daily routine in children and healthy lifestyle habits on diet, exercise, sleep, digital media use, better communication in the family, and maintain social communication, social contacts, online or telephone or other media. And children should be able to engage in indoor activities, household work, any creative work if possible, or simple household task. And information should be sought from reliable sources only. There is an information explosion through the social media. Most of the time, these are false also. And parents should be able to recognize normal emotional reactions of children and seek help if needed. Unhealthy coping, like especially in adolescents, like smoking, alcohol, other drugs should be discouraged. Behavior change, early identification. If a child behaving abnormally or some changes in the behavior recently, it is better to seek help.
Me, sir, just a reminder, sir, just 4 more minutes left.
And if there are any positive effect, there are also several positive effects. We have started the online learning. Canada is a double-edged sword. It is advantages and disadvantages. Now they are talking about blended learning, new university courses. Even KUHS has started several online courses like that. And some students who have social anxiety and all, they are more benefited through online classes. And many telemedicine programs are now coming up. Government of India, the state government, Kerala, has started the e-Sanjeevani program in a big way. We have enhanced, started several online programs for disabled children, therapists at home, etc. So to conclude, what I was trying to say is children experience tremendous stress during the pandemic. And there is significant increase in physical as well as mental health problems. And these issues need to be addressed, not in the level of pediatrician or a psychiatrist, but in the policy level itself. And long-term impact of COVID-19 on psychological well-being is not clear. So we need long-term studies. And similarly, there is a need for longitudinal studies on long-term impact of the pandemic on brain development and the development of the child as a whole. So thank you for the patient hearing.
Thank you, Dr. Krishnakumar. I think you have done a wonderful job explaining the importance of early stimulation, contact with people, contact with society, contact within the limitations of COVID. You have excellently proved it. what we should say is this actually correlate, and you also said the possibility of more ASD cases, autism spectrum coming up further and more, and this can be related to the work of PhD work of Dr. Babu George, which clearly showed that the children with ASD have 20 times less chance of mixing with children of same age. Or other way around, a normal child will have 20 times more chance of mixing with children of the same age as compared to autistic children. And to substantiate it, just 3 weeks ago, I had a child, a young child, both the parents had COVID, there was nobody to help them. So what they did is, their room was there, one window is there, the child is in the next room. They made sure that everything is supplied to the child along with a mobile also. So practically 24 hours, all the waking hours he was seeing mobile, and the child came with all possible features of autism, which of course may go away quickly. It may not be autism in the real sense, but it clearly says that the changing environment can play havoc with the life of the young children. I think, Shaji, any comments?
Yes, Dr. Krishnamar, he has highlighted the need for a long-term follow-up. What he has mentioned is at least for 5 years, because we don't know how it is turning out to be with all the impact of the various aspects of the lockdown, the loss of caregivers, the mobiles, the online classes, all those things. And pediatricians are, and even adult physicians are capable of handling the COVID, the disease. But this is something which we don't usually give much importance to find out about the psychosocial aspects. So the message is very clear that the psychosocial aspect is really important. We've got to look into that, and then we've got to follow up the children for a pretty long time to find if there is any long-term effect of this. Thank you, Dr. Krishnamar. Thank you very much. I think there are no questions in the chat box, so I think we can wind up this session and carry on.
Thank you, sir. That was indeed an eye-opener. Now we have come to our penultimate session. For this, we have Dr. Vinod Skaria to talk on genomic variants for pandemic surveillance and preparedness. This session will be co-chaired by Dr. K.P. Aravindan, former professor and head of Department of Pathology, Medical College, Kozhikode, and Dr. Riaz I, associate professor, Department of Pediatrics, SAT Hospital, Trivandrum.
Welcome, everyone. Actually, this genomic variants is something all of us are very much after the advent of the second wave and the scare of third wave. And as the vaccination is also going on a very low pace, we all expect more variants to come in. And we all would like to listen to one of the great alumni of Calicut Medical College itself on the sought after subject of genomic variants in SARS-CoV-2 virus. Over to Aravindan sir for introducing the speaker and starting the session.
Dear friends, since this is a very short session of only 15 minutes, it would be very unfair of me to use up time. So I will be short. The COVID pandemic has brought molecular biology to virtually every household. Everyone these days knows about RT-PCR. Many people are aware of genome sequencing as they relate to the variants of the virus. I'm very, very happy and proud to introduce Dr. Vinod Skaria, a most distinguished young alumnus of Calicut Medical College, to this audience. He has been a pioneer in clinical genomics in India, right from the days of sequencing of the first genome, in which he played a very significant role. I have no hesitation in saying that he is one among the very top life science researchers in India at present. More than anything else, I know him as a person always trying to share and pass on his knowledge to others, whether in involving students for solving complex drug discovery problems for neglected diseases, or educating the clinicians in clinical genomics in various workshops, or involving many medical colleges and institutions in genomics for understanding of rare disease. It's called a Guardian Network project. So many are the institutions, including his alma mater, Calicut Medical College, that have benefited from his knowledge and skills. So I welcome Vinod, and I'm so happy that you are here to share your experiences about the genomics of SARS-CoV-2 virus with us. Thank you. Vinod.
Thank you, sir, for the introduction. Just share this. I hope my slides are visible.
Yes, they are visible.
Yeah. So over the next 15 minutes or so, I will share a brief overview of what this genomics of SARS-CoV-2 is all about and how is it providing insights into the pandemic. But before that, let me first start with the statement that pathogen detection and surveillance has undergone a very paradigm shift in the last 2 decades or so. And most of this has been contributed, apart from the reduction in the cost of sequencing genomes, has been contributed to the enormous wealth in terms of shared genomic data and shared protocols, which has made this possible. Now, to give a brief example of how this works, earlier, every single outbreak used to be investigated by either isolating the particular virus or the pathogen and then observing them either using an electron microscope or one of the microscopes. But very recently, as you see here, right from the SARS pandemic, the first genome of SARS-CoV-2 did not go through the standard procedure, which was usually time-consuming, usually costly, and in many ways complicated, which required a lot of skills. Now, what really happened in the first SARS-CoV-2 genome, as you see here, the sample was isolated directly from the bronchoalveolar lavage and was sequenced and analyzed to reveal the identity of the virus in pretty much around a week's time. And that necessarily means that this technique of genome sequencing for identification and genome sequencing for surveillance is something that is here to stay. Now, the basis of all of what we do in genome sequencing and surveillance is the fact that every organism, whether it is human or whether it is a virus, have all a very constant rate of mutations or a very constant rate of substitutions. And these genomic substitutions are essentially a way of evolution. The only difference being that the rate of the substitutions are different for different organisms. For SARS-CoV-2, it's estimated that the virus mutates approximately 1 mutation every week or so. So in terms of time, if you plot the virus, and we assume that over this period of time, it has accumulated 6 mutations in very different combinations. And you should also assume the fact that mutations always recur or occur in the background of an existing mutation. So for example, if you'll see mutation number 1 and mutation number 1, 2, so 1, 2 necessarily means that the mutation 2 occurred in the background of 1. And similarly, this could diverge into 1, 2, 4 and 1, 2, 3, so on and so forth. Now, given a constant rate of mutation of any organism, what you would expect at every point in time is a uniform distribution of each of these variants, or what we call as lineages. Now, in other words, you should expect uniform proportions of 1, 2, 3 and 1, 2, 4 at any point of time, because the rate of mutations or rate of substitutions is supposed to be constant. But in real life situations, that is not what you find. What you find in real life situations is one variant or one genetic lineage, in this particular case, for example, 1, 2, 4, to be predominant over the other lineages, for example, 1, 2, 4, 6 or 1, 2, 3, 5. Now, why does this happen and how does this happen? The first and the foremost reason why this would happen is because of human factors, where what we call as emergence events caused by super spreading. Or in other words, if a population is mingling with each other and they could transmit the infection from one to another, that would necessarily mean that that particular virus which is being transmitted would have a significantly large proportion in the time point assay. The other obvious factor is that a virus would have a genetic mutation which would enable it to get transmitted very efficiently, and then therefore there'll be a large number of people with that particular genetic variant in the population. So these are essentially the assumptions that we do when we look at a time scale map of genetic variants and genetic lineages. Now, until very recently, it was not possible to sequence thousands of genomes for genetic surveillance. That was pretty much because the sequencing technology and the applications to assemble such large amount of genomes did not exist until very recently. And one of these early applications is what we call as COVID-seq. This was an assay developed by Illumina, and one of the first real-life applications for this assay happened in India in the lab of Dr. Sridhar Shivasabu, who is my colleague and a close collaborator, and with the help of a wonderful team of young researchers who made this possible. Now, to die this very short, what this assay can do is can sequence anything from 750 to 3,000 samples in one single go on a sequencer. Now, that is essentially the kind of scale and throughput that you would require to do surveillance efforts spanning multiple states and multiple districts in the country. And one of the earliest pilot applications for this was in mid last year, sometime in May to July last year, where we did this pilot surveillance across 7 states of the country, sequencing around 2,000 odd genomes and trying to understand the genetic epidemiology of the virus. And this was part of an early program called the INDICOVGEN Consortium, which was funded by CSIR. Now, what we learned from this is essentially, apart from the predominant lineages which are present around the world, because practically all the viruses into India has come from somewhere else in the world through travelers who came in with the virus. Now, what we really found was there was a distinctly unique genetic lineage, colored here in purple, which was not predominantly found in any other region of the world, but found in India in a very large number. And since this was predominantly Indian, we sort of named it as the I or the A3I lineage. A3I to signify this was an outgroup of the A3 lineage, and the A3 lineage was essentially the lineage that emerged in Iran early in the epidemic, and distinctly different from the A2A lineage, which was the European lineage, which was the most predominant lineage containing the D614G genetic mutations. And to give the context, you also see this yellow dots out here, and these yellow dots are essentially the B superclade or super lineage, which includes B, B1, and B4, which are essentially the virus which came from China. And as you see here, the earliest genomes which was sequenced and deposited in early part of last year belong to the B lineage, because those patients came from Wuhan in China. The other application of genome sequencing is that you could now use this genomic sequence and the map of the genetic mutations, because we know that genetic mutations occur in the background of existing genetic mutation. You could do something called as contact tracing. In other words, from this lineage, what we call as IA3I, we could contact trace molecularly to sort of identify that all these individuals had a common ancestor, and this signifies that there was a super spreader event which contributed to this genetic lineage coming up in different parts of the country. But over time, as we expected, this genetic lineage sort of subsided and was taken over by the most predominant A2A lineage from Europe. And doing contact tracing of large number of genomes on a countrywide scale, we could also pinpoint a large number of super spreader events which happened across the country. And almost all of the early pandemic last year in the country was contributed by one or the other of such super spreader events. Some of these super spreader events, for example, were quite large, while others, like for example, in Andhra Pradesh or in Kerala, were much smaller in number. But nevertheless, a significant large proportion of the virus early part of last year was contributed by these super spreader events. Now, coming to Kerala, we could also identify 3 such events, which we, for nomenclature's sake, name it as K1, K2, and K3. These clusters were traced and identified, and almost all these clusters seem to have an origin from a nearby state compared to international introductions. And this is very significant because Kerala had a significant influx of international travelers during early part of the pandemic last year. But nevertheless, the significant spread in terms of the population of the virus came from viruses which came across the borders of the state, rather than from international introductions. So this also signifies the impact of genome sequencing, not just to identify clusters, but also to validate policy in terms of understanding whether we should quarantine international travelers versus quarantining interstate travelers who crossed across the borders. And that's how Kerala initiated, and is of course one of the first states in the country to initiate a very comprehensive program for genomic surveillance, much before the national program and much before much of the other states even thought about implementing genomic surveillance. And in terms of the structure, this is also quite comprehensive, involving 12 medical colleges. It involves the public health laboratories, both the central as well as the regional public health laboratories. It involves universities, which includes the Inter-University Center for Biomedical Research, as well as the Central University of Kerala, and involves all the 14 district surveillance officers, which are part of the IDSP, or the Integrative Surveillance Program, so that action or actionability on these results are taken in the shortest possible period of time. And this is entirely funded by the National Health Mission Kerala, along with CSIR. Now, we could, over the last 6 months, show how this early signals of genomic surveillance could contribute to policy, and it also contribute to containing the spread of the virus in the state. Early in the early part of this year, we could identify a small cluster of the alpha lineage in many districts in Kerala, which resulted in active case finding and tracing. And of course, with the rise of alpha as well as the delta lineage, which was essentially an Indian lineage, there was the policy of double masking, or in other words, Kerala was the first state to introduce a policy of double masking as a public policy. And of course, significant increase in the numbers of the variants of concern suggested that the state would go into a lockdown. And of course, very recently, it has also introduced a way of micro-containment and micro-surveillance of clusters belonging to the AY1 or the Delta Plus lineage. And this is also exemplified in quite international coverage, like for example, this article from the New York Times, which appeared in May 25, suggesting how India, how Kerala as a state has been able to use technology, not just genome sequencing, but a variety of technologies, along with the public health surveillance system and public health infrastructure to contain the spread of the virus. Now, the obvious question is, how do we go and where do we go from here? And what is very evident is that the virus has been mutating on a constant basis, and each of these mutations have contributed to a stepwise increase in the function of the virus, either by its ability to evade antibodies, what we call as immune escape, or its ability to transmit much more efficiently or infect much more efficiently, which is what we call as the transmissibility increase. Now, every variant of concern on this map has suggested that there was a stepwise increase in these properties. It has never been a drastic jump from, for example, much less transmissible virus to much larger transmissible virus. It's always been a stepwise increase in function. So that necessarily means that we should also expect, therefore, a similar stepwise increase in function, given that Delta has become the most predominant lineage, not just in India, but also in many parts of the world. And that also brings to the very big concept of how and where should we do surveillance. And it's a general paradigm to think that when the cases go up, that is pretty much when you need to do genomic surveillance. I pretty much beg to differ on this particular point. And to exemplify this point, I here plot the origin of Delta, which became the predominant lineage across India and many parts of the world. And as you see here, Delta originated sometime very back in 2020 during the first peak in Maharashtra, as you see here, sometime in August to July to August, while it has been lurking all the way until February to become a major lineage that is spreading across the country. So in other words, while the cases are low, that is essentially an opportunity to sequence much better, much bigger numbers, and be able to identify what are the genetic lineages which are spreading across the populations. And as you see here, unfortunately, we missed that particular period in time because we are sequencing much lesser as the cases were much lesser at the point of time. And that comes to the point of investigating clusters, which are faster and more efficient. And one of these approaches has been developed in the lab, which includes what we call as an accelerated sequencing protocol, where we could identify clusters and sequence representative samples from the clusters, approximately around 48 samples in less than 24 hours. And this is very useful, especially for a state like Kerala, where there are clusters which emerge as the disease is spreading because of a large population which is still susceptible to the infection. And therefore, these clusters could be queried for emerging variants in a very short while in a very efficient fashion, and in pretty much in a cost that is comparable to the large-scale sequencing or surveillance procedures. And we have now extensively used such approaches to investigate small clusters, both nationally as well as internationally. We have also been working with the WHO Southeast Asian office to help our neighboring countries, like for example, Nepal, to investigate such clusters in a very short time. I think I'll stop there and take questions, but before that, let me acknowledge a lot of people who made this possible. A fantastic number of collaborating organizations and people, a large number of people whom I cannot really put names in this list. Multiple different collaborative consortia which enable genomic sequencing and surveillance across the country, and fantastic team at CSIR IGIB, including a fantastic set of young researchers and long-term colleague and collaborator, Dr. Sridhar. And of course, this is not possible without funding. And most of the early funding came from CSIR, and the late funding has come from most of the state surveillance programs as well as the WHO. Thank you very much.
Thank you, Dr. Vinod Skaria, for the excellent deliberation. I find no questions in the chat box, but I think the dignitaries here may be having questions. Harivandan sir also, please.
I don't have any specific questions because we have been regularly discussing with Dr. Vinod about these things, and he has been one of the main advisors for the Kerala government regarding this matter. So just one thing, would you think that we should concentrate on sequencing all those with immune escape and cases? Such cases, do we have to really look at more carefully to look for more new variants? Because Delta is there everywhere, almost everyone thing is Delta now, but now we should be looking for the new ones which are emerging. And it's likely to emerge in those with immune escape population. So what do you think? What should be our strategy of sequencing now?
Yeah, so as the vaccinated as well as infected population grows over time, breakthrough infections and reinfections are bound to happen, right? And especially with a variant like Delta, such infections are bound to happen. Now, does that mean that we need to sequence every single individual of the breakthrough infection? Probably no, because that is going to be a constant proportion given that Delta is the predominant lineage. But having said that, there are subsets of populations which are important on both an epidemiological point of view and of course as a scientific point of view. And these include people who are high contact individuals. And this includes people, for example, healthcare workers, right? Healthcare workers who got early infections despite having 2 doses of vaccine and despite having a significant number of them already infected could mean something in terms of an emerging variant. And an epidemiological point of view, these are important because there's a very high likelihood that they would transmit this virus back into the patient population, themselves being asymptomatic or mildly symptomatic. And therefore, sequencing breakthrough infections and putting them on surveillance is something that is really important, because any new variant that would emerge in, for example, a high contact pool of people, this could be healthcare workers, this could be policemen, this could be office workers, this could be bus conductors, for example, they could have a chance to propagate this very efficiently downstream, and therefore they need to be put on surveillance through genome sequencing.
One question, like we were very prompt in doing all the containment measures, but still we are having the maximum number of cases now. Does this have any thing with the emerging variant lineages or something like that?
Yeah, this is a very interesting question, and My point to that is, as we do more testing, we will find more patients, right? So if we double the number of testing, we would still find more number of patients. Now, does that mean that Kerala is the only place where the cases are increasing? No. I mean, Kerala's situation is very peculiar because that's the only state which has a significant population which is still susceptible to infection, right? And that's also exemplified in the recent sero survey report from the ICMR, which suggests that Kerala is not even 50% seropositive, right? Of course, there are many caveats to that serosurveillance, but having said that, the population, which is susceptible to infection, will have more cases, right? And there is no way to prevent that from happening. The only way to keep it under control so that it doesn't overwhelm the healthcare capacity. And essentially, deaths happen because the healthcare capacity becomes overwhelmed.
Thank you. And another question is, does the genomic analysis help us in predicting the vaccine susceptibility as well as infectivity?
Now, so there are two endpoints to vaccines. And the first endpoint that is widely discussed is the prevention of infection. And that's how the concept of breakthrough infections have come in. The other endpoint of the of vaccines is to prevent serious disease and death, serious disease, hospitalization, and death. Now, in the perspective of the first endpoint, in terms of preventing infections, right, there are breakthrough infections that are happening, and as high as around 10 to 15% as far as Delta goes in many studies across the world and also in India. But that necessarily means that there would be infections, but these infections are mostly mild or asymptomatic infections. Now, in terms of preventing hospitalization, severe disease, and death, right, multiple studies have suggested that even single dose of vaccine is actually much more, efficacious in preventing serious disease and death. Right. Now, having said that, in terms of preventing the second endpoint, I think all the vaccines which are presently available are good enough, right? But in terms of our ambition to prevent infections in the first place, or if our strategy is to eliminate coronavirus infection, then yes, we might need additional booster doses of vaccines, or probably newer vaccines which can take care of the newer variants. But if your second point of preventing death is your endpoint, the present vaccines are as good.
So Vinod, from this, should it also be our policy that any severe cases occurring in vaccinated people should be sequenced?
Absolutely. Absolutely.
So recently we had a lot of cases among students at Trishul Medical College. All of them were vaccinated twice. Both of the vaccines taken. We send genetic test everything, but how it is happened? Second thing is that it is very difficult to believe that we are testing more, so we are getting more cases. Is it absolutely like that? Because death also here high. So is it like that we are testing more, max number of tests we are doing, so we are getting max number of cases like that?
Yeah. So I mean, as you go, most of the COVID diseases, I mean, most of the COVID infections are asymptomatic, almost around 85%, right? So increasing in testing is only going to identify this asymptomatic pool of individuals and therefore increase the number of cases. That's not really going to change much of mortality or much of hospitalization. Now, there is also a very big concern about increasing number of deaths, but this increasing number of deaths is compared to what, right, is always a question that we need to ask. Now, the disease has a very constant case or infection fatality rate, right? The case fatality rate is, of course, dependent upon the number of testing, but infection fatality rate is not dependent upon testing. It's a pretty much constant number. Now, given the case fatality rate in Kerala, which is the lowest in the country, at least a third of what the country has observed in terms of the case fatality rate, that necessarily means that we are taking care of our patients. But of course, there are deaths in COVID which are unavoidable, right? And that is essentially what the infection fatality rate suggests. Now, we should not really be worried about increasing number of deaths, because as cases increase, it will tend to the infection fatality rate, and therefore the cases and deaths would also increase proportionately. But the real good question to ask is it growing disproportionate to what we have already set as a benchmark of a case fatality rate of 0.4 or 0.5, right? Is it increasing beyond that? Then that is, of course, something that we need to be concerned about. Now, coming to breakthrough infection, it is not very surprising that Kerala will have breakthrough infections, and in many ways significant numbers, especially in healthcare workers, because healthcare workers were the pool of people who got their vaccines very early in this year, right? And it is almost 6 months to 9 months since they have got the second dose, and therefore, as the antibody levels wane, they are susceptible to get more infections. But now these are infections; they're not serious infections or death, and then therefore we should understand that breakthrough infections would happen. But of course, these breakthrough infections need to be sequenced using genomic tools, because these are healthcare workers, and there's a very large chance that they could propagate it down to the patients and into the community in very large numbers.
Thank you. Thank you, sir. One last question from Purushottam, sir, and then we will close the session.
Dr. Vinod, we have been talking about the genomics considering the agent factor only, and you are going behind the agents. I think we should be doing more of the human part of the genomic, because we had almost 500 cases of MISC, and the MISC in Kerala and Indian scenario compared to the UK and other European countries, we are having a little younger kids, not the adolescents. So there are differences are there in the affection also. In the UK, there are more of black people were affected, and here in India, compared to the younger ages are affected. So we should be going behind the genetic basis of these bad scenarios. And at least 500 cases, and maybe coming also, that number is it feasible to have a genetic sequencing study. That is important because there are few locus of the genes already noted here, and in the Kawasaki also, there are genetic basis of Kawasaki with some of this. So maybe this will throw open an area where till now we were postulating Kawasaki, there is a possibility of infectious agent underlying. Here is a chance that the genetic locus, which was already proved for the Kawasaki, and this MISC may be having some relevance. So that is throw open an area for this workup. So what IAP should be asking for after this end of this meeting, expert thing, we should be asking for the genomic studies for this part also. That should be one. That's one suggestion. And about the other agent part, the Delta plus variant was noticed almost 3-4 weeks back, around 51 cases. And in Kerala, there were 4 cases occurred in Pathanamthitta, Palakkad. That was 2-3 weeks back. Is it because they lost the news value, or there are no more of further cases occurring? It is not the situation when the other variants like Delta occurred. During that span, the number was huge. So why that's not happening? Is it because of our overall seroprevalence is increasing, our vaccination coverage is increasing? That is also have got some relevance of the inference. The vaccination coverage is gradually, even if newer mutation come, we need not worry. That is one important thing. So what about the Delta plus variant?
Yeah, thank you, sir, for both the very interesting points that you raised. I will actually answer the second question first because that is brief. So the Delta plus lineage that we found in Kerala, which is AY.1, doesn't seem to have much more transmissibility or infectivity compared to Delta. So we don't expect the numbers to explode enormously large, at least in Kerala. And the reason why it has probably lost its interest is probably a commission or omission on our part, that we could not return the results from the last month's surveillance as early as possible. We are yet to receive the sequence data this week, and of course, we will update the government regarding that. So I will take that on myself, that the reason for the late release is on our part. Now, coming to your the first question of MISC, what you pointed is absolutely on the point. And it is very well observed across populations that there is a population difference or an ethnic group difference in the prevalence of MISC. And at least in US, it has been well documented that the blacks as well as the Latinos have almost 4 times more prevalence of developing MISC compared to the white population out there. And this has also been observed in many European countries, which has a significant number of African populations. Now, coming to Kerala, yes, this signifies that people who are non-white or non-Caucasian do have a significant larger risk of developing MISC. And one of the major components that we could point our fingers is indeed genetics, right? What you suggested is extremely in time, because we were, just planning to initiate a program on sequencing a lot of patients with MISC. We have a few gene candidates that we have in mind. At least in small samples, we have found odds of at least 9 or 9 times more risk of developing MISC given a genetic background. Now, if of course we have initiated this program with Calicut Medical College and many other centers across the country, and if IAP would be happy to help us with this, we would surely be interested in taking this up further. But the real question of the genetics of MISC is one that even if we find a genetic marker, how is it going to be used clinically? Because they're not going to be an all or none marker. They're only going to be associated marker with an odds of developing the disease. Now, in most of the cases of MISC, the disease or the MISC presentation develops a few weeks after the child has developed COVID, right? So in many ways, there is and that period of time is not large enough to implement a genomic screen or a genomic test. And even if you were to do such a genomic test, the population pool is quite large and enormous, right? So in terms of a prevention of MISC, the genetic test, in my opinion, might not be having a lot of value, but indeed it would have a value in terms of understanding the disease scientifically, and also probably in our ability to differentiate between MISC and Kawasaki, right? Because MISC and Kawasaki seems to have completely divergent pathologies, though they're phenotypically similar or overlapping presentation, right? So in terms of a scientific pursuit and academic pursuit, and with limited clinical value in deciding or preventing the disease, yes, genetics do have a role. But of course, I'm open to suggestions what others have to say on this.
Yes, the relevance of the genomics, the clinical genomics and pharmacogenomics are all coming, and maybe in the coming years, I'm not for vaccinating less than 20 years, jump and vaccinate all. I'll reserve the IAP or even other recommendation is being given for vaccination to the for the pediatric age group. I will reserve for the high risk group only. So among the high risk group, I will include if such a clinical or pharmacogenomic data is available, if there is risk factor of a group of kids are found. That's a thinking which is beyond. Maybe take years for this to come, or maybe in the years to come, all these genomic basis will be the deciding factor for using drugs, the dosage, the adverse reactions, and who is to get it, who not to get it. All these things are to be decided by your genomic things. So there's a role for these things.
Thank you, sir. I think as we are exceeding the time, we should hand over the mic to the admins. And once again, thanks from Aravindan sir and myself for giving us this opportunity, and to Dr. Vinod for that excellent deliberation. Thank you.
Thank you very much.
Thank you.
Thank you, sir, for that highly informative session. We have come to the concluding session of this academic feast. Next, we have a panel discussion on COVID-19 in children with comorbidities. The moderator for this session is Dr. Mohandas Nair, Professor and Head of Department of Pediatrics, Government Medical College, Idukki. He is also the current President IAP Kozhikode. He was in charge of the genetic clinic here at Medical College. I request Dr. Mohandas to preside on the session.
Am I audible?
Yeah.
Okay, good afternoon all. We all are aware of the time factor. We have heard almost all aspects of COVID-19 in children, and we are somewhat happy that COVID is not that a big issue in children. It doesn't cause much problem when we compare its impact on adults and on those with comorbidities. And very often, many of us have felt that the impact of COVID-19 in children is not because of the infection per se, but because of various other aspects. Many children have lost parents, many psychological issues Dr. Krishna Kumar has already mentioned. And we have a good cohort of children having various chronic problems, and how this COVID has affected these children, and how an institution like IMCH has tried to address that situation. That is what we want to discuss. And panelists are, they actually doesn't need much introduction. One is Dr. Ajit Kumar VT, who is Professor and HOD Pediatrics, and who is the captain of today's program. And he's also taking care of children with leukemia and chronic hematological problems. Dr. Vijay Kumar M is Professor and HOD Pediatrics, Government Medical College, Manjeri, and is looking after children with various endocrinological problems, and we are especially concentrating on children with type 1 diabetes, and he's also the president-elect of IAP Kerala. And Dr. Geeta Govindraj, professor, and is the person in the organizing team today, and she's mainly taking care of children with primary immune deficiency. Dr. Krishnan C, additional professor in pediatrics and faculty in charge of children with renal problems, especially children with nephrotic syndrome. Dr. Sindhu TG, additional professor and faculty in charge of pediatric rheumatology clinic, and who is vice president of IAP Kerala, Calicut branch. So I'll start with Dr. Ajit Kumar. So we all have the impression that COVID will hit hard on children with malignancies because of various problems. So what is your opinion on that? How COVID has influenced their evaluation, treatment, emotional aspects globally and also in our institution?
So thank you, Dr. Mohandas, and I hope that I am audible. Am I audible?
Yes, yes.
Okay. So the problems in children with malignancy, oncology, have been twofold. One is the COVID aspect. Second is the inherent nature of the malignancy. So, so globally, as well as our experience says that there is no increased mortality due to COVID in children with malignancy. So they can be treated. So they are having the same risk as in any other child. And with respect to the malignant part, the children with malignancy had some problem during the initial COVID period. There was a protocol prolongation, and also due to the drug delivery issues. So these are the two issues that had affected the malignant part. So one is the protocol was delayed, and also the drug delivery. So, but as the pandemic progressed, we knew that even though the state had categorized malignancy, children with cancer in the B category, even when they are asymptomatic. So now we are giving, we are not prolonging the treatment for children with cancer, even when they are COVID positive, those who are asymptomatic. So that is one thing which we have learned over time, that those who have asymptomatic, COVID positive, malignant children, we are giving the treatment as per protocol. Previously, even though the maintenance part, there was no delay, there was some delay of 10 to 20 days, the active period, like the induction period. But now we are started giving the treatment as per protocol. And regarding your emotional issues, actually, when we looked into the emotional issues, Dr. Sheetal and had looked into emotional issues, there was not much of an emotional issues due to COVID. They were not afraid of COVID, but they were more stressed because of the initial lack of lack of access to treatment and lack of drugs. So these are the stressful factors they had. Otherwise, the problem of COVID producing stress was not.
Thank you, Dr. Ajit. So the COVID, the direct effect of COVID on children with malignancy is not that.
Globally also there was no increased mortality.
Thank you. So now to Dr. Vijay Kumar, you are seeing cases regularly in pediatric endocrinology clinic for more than a decade, and we all know that in adults, diabetes is an important risk factor for serious disease and mortality. Is there any evidence that COVID has resulted in increase in pediatric diabetic cases all over the world? And what is your experience on that? And any rise in new diabetes presenting as ketoacidosis? Has COVID resulted in increased incidence of complications in children already diagnosed to have diabetes?
Okay, so thank you, Mohandas, and the organizers for giving me a chance. So if you ask me, is there any evidence throughout the world that COVID has resulted in increase in the pediatric diabetes? The answer is no. So there are tremendous increase in incidence of severity of COVID in adults with type 2 diabetes and other comorbidities. But as such, there are no data all over the world, except a small study from England, UK. There are no increase in type 1 diabetes related to COVID. And what we have our experience in Mitai Clinic in IMCH Kozhikode, there are 41 new cases registered in 2019 and 46 new cases admitted in 2020. There are not much difference as far as the new diabetic patients are concerned. But if you ask me whether there is an increased incidence in diabetic ketoacidosis and other acute complications, the answer I have to tell that yes. There are many studies all over the world is telling that there is an increase in incidence of diabetic ketoacidosis during this COVID era. I am not saying due to COVID. So, but there is no increase in mortality and no statistically significant increase in other acute complications like hypoglycemia. But all over the world, the number of children with actual COVID positive infection and diabetes ketoacidosis is not increasing. That may be, they are telling that may be due to delay in initial diagnosis because less access to the hospital. The patients are not coming for their initial symptoms to the hospital facility, and majority of hospital in India and abroad, they are giving more importance to COVID patients rather than the non-COVID issues. And the problems with accessibility to the insulin and the glucometer and other devices, the number of diabetic ketoacidosis has increased little bit, statistically significant increase all over the world. If you come back to IMCH, our Calicut, in 2019, there were 7 children were admitted with diabetic ketoacidosis in our PICU. In 2020, it was 15. In 2021, as such, as till now, there are 5 patients admitted. So even we can tell that there is slight increase in diabetic ketoacidosis in Calicut itself. And among them, only 2 cases were actually COVID positive. But others are because of the relative delay in initial diagnosis and referral and relative inability to get the glucometers and other things.
That is interesting. Even in children with diabetes, it is not the COVID causing problem, but the various other social situations which is producing problems here.
Yes.
Now to Dr. Geeta Govindaraj. We had a lot of apprehension about children with a primary immune deficiency or otherwise inherited defects of immunity about consequences of this COVID infection. how they handle the virus, whether the viremia will be prolonged in them, like that. So what is the experience globally on COVID-19 in children with inherited defects of immunity who are immunocompromised to varying extents? What's your experience?
Yeah. So we're having some disturbance in the background. It's okay. Background disturbance, and now it's okay. Yeah.
Okay.
So thank you very much, Dr. Mohandas. It's a very pertinent question. As you know, there are more than 450 inborn errors of immunity that are described, and children with these disorders have increased susceptibility and severity of infections, not only infections, but also inflammation, allergy, malignancy, and autoimmunity. So everybody at the onset of the pandemic, 18 months back, was worried about this group of children. But to our relief, and also from global estimates all over the world, there has not really been, and this has not become a priority group of people who have suffered due to COVID. And actually, there is a small subgroup. So because the inborn errors of immunity cannot be all lumped together, there is a tremendous heterogeneity among them. So there is actually one group of children, probably the commonest, that is children with antibody deficiencies, mainly A-gamma globulinemia, who have actually had an advantage by having lower absent numbers of B cells. So this was very surprising. So we went into the reasons why. So actually, the absence of B cells leads to reduced antibody formation, which is usually deleterious, but not all antibodies are advantageous to the body. There are some antibodies which can act against type 1 interferons, and also there is susceptibility to formation of cytokines which can result in increased inflammation. And so therefore these children have actually been at an advantage. And there is a large study from ECID, and what they had was about 94 people with inborn errors of immunity, of which 1/3 were children. So around 30 plus children in this study. And out of that, only 2 children passed away. And those children who died had underlying related problems. Like one had was 4 months post hematopoietic stem cell transplant and had severe gut GVHD. And the second child had a severe hospital-acquired infection due to Burkhold area sepsis. It was a child with CGD. So this is the global sort of experience with children with IAIs. And there is another way also they looked at it. They looked at people who had severe COVID and analyzed whether they had any genetic susceptibility. And they found that there were problems, there were defects in interferon signaling and in the type 1 interferon pathway, which is very essential for immunity to SARS-CoV-2. So this is what has been found. And they also, apart from having mutations in these genes, they've also found some individuals who have autoantibodies against the type 1 interferons. So that was also one important finding. Now, regarding our experience, well, we have had 2 children with XLA, 1 child with a SCID variant, 1 child with hyper IgM syndrome, 1 child with hyper IgD syndrome, and 5 children with trisomy 21 who have had COVID-19. But the only child who required ICU care was a child with trisomy 21 who also had B-cell ALL. So the reason for that was probably because of the associated immunocompromised state. One thing which we have found, that is in children with XLA, although they had a very mild symptom due to COVID, the duration of viral shedding was more than in the general population. So both these two children with XLA who we had with COVID, they were both adolescents. They had the rapid antigen test becoming negative only after 14 days following the first positive test. So that was one finding we had. So on the whole, these children have been doing rather well, surprisingly.
Also, it's a very good news, contrary to our belief. Now to Dr. Krishnan, another group of children we were worried about is children with nephrotic syndrome who can have problems both because of their renal involvement and also because of the medicines they receive, various immunosuppressant medications. So what is the risk of COVID-19 infection in children with nephrotic syndrome and children receiving immunosuppressant agents? And what is the pattern of COVID-19 infection in children with nephrotic syndrome and those receiving? So is there any change in pattern and do they require any special preventive measures? Have you noticed any increase in the first episode of nephrotic syndrome in this particular period?
Thank you, Mohandas, for these questions. I will start with the risk of infection in children with nephrotic syndrome. For this, I will first of all share some of the data from other countries, and I'm also having my own data findings. I will share data. So, in an Italian study, 6 children with nephrotic syndrome on immunosuppressants had close household contact with COVID infection, but none developed any symptoms of COVID within 14 days of exposure. They also found that IgM and IgG COVID antibodies at 4 weeks and 16 weeks of exposure were negative, which means that they were not infected. In another Italian study on a cohort of 1,572 children, they were having these children were having nephrotic syndrome, chronic kidney disease, and they were receiving immunosuppressant. Of these, only 3 were tested positive, and out of which 2 were having mild symptom and 1 was asymptomatic also. No severe disease was detected in these children. And in another study of a survey on from 16 pediatric nephrology centers across 11 countries, only 18 cases of COVID were reported. In our experience also has a similar findings of reduced cases of nephrotic syndrome, reduced cases of COVID infection occurring in nephrotic syndrome. Even after exposure, many of them are not developing symptoms. So with the existing evidences, we can conclude that similar to the general pediatric population, the incidences of symptomatic COVID-19 infection in children with nephrotic syndrome and those receiving immunosuppressant drugs is low, and there is an increased risk of COVID-19 infection, provided that these children are, the family are adhering to the preventive measures regularly and strictly.
And have you noticed any increase in episodes of nephrotic syndrome or any increase in relapses?
Okay, as per the international survey published in Lancet regarding the pattern of relapses in these children, these children were taking medication, they were having kidney disease also. They were having, all of them were having mild course of COVID-19 infection. There was no significant differences in the severity of COVID infection in this group of children and compared to the normal children. Majority were having a category A disease, and only a few had category B disease, and category C was not known. It was not reported at all. There were no reports of MIS-C in children infected with COVID infections. So these literature suggests that children with nephrotic syndrome and those having on immunosuppressant tend to have a mild course of COVID-19 infection. And regarding the prevention, we now know that the risk, the infection rate and the severity, everything is low in this group of children reportedly. But still, these children constitute a high risk group because they are prone for adverse outcome also, especially during the early stages of diseases. And there is always a risk of developing acute kidney injury in this group of children. So they have to follow all the recommendation in the country and the locality strictly and regularly. And there is no additional precaution they require.
Okay. Thank you. Now to Dr. Sindhu. So you are looking after children with chronic rheumatological problems, and many of them are on immunosuppressants and biologicals. So what is the disease severity in rheumatological conditions? Is it more? And how will you manage a child on immunosuppressive therapy when that child develops COVID infection?
Thank you, sir. As already all the speakers has mentioned, in the initial period, we expected this corona will be more severe in our children also, because they are immunosuppressed and we are giving several drugs. But as time passed, we find out that there is the contrary. We are not getting any severe disease. In our follow-up, we have more than 150 juvenile arthritis cases. They are among them around 10 were positive, but all went well. I think most of them not admitted at all. Majority were asymptomatic, and they used to call us and tell us, as all the other family members are positive, they were tested and positive. There is not much problem for them. And the SLE patients, we had 3 of them were positive and 2 needed admission at the local hospitals, and they also improved. And the JDM also 2 were positive, but they are also doing well. So I think this disease severity is not as expected. It is going in a milder course. And I think some immunomodulator drugs may be a little bit protective effect on them. Many of them are on low dose steroids and all. And there are some reports regarding like that. And also regarding these drugs while on treatment, they used to ask them what to do with these drugs. This ACR has put forward with the guidelines how to do with the immunosuppressive treatment and other modalities of treatment in rheumatological conditions. The second version of the pediatrics rheumatological condition, they says that if the child is having only a asymptomatic infection, as for the oncological conditions, there is no need for stopping the treatment. You can continue if they are asymptomatic or exposed children, they can continue. But the steroids, if better, you can decrease to the least possible dose. It is up to 0.5 milligram per kg per day if possible, and should not stop the steroid as on a sudden. It can predispose a flare or it can predispose adrenal insufficiency as they are on long term for steroids. And if they have any symptoms, you have to decide. They recommend a temporary stopping of some DMRDs like methotrexate and or for a short duration of time, that 7 to 14 days, depending upon the severity. But this also to be in consideration with the treating doctor, because we only know how this child had the initial symptoms. This child had a severe condition at the onset. Suddenly stopping all these drugs can go for a flare that may be more detrimental. So it is now it is going for more and more continuing the drugs, and steroids should be continued at the lowest possible dose, even in the symptomatic group.
So you will be concentrating more on the primary condition rather than the COVID.
Yes, it actually says more than the disease, corona infection, the uncontrolled disease is contributing to the mortality and morbidity in these children. So we have to focus should be on controlling the disease. And as most of our children, if they are on immunosuppressants, they are taking very much care. The parents for a long time, they are taking this care. So there's a less infection is seen in these children. Only when all the family is infected, they are getting the disease.
So we have gone through 5 important group of conditions, and in none of these conditions, COVID directly is not causing much harm, but various other situations because of COVID has resulted in some difficulties in managing them. So my next question is to Dr. Ajit. In children with a malignancy, what all efforts you have taken to ensure their management is not compromised? And another worry would be when they are getting admitted in the hospital, they may get infected. So what all measures you have taken to prevent them from getting infected? And a lot of anxiety is likely. So what all efforts you have taken in that aspect?
Regarding infection, I think all bystanders as well as patients were given N95 mask and they were screened. And only a single caregiver was allowed in the ward. No, the caregivers were not allowed. I mean, second caregiver was not allowed in the ward. And all those who were symptomatic, we have a social worker. So if they are symptomatic with fever and they are not allowed in the ward, only once they are out of not having fever and we ensure that it is not COVID positive, RT-PCR was done. And all these parents as well as children who are antigen negative were screened with RT-PCR also. So these are some of the measures that we have taken to prevent infection. And they were not, previously we used to have a home away from home. Am I audible on this?
Yes, yes.
Previously we used to have several home away from home. So there was some clustering in the homes away from home. Like during the chemotherapy, they used to stay in some of the homes, but that we discouraged. They asked them to go take individual rented houses so that there won't be any infection among themselves in a group. That is one thing which has succeeded. And regarding the management, as during the COVID period, we had online consultations through our we did online consultation through the social worker arranged online consultation. And we ensure that medicine reached the patient at their home using the police network. So there was a very efficient police network where the medicines reached there especially during the maintenance. And as we said, there was no delay in the protocol during the maintenance phase, but during the active phase, there was some delay because initially we didn't know about the course of the illness and what happened when the COVID struck a child with a malignancy. And also, and another thing that we have learned is that the parents, the mothers, if they're empowered, I mean, they can be a good they can be a part of a caregiver team. So empowering the mother about COVID, about hygiene, about the hand washing and other practices will improve our prevention of infection control. Even then, we had around 31 children with COVID, but none of them were serious. Regarding the stress, I have already said in the first part that there was not much of a stress because of due to on COVID, but there was some stress because of delay, which was we took care through online consultations, through social workers and support groups. We have a good number of support groups along with us, 4 or 5 support groups, and these support groups also helped us during this period.
Thank you. So we can assume that the worst period of COVID is already over, and during that difficult time, we could manage them effectively without compromising on the care. That's very nice to hear. To Dr. Vijay Kumar, what are your observations regarding the problem faced by these children in your cohort during pandemic? You have already mentioned that the ketoacidosis incidence is slightly high. So naturally, the glycemic control might be compromised in this period. And also the psychological problems which you have noticed in them.
Okay. I think I'll divide into 4 headings actually, what has happened to these children. And as you said, 85% of the children with type 1 diabetes who had COVID all over the world, had mild problems. They could manage at home. Only 1 or 5%, as in the world literature, had required PICU admission. We have two patients with COVID admitted for DKA. And the main problem they faced is access to insulin and accessories, because they have to come all the way from from Kasaragod, Kannur, Calicut, Wayanad, and Malappuram to Calicut to take the insulin and the CGM machines. But after a few weeks, the Social Security Mission had a novel idea. Why don't you start satellite clinics in each district? Actually, we started satellite clinics in Malappuram, Wayanad, Kannur, and Kasaragod, and we sent. Actually, we went together there in once and saw the patients attended there and distributed the insulin syringes and pen and the accessories to them. So after that, we could manage them. Another problem they faced is attendance to the diabetic clinic. At least face-to-face consultation was there only around 16% of children, and many resorted to phone calls, WhatsApp, SMS, and sometimes parents will come with the records and video consultation in a few. And another big problem what we have noticed is slight increase in BMI and some derangement in the diabetic control. That is, everybody has increased weight. And in the statistics in Mitai Clinic, Calicut, the total number of patients we could study was 227 children, and weight gain was seen in 140 children. And insulin requirement increased in 160 children, and HbA1c was increased in 82 children. The mean HbA1c before the start of COVID was 9.25. Then after 1 year, it has increased to 9.5. And invariably, the food consumption increased because they are not going to school and they are eating, and everybody's food consumption increased. And in the lipid profile also, LDH amount was increased in 20 children. So that is an indirect effect of COVID because of the lack of exercise, changes in the dietary habits, excess use of electronic media and sitting idly, increased snacking, restriction due to routine visit to physician. They are not coming to physician, and they are not going outside because of the restrictions. And I think these are the increased BMI and increased requirement may be the effect of that sedentary habits rather than the COVID. And the psychological problems, I think they have discussed in detail by Dr. Krishna Kumar. Here, our patients are also having some stress. One is the stress of increase in the complication if they get COVID. That was the real stress, but actually that didn't happen. Even the parents are under stress and worries about the supply of these medications. And the problem is social distancing. So we didn't evaluate, but many are having some anxiety, depression, and insomnia because of this COVID season. And at least 25% of the parents are having real stress, whether their child will get COVID, and if they get COVID, they will get some complication. That was the issue in the parents also. So these are some of the complications that I have observed in my Mitai Clinic patients, diabetic patients.
Thank you, Dr. Vijay. So if that is the situation in children with the diabetes, the similar type of weight gain will be there in all children, irrespective of the condition they are having, which we have to.
All our lean children has become chubby after 1 year of COVID situation. Okay. Everybody is very happy.
Now, to Dr. Krishnan, regarding children with nephrotic syndrome, whether you needed any modification in the treatment of nephrotic syndrome when they had COVID-19 infection, if some of these children developed infection while you are taking care of them, And what is your comment on the use of AC inhibitors and ARBs during COVID pandemic? Because this AC receptors have some role in COVID infection. And can COVID vaccination can cause nephrotic syndrome?
Okay, I will start with the treatment part. There is no consensus on the treatment part, but IAP has made recommendations. Some workers are against starting immunosuppressive agents in COVID-19 infected patients without achieving a viral control. I think that intact immune system is necessary to ensure a viral clearance. So these centers initiate high-dose steroids only after the patient becomes RT-PCR negative. There are several studies showing that high-dose steroid will not worsen COVID-19 infection, and even high-dose steroid will inhibit interleukin-6 production. And there is a meta-analysis in which critically ill patients with COVID infected, high-dose steroids reduced even the mortality, and it did not delay the virus clearance also. So in this line, some workers are in favor of starting early steroids in high dose. They feel that the risk of a severe and prolonged relapse due to a delayed treatment is more than the risk of immunosuppression during active COVID infection. So in this situation, that is, if they are starting high-dose steroids, it should be started with the consent of a parent. And even though these are evidences for and practices that there is no problem with the starting immunosuppressant during infection, one has to use steroids. One has to use the immunosuppressant agents and steroids very judiciously. And we can start steroids at a lower dose. So IAP recommends to start steroids at a lower dose during relapses. And once the child becomes negative, you can increase the dose. And those taking immunosuppressants already should be, the dose should be reduced to the lowest possible dose, which will maintain the patient in remission. During severe COVID diseases, especially if the child is having a sick COVID category C and all, the steroid dose should be reduced to the stress dose level. And those taking immunosuppressants like calcineurin inhibitors, mycophenolate, can be withheld for the time being. So that is the recommendation one can follow the treatment if the patient is having the disease. And regarding prevention, we can adopt some specific measures. One can conduct a regular teleconsultation with the patients and the families that will minimize the hospital visits. And the treating doctors, the nurses, and even counselors can conduct these teleconsultations. And during this consultation, we should be stressing upon the mental support and the general well-being of the patient so that all the anxieties and stresses can be relieved. And always we have to advise the parents to keep a stock of medicine for at least 1 month. That is also very important because there may be discontinuation of medication and other concern we may have. And regarding the ACE inhibitors and the angiotensin receptor blockers, we know that the COVID-19 virus binds to the ACE2 receptor that will facilitate the entry of the virus into the target cells. And if the patient is already taking ACE inhibitors, the virus can enter, so the risk of infection is theoretically there. But this matter is in debate. So regarding safety of these agents during pandemic, whether it is to be used or not is in debate, but there is no contraindication recommended for usage of these agents. That is, ACE inhibitors and ARB need not be started, need not be stopped during this pandemic. That is the current thing we can follow. And what was another question on?
You can continue. Please continue.
And any other one question regarding the
regarding any problem with COVID vaccination and
vaccination. Okay. So regarding vaccination can also there are reports of inducing first episode nephrotic syndrome and even relapses following a vaccination that has been reported, especially following Pfizer vaccination, first episode of nephrotic syndrome has been reported. And the pathophysiology is this COVID virus can stimulate the T lymphocyte, Th2 cells, which may lead to release of interleukins, which can stimulate the podocytes and induce proteinuria and all. So there is this vaccine, which any other vaccine, and there is a chance of inducing even first episode and or relapses in children with nephrotic syndrome. So the COVID virus can also induce relapse, as well as the vaccine can also induce relapse and the first episode of nephrotic syndrome. Okay. Regarding some experience with the COVID during the patient's experience with the cohort of my in our group, we have collected data from the patient during the teleconsultation, and most of the children in our cohort were taking steroids, other immunosuppressants, and few patients were even has used rituximab recently. There were around 400 patients in our cohort, and of these 12 children developed COVID infection during this pandemic. And out of these 12, 3 were asymptomatic, and 7 children were having category A symptom, and 2 were having category B symptom, and none had a severe disease. And 5 children, even after an exposure with a household contact, didn't develop any symptom. And we didn't test them, but even after exposure, they didn't show any symptom. And another interesting experience we have is a child with a steroid-resistant nephrotic syndrome. That patient was on high-dose steroid on cyclosporin and had received a course of rituximab also. He developed a COVID positive, but that was not having any symptom. And interestingly, that patient didn't develop any proteinuria also following this COVID positivity. And 2 children who developed category B symptom, went into relapse. But majority of children, that is 10 out of 12 children who were infected, didn't develop any relapse following the COVID infection. So from our experience, we can conclude that there is no increased risk of COVID-19 infection even after exposure, and severity is also less. And we have also just looked into the hospital data. After analyzing the hospital data before and after the declaration of the pandemic, and during 2019, that is before the pandemic, an average hospitalization of children with nephrotic syndrome were 22 per month in the wards. And during 2020, that is after the declaration of the pandemic, there were total 154 children hospitalization of children with relapses at with an average of 12.8. That is almost the admission rate has been reduced to its half. And PICU admission also has been reduced. During 2018, the annual PICU admission among children with nephrotic syndrome were 10. And during 2019, that is just before the pandemic, it was 11. But during 2020, that is after the occurrence of pandemic, the PICU admission is only 6. And during this year, that is in 2021, till this last month, no cases of children with nephrotic syndrome were admitted in the PICU. So that means the severity of the disease, hospitalization rate, and the infection rate, everything is found to be less in our group of children we were following up. And this was mainly, I think, the effective shielding done by the parents and family. I think this might have helped to reduce the incidence of COVID infection even after the exposure. Even if the family member is infected, many were not getting infection. They were very effectively following the preventive measures. That is one thing. And the teleconsultation we were doing regularly, and that also would have helped them. We were able to identify the relapses at an early stage. So even before the development of edema, we were able to treat them over the telephone and all. and many follow-up visits were reduced because we were able to counsel them and advise treatment also. The follow-up visit also reduced in this patient. That may also have reduced the risk of getting infection, especially from the hospitals or during the travel. So these are some of the experiences with in our children during this COVID pandemic.
Thank you.
And even we can, one case of first episode nephrotic syndrome also occurred in our group. One patient was diagnosed COVID positive during the admission for the first episode. Whether it was due to the disease or a presentation or it was a coincidence, we don't know. There are case reports of first episode nephrotic syndrome also. And there are evidences of direct effect of COVID virus on the kidneys. During many from China, they have done a post-mortem renal biopsy in COVID-infected patient, and they demonstrated COVID virus in the glomeruli. It has been identified. So they posted that there is a direct effect of COVID virus which can cause. That was the discussion there. That was a observation they made. They concluded that the COVID virus can directly act on the kidneys and can induce first episode nephrotic syndrome.
Anyway, these observations are really interesting. We know that many of the childhood infections have decreased during this pandemic period, and that could have contributed to the decrease in the number of relapses.
That's also right. So the respiratory infection will be less. That might have reduced the relapse rate also.
These findings are really interesting. And now to Dr. Geeta. So how the treatment and follow-up of children with primary immune deficiency were affected in your cohort? And are there any measures you had undertaken which you would prefer to continue even after the pandemic subsides?
Yeah, that's a very pertinent question, I think. Like in the initial phase of the lockdowns, there was absolutely no way that our patients could come to us for regular follow-up, on the one hand. But on the other hand, in a large subgroup of these patients, there was no need for them to come. Okay, so it was impossible, but at the same time, it was not necessary. So we were quite reassured at the beginning, and we tried to put in place certain strategies to make sure that we do not lose sight of our patients and lose them to follow up. And we didn't want them to get into trouble. Okay, so one thing we did, like Dr. Krishnan had earlier mentioned, was the virtual focus group discussions. We did these virtual focus group discussions mainly among 3 groups of patients. 1, among our children, a cohort with X-linked agammaglobulinemia. 2, among another cohort of those who already had a hematopoietic stem cell transplant for a primary immune deficiency disorder. And 3rd, among a group of children, a cohort of children with an autoinflammatory syndrome, that is a hyper IgD syndrome. So our experience was shared. Actually, we published our experience with managing the cohort of children with XLA in the NEJM Innovations in Care Delivery. So what was actually done with the help of the administration, our HOD, superintendent, everybody was involved. And we tried to set up linkages between our tertiary care center and primary healthcare centers and the other secondary hospitals. And these children used to come every 28 days to us for intravenous immunoglobulin, get admitted, stay for 24 hours, and leave the next morning. So what happened was that we were able to empower pediatricians in these peripheral hospitals so as they could be sure enough that they were able to administer IVIG locally. And they were also able to, a few hospitals, one Taluk headquarters hospital in Ponnani, they were able to procure it themselves. And for the others, we use the established network, a non-medical established network with the police, already mentioned by Dr. Ajit. And we were able to send these parcels containing IVIG directly to the homes of these patients. The police would either deliver it to their homes or to the nearest police station. And it was kept in the refrigerator. It was sent on ice, and they would administer it as quickly as possible in the peripheral hospital. So that was one great thing that happened. The next was how we were able to counsel these mothers. We felt that mothers would be unable to manage focus group discussion. They would be unable to manage the mobile phone and the technology, but that was absolutely not the case. They were very easily able to join the virtual focus group discussions, and they were able to share their problems, which mainly included the increased irritability of children, unable to go to school, unable to play outside. But there were some good points in the fact that they had started setting up kitchen gardens for themselves. And there were nice things like that, that also we were able to know. But what we found was they were not getting sick as regularly as they used to. And this was possibly, as was already mentioned, that they were cocooned in their homes. And whenever they went out, there was this adequate masking, distancing. But actually at that time, they hardly ever went out. And the next thing, so I must mention the services of Atulya, our junior research fellow, who helped really a lot in these setting up the virtual focus group discussions, and of Mrs. Kavita, who helped in the distribution of IVIG through the police system. And of course, our superintendent, Dr. C. Sri Kumar, and HOD, Dr. Ajit. And we were also able to do virtual genetic counseling. Actually, you were involved in this to a large extent. So this is something that we were not all that happy with, but that was the basic minimum we could do, because we had the genomic data available for a large number of children with XLA mainly. So we wanted to convey it to their families, so that we wanted to prevent affected individuals being born if we delayed this information to the families. So that also happened, although I wouldn't say it was the optimal way that we could do it. And another thing was, so the genetic counseling, these linkages with primary care, and the linkages with non-medical networks, and the follow-up of our cohort of children with the autoinflammatory syndrome, the hyper-IgD cohort. So we compared the parents' experience from April to December of 2020, that is the first wave, with their experience in the corresponding period of 2018 and 2019. And we were able to find a drastic reduction in the number of flares, the frequency of flares, that is the frequency and the number of flares, the duration of the flares, the number of OP visits and hospitalizations of these children. And we postulate that possibly a reduced number of infections was responsible for a lower rate of flares among these children. That is possibly because you have the products of prenylation in the cholesterol biosynthetic pathway, which actually stimulate Rho-A, which has an inhibitory effect on IL-1 beta formation. So because of the reduced number of infections, there were reduced number of flares and reduced cytokine release and all these associated things. So all in all, what I would like to say is that the WHO had said that we should try as much as we can to change this unfortunate pandemic into an opportunity, so that we set up new processes, new technologies, new models of care, which can be continued even beyond the pandemic. And I'm quite happy to say that we have possibly done so, and it's been a great learning experience. Thanks.
Thank you, Dr. Geeta. A child with Pompe disease getting enzyme replacement therapy, we could provide the enzyme to the district hospital. They need not have to visit there. And many a time visiting a hospital is sometimes dangerous also, especially children like you are taking care of. So, okay. So in future also, I think we should ask them to visit hospital only if it is needed.
Exactly.
And crowd in our society is another problem. Okay, now to Dr. Sindhu. See, many rheumatological problems are said to be due to certain viral infections and all. So now, within a short span of time, a very large number of children have developed this particular infection, COVID infection. So do you think there is going to be an increased incidence of rheumatologic problems in the coming months? What is your take on that? And also, what is your suggestion regarding vaccination in children with immunosuppressives?
Even before, several viral pandemic have resulted in increased incidence of rheumatic conditions. We all know that following our chikungunya and all, there was a relative increase in rheumatological condition. And usually many of these autoimmune conditions are precipitated by this several viral infection. So anyway, we have to expect. And all of you are seeing it. Actually, the MIS-C is actually a post-COVID phenomenon. There is some immune mediated phenomenon. So we should expect, but for the time being, I think there is no increase we have seen. We have passed over more than 1.5 years. We had actually only one case of systemic JA. That child had a COVID infection. That's 4 months back. Child had recurrent fever and finally diagnosed as surgery. Other than that, we didn't have a particular, we cannot say it is particularly related to this COVID. So there's a purpose that in this COVID infection, there may be a transient immunosuppression, and there may be this self-regulations that there's a self-tolerance mechanism that is lost during this period. And after that, we can have there is a dysregulated activation that may result in increased autoimmune disease. So we have to look forward for there may be a rising, but our experience in the last few, the last months, last 1.5 years, we don't have much things to say, but there are some reported evidence of several autoimmune conditions like autoimmune cytopenias like thrombocytopenia and other autoimmune conditions, GBS, all were related to this COVID. But as there is not definite numbers at the present scenario, but we have to look forward it. And vaccination, we have to consider these children as a priority group when we are starting immunization for children. These children are immunosuppressed, and also they are the priority group. And there's a theoretical risk of disease flare following immunization that should also be considered. But most of the recommendation for adults, they recommend the vaccines for all these children. And also I think that there is some, because this immune response may be blunted due to this our disease modifying drugs. So they recommend a period of 1 to 2 weeks discontinuation of drugs. For example, methotrexate, MMF, etc. to be stopped for 1 week following this vaccination, and then to restart if the child is well controlled.
Okay, thank you, Sindhu. So it is very heartening to see that despite the pandemic, the management of children with chronic problems could be done without much issues. And I would like to congratulate the entire department, and especially Dr. Ajit being the head of the department for achieving this great goal. And this we have experienced previously also during Nipah. All these the follow-up, everything collapsed. Now for the last 1.5 years, this pandemic, and we can expect further waves or new diseases like this. So one last question to Dr. Ajit. So learning from this, do you have any plans in such future issues?
Actually, it's a change which is very, very rapid, which we are seeing in many aspects, not only in health, the way we deliver the health system, health to our children. So I think from this experience of this pandemic, many patients can be treated online or maybe managed online with the help of pediatricians or doctors at the periphery. That is, so what we are planning is to continue our system of online consultations. And we had already started our, through the government scheme, Sanjeevani, e-Sanjeevani scheme, we had been active for some time. And also we are planning to have a audiovisual room with, for audiovisual as well as a conferencing room, which are planning, which will be will be establishing within 1 or 2 months, so that our mode of treatment, which we are using now, like what Dr. Krishnan and Dr. Geeta has said, a group consultations and all this will continue, so that those who are immunocompromised and those who are far away can have the benefit of this. And also, even our learning has also improved all this, as we have seen in this great discussion started by moderator Dr. Mohandas. So learning, even now we are learning that those who have those who are immunocompromised or those who are having chronic illnesses like JIA or nephrotic syndrome, they don't have serious issues even when they are having COVID. So this is a great. So my request to Dr. Mohandas is that we have to publish this data as a combined.
Definitely.
Yeah, we have to publish this data, and we have a great experience of 1.5 years, which can be published as not only collectively but also individually. So I think I take this opportunity to thank all my faculty here, not only on this panel discussion, as well as all the faculty in the department who had stood behind me during this pandemic.
One thing, Mohandas, one point I would like to add. We
Yes.
are able to manage our children in liaison with the medical officers in the periphery, PHCs, CHCs, and district hospital, and many pediatricians also. Even difficult cases, we were able to manage over the phone. They were asking us advice. Even they were admitting our patients, and they were effectively managed. We'd like to complement that. That is also very improved outcome in this children. That's another point we would like to add.
Yes, sir. That even in rheumatology patients, we were able to give this drugs like tocilizumab from the periphery. Even in Kasaragod, Palakkad, Manandawadi, all the hospitals there, they were giving this drug. Previously, they had to come to travel this much distance to get the drugs. Now they are not coming to us. They are managed by the local pediatricians from there itself.
Similarly, children with osteogenesis imperfecta, they used to come to IMCH for getting this bisphosphonates. Now they are taking it from their local hospitals.
Dr. Riaz, I wants to have a comment. Can he, Dr. Mohandas, can he?
Yes, definitely.
Dr. Riaz, please unmute yourself, Dr. Riaz. Please unmute. Please unmute, Riaz.
Actually, I'm happy to be a part of all this. Actually, this COVID had given us many opportunities. Here at Trivandrum also, we were able to have a hand-in-hand relation with the peripheral institutions. So for districts like Kollam, Pathanamthitta, we were able to give medicines, especially of the type 1 diabetes children. And also many of our patients who were coming regularly to the clinic, we were advising to just get the blood checked for this TSH, T4, and inform through telephone. So this all tells us that many consultations we can avoid actually. This the scope for telecom consultations, reducing the crowd in the hospital, and thereby preventing the not only infection, it actually helps them economically also. Unnecessary travel to the hospital and delivering the drugs and consumables to their doorsteps. I think we should take forward these experiences post-COVID eras.
Thank you, Dr. Riaz. Purushottam sir, any comment to make? Please unmute, sir.
First of all, that is a wonderful CMA all through I heard and I was enjoying. And about the last part, I would like to comment about the public health importance of this session, of the last session, panel discussion. There was a different type of a group of patients. The difference which we noticed were a little longer duration of the spreading of the virus can occur in all the 5 categories mentioned. How long is the viable virus lasting? Will it be same 8 days, or should we consider a little more, 20 days or so? The PCR positivity alone we need not worry, but a little longer duration of viable virus shed is possible. But we are talking now Zika, 30 days at least, 3 months, 6 months, it can remain in the cement. Like that, immunocompromised cases can serve as a source of infection to the other people. So what Ajit told is a measure, we should be considering this as a source of infection to the others in the family. So that is a public health measure which specifically mentioned about this category of contacts. And thank you all for this thing. And Dr. Ashraf Amai and Dr. Ajit, one thing is, before you submit a recommendation based on this CME, get a few feedback from others also, because I need to include a few other things like school starting, the immunization and all. We need to have a consensus before we submit it to the minister. So I think there will be a favorable response from the minister for the improvement, the lab diagnosis, everything. I think they will hear from the conference. So well-planned report may be given. So thank you all.
Thank you, sir. Ajit, that suggestion is well taken, isn't it? Yeah, definitely. Okay, Krishnan.
Regarding the longer period of viral shedding, longer the virus shedding occurs, the more chance of getting mutant strain also. That's also another problem. If the immunosuppressed patient will be shedding the virus longer, so more chance of variants, mutant variants, more virulent strains may emerge. That's also another risk.
So the consensus from this panel discussion is the COVID-19 directly has not caused a significant problem in children with various comorbidities or chronic illnesses, but the circumstances resulting out of the pandemic has caused various issues, and the system has tried to overcome all these issues successfully by various measures which has taken, and many of these measures we can continue even when the pandemic is over. So with these comments, I am handing over the mic to the organizers. Thank you all the panelists and all the audience.
Thank you, Mohandas. So yes, to organizing team there. Shahana.
Yes, sir.
Yeah.
So we have come to the conclusion of our conference. We would like to thank all the delegates and faculties for making this a successful program. Thank you one and all.
Sindhu is our co-chair, co-organizing secretary. Sindhu, your vote of thanks for that. Unmute yourself. Unmute.
It is almost only 40 participants, delegates are left now. And so it is our concluding remarks. I think it was very happy with this that we could organize it successfully. Thanks all the delegates, all the speakers, and a special thanks to our technical team, because in a virtual platform, it is very difficult to conduct. So thank you all.
So, thank you very much. So have a good day, and let me conclude. So thank you, sir. Thank you, everyone.
Thank you.
4 മണിക്ക് 5 മിനിറ്റും കൂടിയേ ഉള്ളൂ.
ശരി, ഓക്കെ. ഹാവ് എ ഗ്രേറ്റ് ഡേ. താങ്ക് യു.
എച്ചോട് എനിക്കൊരു പണി ഏൽപ്പിച്ചിട്ടുണ്ട്. അത് ഇനിയും കഴിയണ 1 മണിക്കൂറും കൂടി എടുക്കും.
ഏത് റിപ്പോർട്ടാണ്?
കുറിപ്പ് എഴുതാൻ.
അതൊന്ന് ഷെയർ ചെയ്യണേ, എഴുതി കഴിഞ്ഞാല്.
ഫസ്റ്റ് പാർട്ടി ഷെയർ ചെയ്യാം. ഇതിന്റെ ഇടയിൽ മൊബൈലിൽ ടൈപ്പ് ചെയ്യായിരുന്നു. മോഹൻദാസിന്റെ ടെക്നിക്ക് ഇപ്പൊ ഞാനും പഠിച്ചു.
ഓക്കെ,
ഹിന്ദുവിന് ഞാൻ കൊടുക്കണ്ട് കേട്ടോ.
മോഹൻദാസ് കഴിഞ്ഞോ?
കഴിഞ്ഞു.
പിന്നെ എന്നോട്